Recording in progress.
ChatGPT.
Right. Hello, everyone. Good morning. Beautiful morning to everyone, with our esteemed guests present here and all our participants online. Um, it's the one of the much anticipated AMSA Medical Education Conference 2026, and I hope we're all as excited as I am. I am Blessed Olaomo. I'm a fifth year medical student at College of Medicine, University of Ibadan, and currently I serve as the administrator of the FAMSA Education Students Associations. So is the body representing the interest of medical students both continentally and globally. And our vision is simple: is to equip medical students to become people who are not just aware of global health issues, but also able to actively contribute to solving some of these issues. So today's session, I'm really excited for it. Is very much in line with our vision. So we're looking at how we can better equip our medical students to become people who can be contributors, solutions in real healthcare systems, and also can also going to be looking at the potential impact that they can in contributing to solving global health issues. So I'm really excited, and I hope you're all as excited as I am. Before we delve into the session for this morning, I'd just like to welcome my chief, Mr. Dimeji Olawi, for a brief welcome address. You're welcome.
Morning, everyone. I'm Dimeji Olawiye. I'm the advisor to the Farmside Headquarters Board. So, and it's my pleasure, and I welcome everyone to be here today. So, today is the first day of the AMSA 2026 conference, and AMSA stands for the. So, AMSA is a senior association to FAMSA. FAMSA is the Federation of African Medical Students Association. And through our partnership with AMSA, we're able to secure this parallel session, which is themed um, Training the Future, Strengthening the Present, Medical Students as Catalysts for Health Systems Training in Africa. So why some will be wondering what is FAMSA? FAMSA stands for the Federation of African Medical Students Association. It's the continental body that represents the interest of all African medical students, both at the continental level, the international health landscape. So for this parallel session, we've invited seasoned speakers panelists all across the concerned levels. We have students, we have medical graduates, we have professors, we have doctors, all on our panel sessions list. Also, we've invited some of our partners, including Blue Cloud X. We have them on the call, and also we invited Futurize. So we invited them to come and give their perspectives on the team and to also share the available opportunities with medical students. So I hope we will all sit tight and participate as much as possible by giving our contributions and asking relevant questions. Thank you very much, everyone. I hereby declare this panel session open. Thank you.
Good morning, everyone. I hope we're all delighted to be here with you all today. And thank you all for joining. My name is Sekina Adegbite. I'm a fifth-year medical student at the College of Medicine, University of Ibadan, and also a member of the FAMSA Headquarters Board. So before we delve into today's panel session, I'd like to introduce one of FAMSA's official partners, Blue Cloud X. Blue Cloud X is a global connectivity and interoperable networking platform that provides global communication and also a way to streamline everyday's business. With us here today is Mr. Al Pacino, the CEO of Blue Cloud X, and also a United States Army veteran and senior executive with over 35 years in healthcare and clinical research. He's also actively involved as an innovator in the industry. As a 16-year can give back in making a difference in the industry, Mr. Al Pacino, along with patients and patient survivors, co-founded the innovative Blue Cloud X network that is now saving healthcare and clinical research millions of dollars. Current base includes over 2 million healthcare professionals, 150 sponsors, 45 CROs, and over 200,000 in healthcare professionals and clinical research sites. Is here today to introduce us into the field of clinical research and also talk about emerging opportunities for medical students. Please join me in welcoming Mr. Al Pacino. Thank you.
Thank you very much. Thank you for the FAMSA leadership, and thank you for the opportunity to speak with you. Specifically, I have a passion for speaking in front of students about opportunities that wouldn't come often because of access. I'm going to go ahead and share my desktop real quick. Tell me when you see my screen on your end. Can everybody see my screen? Yes? Okay, good. So a real quick background about who I am. Like I said, my colleague said, I've been in healthcare for over 40 years. I've also been in clinical research for 35 years. Clinical research is the fastest growing lives and health sciences industry and is given opportunities to young physicians, young nurses to participate in clinical trials. So today, I'm so glad you guys are here as students because otherwise you wouldn't find opportunities, you wouldn't have access to opportunities that you're going to learn about today. Okay, so in healthcare, the reason why you go to school, first of all, is and you go into medical school and you're spending money in medical schools is because you hopefully gonna position yourself to go into the healthcare industry because of altruism or because you want to have help patients or simply because you want to increase the opportunity of earning more for your families and for your wives and husbands and so on. So today, in the next 5 minutes, I'm going to give you a synopsis on the opportunities to be able to earn after you graduate from medical school up to so, whenever you graduate from medical school, you're going to earn a certain amount of money. However, if you get into clinical research, you have the opportunity to earn 4, 5, 6 times more than you would as a basic health. So, and this is parallel to the initiatives that we have all over Africa. So we are building modern infrastructures to build capacity in Africa, including training and education in the form of scholarships, which we have given to FAMSA, and you'll see it at the end of this presentation. And as you can see, this is the world outside of Africa. The healthcare is life and health sciences ecosystem, and clinical research is only 10%. So with new laws and regulations all over the world, in the United States, Germany, France, China, even China, these worlds of healthcare and medical research are merging because we need to make sure that we include patients of all races, religions, socioeconomic status, political affiliations to participate in clinical trial. The unfortunate part of life is that 90% of the patients are in healthcare and they don't have any access to clinical research as a care option. So once you graduate from medical school or nursing school or technical school, you will have the beginning opportunity as of today to get involved into the careers that are in clinical research, all the way from entry level, which is 0 to 2 years, clinical trial assistants, clinical research coordinators, research assistants, regulatory associates for medical research. If you have a degree in medical school, then those healthcare professionals in research are called principal investigators. Principal investigator, you'll have an opportunity to position yourself after you graduate from school from 4 to 5, 6 times more revenue because the research industry is more expensive than the healthcare industry. And as time goes, get involved with clinical research associates, data managers, regulatory specialists. This is a whole career that you have an opportunity to get involved with once you graduate from medical school or nursing school. Unfortunately, medical schools teach this. They don't teach that there is an opportunity to add an additional career on top of what you've already learned in medical schools. All over the world, this is an initiative to get healthcare professionals, physicians, involved into clinical research to where you can increase the amount of opportunity that you to earn more by adding clinical research into your portfolio as a professional. This is actually a screenshot of the different careers in Germany, in France, in the United States. And you, as a healthcare professional, especially as a principal investigator doctor, you're going to be able to earn, as I keep saying, more than 4 times the amount of money that you would earn if you just a physician taking care of patients in the healthcare industry. So, as you can see on the screen, medical research is very expensive, very expensive. Clinical trials is a phase one, two, three, and four sequence of events that happen over the over 10-year period. And whenever you're treating patients, the sponsors, which are pharmaceutical companies, medical device companies, are willing to pay 4 to 6 times the amount than you would also earn if you were only doing healthcare. You can actually find this information on Google or AI, find out how much does the pharmaceutical companies pay for patients and for clinical trials or medicine, where the increase to the opportunity to earn 4 times more than if you just treating patients for healthcare. So what Blue Cloud X does is we all over the world over the past 20 years, we train and certified healthcare professionals, physicians who are called PIs in research, nurses who are called CRAs or study coordinators, all over the world with patient. We train them on how to screen patients in stroke, cardiovascular, neurovascular, traumatic brain injuries, infectious disease, and mental health. These training and certifications are not taught in medical schools or nursing schools. We do this all over the world, and we provide this training and certifications not only for healthcare, for medical research. These scales, the assessment instruments that you see on the screen, are owned by governments, universities, all over the world. We will provide those as in the form of scholarships, and each scholarship is worth $2,000 free of charge to FAMSA members. And so that way you can position yourself not only to use the scales in healthcare, but then you can immediately are able to position yourself to tell the sponsors, pharma medical device companies, that you are trained and certified on these types of scales. There's approximately a dozen. These are the ones that are used the most. Another part of the scholarship, which is worth $2,000, that are given through the FAMSA organization, is what clinical research is all about. When we go to medical school or nursing school, we don't know anything about this. Good clinical practices, informed consent in clinical research, safety in clinical research, and many other training and certifications on what clinical research is all about. We don't learn this in medical schools. We will provide them to you through FAMSA as an association, free of charge to medical students. Excuse me. Well, this is actually the screen. If you have a phone, go ahead and use this QR code, and you will see that you'll have access to a website that is the FAMSA Blue Cloud X system. To do is register, and you will be able to have access to all this training and educational activities focused on both healthcare, the scales, and clinical research, both. This training and certifications are not, you're not going to find this in any medical schools in Africa. So hopefully you're able to do this QR code on your phone, and that's the FAMSA website. If you have any questions, please contact the FAMSA leadership, and they will guide you directly into their own Blue Cloud system website. So that way you can have access free of charge through scholarships. So that way you can position yourself to not only do well for patients, but ultimately improve your potential of earning more revenue than you would as if you just have a degree, a medical school. Does anybody have any questions? No questions? Everybody's on mute. I think
Thank you
that's
very
my
much. Thank you
my
very much,
presentation
Al.
for today, and feel free to ask how to access those scholarships to the FAMSA leadership
Yes, thank you
after
very
this
much,
meeting
Al.
today.
Well, actually,
Also,
questions.
I would like to invite every African medical schools to talk to us so that what you can include this this curricula into their everyday uh, into into their curricula at the medical schools. This will move Africa and into providing opportunities to your medical students. So I urge you to get in touch with FAMSA.
Yes, thank you so much, Al,
Thank you
for
very
taking
much.
out the time. I know it's 2 a.m. in Texas. We really appreciate the sacrifice. So we have a question from one of our guests here, Professor.
Much for the lecture. Uh, the lecturer has made it so rosy. The issue of clinical research made it so rosy. But I know that there are lots of downside to that, which he has not mentioned. So I would like to give him an opportunity to mention some of the downside to the pathway of clinical research in medicine.
Thank you very much. Mr. Howell, did you get the question? Do you get the question, Mr. Howell?
One of the questions that is in the chat box is medical laboratory science included? No. This is for clinical trials, clinical research specifically focused on patients.
Thank you very much,
The
Mr.
NIH
Howell.
stroke scale, if a patient has a stroke, you got to understand how to assess and diagnose a patient who has a stroke. All those all those trainings are part of the scholarship. If a patient has a heart attack, you got to understand, you got to use the Rankin scale. You're going to be able to train and certify on how to use properly use the Rankin scale, which comes from the University of Glasgow in the UK.
Thank you very much. Can you please confirm if you can hear me? Can you hear me?
Any others?
Can you hear me?
Explain to me what the downside of clinical research is about. Not sure exactly what you're asking. Downside of clinical research. There's no downside to clinical research because you're offering clinical research as a care option to the latest therapies, to the latest diagnostics, and to the latest medical devices. And this is happening all over the world, and Africa has been left behind.
I'm not sure if you can hear me, but we have people asking questions in person. Kindly confirm if you can hear me.
Any other questions?
Can you speak to your
Can you hear me? We have people asking questions in person here. I'm not sure you are getting the questions.
Continue to type your questions in the chat box, please. Okay. If there are no more questions, I just typed in the address that you can click on the chat box so you can access those scholarships. Just simply register and the system will
Good morning.
release those courses to you in the form of scholarships.
Hello, Al. Good morning.
Good morning.
Can you hear me? All right, so kindly stay on the call for some minutes. We have some questions for your in-person.
Okay. I'm not sure if anybody's asking any questions, but I don't hear anybody asking questions.
All right, we are coming.
We're trying to not have technical issues.
Can you hear us now, Mr. Ham?
We are having feedback. So something needs to be obvious. With it, like switch yourself. Okay. Okay. Don't use him. Use yourself.
This is specifically for medical students. Yes, I showed you the QR code that you could scan, and I also typed in the address where you can go to the FAMSA Blue Cloud system and go there to register. It's on the chat box.
Hello, Hal.
Can you hear us?
Can you hear us, Hal?
Can you hear us?
Hello, Hal.
Yes.
Yes, so we have some questions in person. So I think there's some technical issues. I don't know if it's from your end. Hello, can you hear me? You can't. You can't hear me.
Okay, there's for beginners interested in clinical research, what practical steps can help us get started, especially in Africa where opportunities may seem limited? That's part of the scholarships. Just simply go register, and there's tons of courses that will answer all those questions. Those are courses for clinical research. Just like you're going to school today, why are you going to medical school? So that you can have an opportunity to do better in the future. We're providing you the opportunity to take training and certification for clinical research so you can have an opportunity, a better opportunity to earn more in the Africa has been left behind. Hopefully that answers your question, Emmanuel. Any other questions? Hi, Al. Could you share your contact information? Find me on LinkedIn if you guys have a LinkedIn place, it's Al O. Pacino. Search for me on LinkedIn and you can connect with me if you have any questions at all.
Ma'am, can't hear us.
Issues of clinical trials in low and middle income countries. And what is the purpose actually in clinical trials, I think for medical students or for clinicians in general? Number one, knowledge, which is how to do critical appraisal as whether there's a new drug that's coming, tried only in a whether that drug is,
our patients are eligible if they were in those clinical trials in terms of performance status and all the eligibility criteria, and then how to do critical appraisal. I think these are very important medical students and for clinicians. But at the same time, there are other ethical issues related to, even if we put patients on clinical trial, will we have access to those medications if the clinical trial shows that they actually can help patients? So I think in these types of courses that we avail to students from Africa, I think we need to also mention all the other caveats and all the ethical implications of clinical trials. It's a great career, but sometimes it's not always possible to engage in clinical trials. There is other aspects such as health services research and others that may actually also be avenues.
So the answer to that, there are courses specific to ethics and clinical research that are part of the scholarship. There are approximately 10 courses that are focused on specific areas of clinical research. Ethics and social responsibility is one of them. The idea of what is happening around the world is clinical research is being offered in hospitals and clinics all over the world as a type of care option to where the patients are able to get paid for their physicals if they get involved in clinical research, have access to clinical research as an option. And this is a movement that is happening all over the world. And not only in the United States, but China, everywhere. Africa is positioned, you position yourselves to offer clinical research as a care option so that the patients can get the best care possible and the latest cures. But you cannot do it unless you properly understand what clinical research is all about, ethics and social responsibility, and all the skills. They're not only used for medical research, but they're standard in healthcare. The NIH stroke scale, you use it for healthcare as well as clinical research. The Rankin scale, how to assess patients with a heart attack, research, and you also do it for healthcare. So when you take this core clinical scales or scientific instruments, you're training and certifying not only for clinical research, but you do it for healthcare as well. Those are the latest and most modern patient assessment instruments that are used all over the world, but they're not used in Africa. We're giving you the opportunity to get involved with the latest patient assessment instruments for healthcare, which are then also used for clinical research. So if you don't want to do clinical trials, at least you modernize the way you assess patients in healthcare. Any other questions?
Thank you very much. I hope that answer your questions, ma'am. I hope that answer your question. Yes, thank you so much, ma'am.
Thank you.
All right, so I think we have a few other questions in the chat box. I think
Okay, so there's a question here on the chat box. Again, you take this courses because all the questions that you guys are asking are part of this courses. How long does it take to the market? It depends what it is. Sometimes it takes a couple of years, sometimes it takes 20 years. Depends how safe it is. All these questions that you're putting on the chat box are answered in those courses that are.
right, thank you very much, Mr. Al Pacino. So I think email in the chat box. We really appreciate your time. Thank you so much, sir. So we're moving on quickly to the panel session. We have distinguished speakers, esteemed veterans amongst us. So, like Mr. Dimitri rightly said, the theme for this panel session is training the future, strengthening the present, medical students as catalysts for health system strengthening in Africa. So we have 4 amazing panelists amongst us, and we'll be co-hosting. I won't be the only moderator here. This session will be co-hosted by Mr. Akitudi. Can please come forward? So let me go quickly to read the citation of our speakers. So we have Mr. Victor Femi Lawal. Mr. Victor Femi Lawal is a medical student, a final year medical student, global researcher, youth leader, and health advocate dedicated to improving health outcomes through research, innovation, and policy. He has led various high impact South Africa, and globally, including adolescent health research as a project editor with Polyedra Cambridge and an international global health think tank, and evidence-based interventions. He's the co-founder and director and policy at the Mafia Initiative with over 20 peer-reviewed scientific publications. His work has been published in various high-impact journals, including The Lancet, and he has presented at various international conferences, including the American Association of Thoracic Surgeons, the annual meeting, the 25th International AIDS Conference in Munich, the RSTMH annual meeting in London, and the 12th European and Developing Countries Clinical Trials Partnerships. He also served as vice president of FAMSA in the 2023-2024 tenure, where he led impactful initiative for over 100,000 medical students across the continent and pioneered digital health innovations in the organization, co-designing the African Youth in Digital Health Network with the Africa CDC and the German Society for International Cooperation. He's passionate about capacity building. He has trained 1,000 plus early career researchers globally, and is committed to driving progress in digital health, sexual and reproductive health, and NCDs through research and leadership. Currently, he serves as research lead in the Africa CDC Youth Network in Digital Health Network. Kindly join me in welcoming Mr. Victor Femilawal. Mr. Victor Femilawal, I believe he's on the call. So our second speaker will be Dr. Abdulhamid Babatunde. Dr. Abdulhamid Babatunde is a medical doctor, a digital health researcher with a passion for increasing access to healthcare in underserved communities. He co-founded MyBelle, a social enterprise that leverages digital technology to reduce maternal and childhood mortality. His organization has reached over 9,000 women in Nigeria. As a researcher, he publishes scholarly articles in peer-reviewed journals on digital health, HIV, and other public health issues. Collaborating with researchers from University of North Carolina, London School of Health and Tropical Medicine, Nigerian Institute of Medical Research, etc. He's also a past vice president of the Federation of African Medical Student Association, FAMSA, where he coordinated activities of medical students across 250 medical schools in Africa. Dr. Abdulhamid is a fellow of Being Native and Youth in Digital Health Network Bootcamp. His work has been recognized globally as a One Young World Ambassador and a recipient of the UK Diana Award. He has worked as an independent consultant for international organizations such as UNICEF and WHO-TDR, and currently serves as a research consultant for NIH at the University of North Carolina at Chapel Hill. Kindly also join me in welcoming Dr. Abdulhamid Babatunde. So, thank you very much, sir. So our first speaker is Professor Rufus Akinyemi. Professor Rufus Akinyemi is winner of the 2023 Gold Medal Prize of the Nigerian Academy of Science. He's a professor of geriatric neurology and translational neuroscience and the director of the Biomedical Research Center, College of Medicine, University of Ibadan, Nigeria. He holds a PhD from Newcastle University in the UK and an MSc in cell biology and genetics and a Bachelor of Medicine and Surgery from the University. Fellowships of the National Postgraduate Medical College of Nigeria and the Global Brain Health Institute. He was recently elected into the fellowship of both the Nigerian Academy of Science and the Academy of Medicine Specialties of Nigeria. His research focuses on vascular and degenerative brain disorders using a translational bedside community framework. He spearheaded the establishment of the African Stroke Organization and the African Dementia Consortium and hosted the first African Leaders Summit in 2022. He has co-led the largest study of stroke in Africa, the NIH-funded SIRENE SIBS genomic study in the last decade, and currently leads the current largest study of dementia in Africa, the NIA-funded READ ADSP study. Professor Rufus Akinyemi has been elected Fellow of African Academy of Science based on his contribution to deepening understanding of the genetic epidemiology of stroke among indigenous Africans and global populations, and for enhancing ancestry-specific prediction of and unmasking novel targets for prevention and treatment. His excellent translational research on stroke and dementia led to the discovery of plasmatodendrosis as a critical neuroinflammatory substrate of vascular cognitive impairment and dementia with therapeutic implications. He currently leads the largest study of dementia in Africa at unraveling the genetic architecture of dementia in African ancestry populations. He is a pioneer in neurobanking in Africa and recently established the Ibadan Brain Bank, also a well-published writer in peer-reviewed journals with over 250 publications, an H-index of 68, and over 80,000 citations. He's married to Dulupe, an excellent biomedical scientist, and the union is blessed with 4 billion children. Kindly join me in welcoming Professor Rufus Akinyemi. Lastly, we also have Professor Alfred Yosin, the Provost of the University of Ghana College of Medical Sciences. He has over 20 years of medical practice and research experience. He's an alumnus of the University of Ghana Medical School, the London School of Economics, Medical Science, and the London School of Hygiene and Tropical Medicine, where he is an honorary associate professor. He's a fellow of the West African College of Physicians and a fellow of the Ghana College of Physicians. He's the principal investigator for WHO World Health Survey Plus in Ghana and chairman of the Ghana Non-Communicable Diseases Injury Prevention Poverty Commission, and a past vice president and chairman of the Ghana chapter of the West African College of Physicians. Professor Yosin is a physician, public health practitioner, academic researcher, and combines these skills to support, develop, and strengthen national and international health systems. He has worked as national and international consultant for many international organizations, the development of several national policy and strategy documents. He has many international collaborations and research grants that support resource mobilization, training, and mentoring of undergraduate and postgraduate students of the College of Health Sciences, University of Ghana. He has a decade of leadership roles in the university and is the immediate past dean of the University of Ghana Medical School and the current provost, College of Health Sciences, University of Ghana. Kindly join me once again in welcoming Professor Alfred Yosin. Thank you very much. Just to confirm, so our dear speakers, can you hear me? Professor, welcome, sir.
Right. Thank you very much.
It's a privilege to have you here, sir. Thank you so much for honoring our invitation, sir.
Right.
Yes, so Dr. Abdulhamid Babatindi, I can also see Dr. Abdulhamid Babatindi on the call. Thank you so much. Welcome, sir.
14.
Yes, thank you so much, sir. So let's get right into it quickly. So the theme once again is training the future, strengthening the present. African medical students as catalysts for strengthening health systems in Africa. So, but before we go right into the potential contributions of medical students in solving some of these health issues in Africa, like I said, the vision of AMSA is to students to be people who can identify global health problems and not just identify these problems, but also contribute to solving them. Before we go into the opportunities for students to contribute to solving our health problems, I would also like to direct this question to Professor Akinyemi, sir. What exactly do we mean when we say health systems? What are health systems? About something that is so vague, what does it mean, health systems?
Right. Thank you very much, moderator. I want to first of all start by thanking the organizers of this conference for the opportunity to be part of this session, to contribute to this discourse. Such a privilege. When we talk about health systems, we talk about systems that include services delivery. We also it also includes training of health professionals, medical students, dental students, and all the different subspecialties within the health professions, including public health. And of course, this also includes policy making, for delivery of health services across different parts of the world, and of course, Africa specifically in the context of this discourse. So it's an overarching, I would say, a network that guides the planning, delivery, and the organization of health services, so that the health of the common man can be enhanced, such as, as it's been popularized by WHO universal health coverage. Health, every person who is living has access to sound health care. Healthcare, covering all the different domains of healthcare delivery. So that'll be my brief introduction to health systems. And it's a network, and a very profound network indeed, that requires multiple inputs from different stakeholders, so that the common man on the streets can enjoy the best quality of life throughout the life course. So that'll be my very brief introduction to health systems. Thank you.
All right. Thank you very much, Professor Akemi, for that wonderful response to that question. Health system training medical students to deliver healthcare systems to people that are actually in need of it. So based on that wonderful definition, I would like to direct my next question to Professor Yosin. Professor Akemi has wonderfully explained what health systems are. What I'd like to know from your perspective, Professor Yosin, what are the gaps that are present in the Africa's current health systems?
Thank you very much. And again, thank you for the opportunity of being here. The health systems, as Professor said, is all the resources that come into play to provide essential care so that we prevent persons from getting sick in the first place. If they do get sick, then the system kicks in quickly to restore them to a reasonable level of health, both socially and economically. And if they develop complications, then the system should be able to deal with these complications quickly and again to restore them to a level of health so that they are economically productive. And if it progresses even to a point that the system cannot handle, then we bring in what we call palliative care, we bring in geriatric care and others to, even at the point where the system really cannot save them, we still provide them with some reasonable level of satisfaction, even if they have to depart. So we have human resources, the health workforce, as one of the health system building blocks, as indicated by WHO. And we all know Africa, the challenges with health workforce. We are not able to train adequate numbers. And when we train the numbers, we are not able to distribute them equitably. And also, upon this, we have a lot of external migration of trained, qualified health workforce leaving the African continent to other areas, especially in the north. The next is finance for healthcare. Universal health coverage is based on making the health system financially sustainable so that finance is not a barrier to healthcare by the population. And how do you do this? Many African countries, in fact, face severe challenges. We are part of the countries that contribute less than 5% of the global expenditure on health, but suffer more than half of the global burden of disease. So that in itself tells you where the challenges in Africa are. And our systems, even if we are able to develop national health insurance as it were, because ours is social types of insurance, it has its own inherent challenges. So health financing is key. Service delivery, yes, if we don't have all the resources, including human expertise and numbers and equitable distribution of facilities across the country, aside the urban areas and the city, you tend to have challenges with delivery of health services. Again, the supplies of vaccines, medicines, we also during the COVID epidemic, how Africa was strained, because we are not producing the essential medicines and essential product that we require for delivery of healthcare. So that in itself is another major challenge, and systems in Africa will need to really look at the essentials of this and be able to develop essential medicines and essential vaccines that may be required for our population. So there are other key elements of the health system, but these really are the elements that constrain the African health system, as it were, currently.
Thank you so much, Professor Yosin. Thank you so much. I think I was seen some of the problems that are key problems in our health system. So I just wanted to ask, as a follow-up on that, Professor Yosin, what are some of the efforts that are in place at the moment to mitigate some of these challenges in our health system?
So we'll take health workforce. I think many African countries are going into training of specialists. We are strengthening our postgraduate medical, nursing, pharmaceutical, and allied health institutions, such that we don't only have generalists, but we have specialists and even subspecialists training to take care of the complications of non-communicable diseases as it's rising in Africa, and also of the infectious diseases as well. So most countries are going into specialist training, which is good. We are also increasing the number of undergraduate trainees, medical student, nursing, dental, all that. However, as I continue to say, this effort, even when it is at the national level, when we have bilateral partners in Europe, the Americas, Canada, and Australia and others, these our health workforce continue to migrate in their numbers. So it is really a strain on the health training budget of Africa. You train a lot of these. Now is becoming critical, especially for critical care nurses, anesthetists, those who are required for the very essential delivery of our systems are migrating. And therefore, we need to put in measures, as it were, something to attract them or something to improve the training. And there is need for a continental voice engagement of our partners, so that if you are benefiting from our health workforce, what it is that you need to contribute to the training of this health workforce in Africa. And I think this should be at the level of the African Union, at the level of UN and all that. Our president just in Ghana just pushing for the reparation slave trade to be declared as criminal at the UN. I believe African government should also table some of these health workforce migration, both ethical and unethical, by our colleagues in the more developed countries, so that we can try to stem the tide. For our own effort, it will be difficult because people will always migrate where they want to practice, and you cannot legislate or constrain them. Again, service delivery, yes, we need to improve the package of services that is delivered even at the lowest level of the healthcare system. It shouldn't be only to the population in the urban areas. Everybody everywhere, as is in the universal health coverage, must get a reasonable level of health care that is commensurate with their needs. That is equity. And we need to ensure as government, and this is being done, we are trying to strengthen the lower levels of our health system in most African countries. We need to do more, much as we are contributing and improving super specialist care in our teaching hospitals, in our tertiary facilities. We need to look at primary health care and how to finance this primary health care. Example, in my country, we have been trying to introduce what we call free primary health care, which we think is essential if we are health coverage. Immunization, nutrition services, family planning service, all this we depend heavily on partners and donors, development partners. Their contribution to the whole entire health budget of Africa has been reduced. Projection is that this is going to reduce with the geopolitical happenings, and therefore African government must come to the table and see how best we can support the essential element of our health systems. And we are trying to do it bits and pieces in different countries, but I think there should be a concerted effort again, as indicated, led by the African Union. We've said this before, spend 15% of your GDP on health. This was in Abuja 2001. Many countries are still unable to achieve this 15%. And therefore, we really probably need another governmental summit to ensure and encourage African government to spend as much as possible within their means on health, and see health as an investment, not just as an expenditure.
Thank you so very much, Professor Yosin, for such insightful comments. I think most of the solutions that you mentioned, I like that you mentioned that the government has a role to play. We have international organizations such as the African Union and the UN have a role to play. institutions as well. You talked about medical training, specialist training. So the institutions also have a role to play. So I want to direct this next question to Professor. So when you were defining health systems, you mentioned some of the contributors, of course, the government, the institutions, medical institutions. These are key contributors in the health systems. But something that you also mentioned, if you go a bit, let's say down the hierarchy, is medical students. You mentioned medical students. So medical students are a part of the health. So do you think that medical students, apart from the government, apart from institutions, do you think medical students can also play a role in also solving some of these problems that we have in the African health system, maybe through innovation? I know that digital health is also an upcoming solution to solving some of these problems. So maybe we could have student-led initiatives, maybe we could have students in advocacy or in research. So in what ways do you think, or do you think that students also have a role to play as contributors in the health system to solving some of our problems, sir?
Right, right. Thank you very much for that question. Certainly, medical students have a central role to play in contributing to mitigating the challenges of the health systems of Africa. Let me come from the perspective of research and innovation as a specific example. We know that Africa contributes about 80% to the global population, and the global burden of disease as Africa contributed about 25%. In other words, 1/4 of global burden of disease resides in Africa. But Africa only contributes 2% to global research output. So you can see that there's a very huge gap because you need research to generate evidence, and evidence normally should drive policy. Research should provide evidence to drive policy, to drive practice, and of course, is a catalyst for change in any health systems. So how do we then fill this research gap? How can medical students contribute to filling the huge research gap that exists on the continent? I will use an example and a model that we have developed in Ibadan over the last 6 years. We have what we call the College Research and Innovation Hub, which was established on the 11th of April 2019 through the vision of some past alumni of the college, 1970 to 74 set, when they were marking 70 years of their living, about 50 years of their living the medical school. So in the last 6 years, we've had over about 240 students, including medical, dental, physiotherapy, and nursing students, passing through, I would say, incubation hub. And what do we do? Is a group, is a platform where we mentor passionate students who want to do research. We mentor them, and they have various programs, seminars, journal clubs, conferences, and they're mentored also by passionate mentors. I serve as the current grand patron. What has been the impact in the 6 years of the existence of the College Research and Innovation Hub? The group has produced about 70 publications, including publications in Nature by medical students. The group members have also won more than 20 fellowships, more than 20 grant awards. And as I speak, there are some of the alumni of the group that are currently, they are staff on the National Institute of Health staff in the US, staff of NIH. Many of them have also gone on to pick on PhD and MD programs, to train as physician scientists. For the model that we have in Ibadan, that we are engaging medical students in research and innovation, and we're training them to pick up careers in physician scientist career pathways, and that is contributed to filling the gap that is a huge lacuna on the continent. So we need this sort of model to be replicated across medical schools of the continent. When we do this, then we know that we are training the next generation of researchers. We are also filling the human resource gap. And when you have these, as you know, they also become they become leaders of innovation and research in the respective spaces. And of course, with this, with improvement in funding and improvement in research infrastructure, and with improved funding from our governments, African governments, philanthropies of the continent, we can retain many of these billions of young people who actually desire to work on the continent. Many of them desire to use research as a tool to drive research, solve African problems, African solutions to African problems. So if we're able to encourage these young people to do research and stay back on the continent, then we'll be filling the human resource gap. We'll also be generating evidence that can drive policies that can help to improve our health system. Just a little contribution that I like to make in this respect. Thank you.
Thank you very much, sir, Professor Akiemi. He has rightly explained and confirmed that, of course, students have a role to play in filling those gaps, and strengthening our current health systems. Based on this, he has also given an example of the College Research and Innovation Hub, which is a research hubs, and he mentioned the various achievements that they've had, which can also be replicated in other schools. But I would like to go down to the student level. I'm going to direct my next question to Mr. Victor Femi Lawal. He, as a student, medical school achieved many of these things that Professor Akiemi gave the example of. I would like to ask you, Professor Akiemi has mentioned opportunities in research, but I also love you to also talk more on other opportunities that are available that students can play a role in to fill in that healthcare system gap, both in research and other various aspects. So, Mr. Victor Femlawal, I would like you to speak on that, the opportunities that are available for medical students to actually involve themselves to solve these health issues and health gaps.
Hello, thank you. Can you hear me now?
Yes, we can hear you now.
All right, thank you. Yes, a good day, everyone. Thank you to the FAMSA team and of course to AMSA for the invitation to speak at this meeting. So I believe you asked me about some of the opportunities that medical students have to health systems strengthening. And I think, of course, it's a very, very pertinent question. And as Prof has also highlighted, research is one of the key opportunities that students get to actually contribute to, filling some of the gaps that we have in the health systems, contributing to evidence, and also, of course, building the careers. But I think also beyond that, of course, students have, I think, many of the various other roles, which I think I could also mention, which I think, of course, I've also been involved in at various levels. We can talk about advocacy, for example. Of course, many students are young people, they're youths, and of course, have the capacity or the energy to actually engage with the communities in terms of, for example, outreaches, organizing outreaches, participating in outreaches, and just help plug certain system gaps. But also even at high levels, policy levels. FAMSA, for example, is recognized as a non-state actor at the WHO Africa Regional Office, and every year actually gets to contribute statements, key issues that are facing Africa. So that is one of the ways that medical students actually get to, talk about key issues that are affecting the continent, spotlight them, and also contribute actual solutions that can be, implemented and discussed at high levels. Capacity building as well, we can see, contributions because at the end of the day, we as medical students, we're in training. So it's very important for us to build our own capacity so that when we get to become professionals, we actually have the capacity to actually address the problems that are faced by a continent, right? So whether it's in terms of research skills, whether for example, in clinical trials, like the session we had earlier, or leadership, stakeholder engagement, all these key skills. These are just some of the ways that medical students do have the ability to actually improve health systems. Yeah. Thank you.
Thank you very much, Mr. Victor. So as a follow-up to that, I'll be directing my next question to Dr. Babatunde. Thank you very much for joining us, Dr. Babatunde. So as a student that I am, as a student who is still green, I'm not sure how to involve myself. I'm very passionate. I see some of these problems. I'm like, what can I do to really solve these issues? What can be done? CVD rate is rising in Nigeria. How can I come in? What role can I play? Or do I have to wait till I become a doctor before I can contribute to solving these problems? So as someone who is still green, someone who is still not so sure who can get himself involved, how do you think I can position myself to, contributing to solving some of these issues? I know that Victor has mentioned FAMSA. Do you think student bodies like FAMSA and probably IFMSA and other student bodies have a role to play in positioning students for some of these opportunities? I would just like to hear from your perspective, Dr. Babatunde.
Thank you very much for the question. Can you hear me?
Yes.
Yeah, thank you. It's an honor to be here today. So yeah, as a student, it's very important to contribute to solving problem, and there are different ways to actually engage in solving problem. First is trying to leverage on the things that are actually in your immediate community. For instance, you're a medical student, your medical student association probably has programs that do in terms of reaching out to community, or there might be organizations within your school. For instance, when I was in 200 level, that was when a set of senior colleagues were organizing Feed a Child initiative, and I volunteered for that because I was interested in solving problem. So we went to Sabo community, and where we had a lot of children were out of school, and we provided some services in terms of addressing malnutrition in that community. So that was how I got started. So the leveraging your local community, we want to go for international conferences and stuff, because when you actually eventually find yourself in these high-level meetings, you want to give scenarios, you want to give the story of what's actually happening in your local community. So it's very important to be ready to do the actual groundwork in terms of reaching out and engaging with your act. Then for research, you can also want to advocate and write simple papers. You might not have the opportunity to engage in randomized control trials or highly funded research, but you can write some paper like a commentary, or you write a review as a medical student. So I remember when during the COVID-19 period, I tried to collaborate with people, attending research training programs in order to build my capacity. And immediately I was trying to utilize what I learned by writing some papers. We wrote about my first publication was about talking about the proliferation of quack practices. I mean, people who are not trained, but they are attending to people, which is still a big problem in our community. So, and it was something I experienced while I was out of school during the COVID-19 pandemic, and I was going to a private hospital, and I saw the big problem in probably FAMSA activities, or at the national level, which is for Nigeria instance, NIMSA. So you get to engage, and in the process roles by calling yourself the president or something, but actually solving problem while occupying those roles, engaging with the authorities and people who are your professors and other policymakers, and trying to see how you can solve a particular problem. And with time, you get to see that you're actually growing, you are experiencing personal development growth, you are broadening your network, and then you get to understand problems more, and you are ready to take more responsibility even when you become a medical doctor. Thank you.
All right, thank you very much, Dr. Abdulhamid, for answering that question beautifully. I'm going to be asking a follow-up question to that question, actually directed to Dr. Abdulhamid and Mr. Victor Femilawal. I would like to know of their opinion. They've spoken about how to actually position yourself, being volunteering for all of those organizations in school, looking out for problem, and trying in your little way to see that you are filling those gaps and answer those questions. He gave a very beautiful example, very beautiful example when he went to a public health center, and he just noticed a problem, and they felt, okay, why don't we just write a paper on this, right? That's actually very beautiful. But amidst all of this, I would like to know, Dr. Abdulhamid, if it's actually after volunteering, after doing this, after writing papers, at the end, now that you're a doctor, looking back, will you actually say that it pays to actually do all of these things? Will you actually say that it pays actually be involved in all of this activity looking back? That's the first question. And also, I would also like to know your perspective because we are talking of being involved in different activities, but we should not also forget the fact that we are also medical students, right? And of course, medical school can be very tasking with ward rounds, with clerkings, with presentations, with reading, different things that you have to do, right? So different postings, hectic postings. So, and I would like to know why you were a student, how were you able to like balance being involved in all of these activities, these research projects, volunteering, how were you to balance it and still be a actually very good medical student that is paying attention to their medical training? So this second question is to both Dr. Abdulhamid and Mr. Victor Femlawa, but I'd like to hear from Dr. Abdulhamid first.
Thank you for the question. So the first question is about does it pay? So first, there's no end. I'm still a young doctor and I'm still growing. So yeah, definitely we are still trying to explore a lot of things. Yeah, but looking back, I think it's really pays, and I was very happy that I like used the best the available resources as much as possible when I was a medical student, because it's actually easier to do a lot of things when you're in medical school when you actually become a doctor. For instance, as a house officer and medical officer, there are a lot of other things that take your time and you might not be able to explore things as you add the flexibility in medical school. So yeah, starting very early is very important, it's very beneficial. First is that you build your problem solving and critical thinking approach. Why people who are going to class and thinking about, oh, this is another lecture, you are probably looking at it from a different perspective, from a bigger lens, and seeing that, oh, this is actually a big problem. For instance, you're in a session where they're talking about ONG class, talking about cervical cancer, or you are someone who has gotten involved in doing activities in the community or at FAMSA level, and you know about efforts that is being put in place about increasing access to HPV vaccination and screening and some other things. And so this helps you a lot in understanding the problem. Because when I was a medical student, um, I was working a project with Nigerians of Medical Research, NIMA, which was about promoting HIV self-testing among medical students. So it gave me a better understanding about the problem and how we were able to come up with solution in promoting self-testing among university students, University of Ibadan, the approach that we were able to use, and then we implemented it over 2 years. And also in the process of doing this, you get to build more network, and I got to collaborate with people from Nigeria and outside the country. And then you also reach out to other people. When I was in FAMSA, for instance, I'd reach out to Africa CDC, reach out to a lot of other international organizations for collaboration on a particular project I was working on. So it helps you in building this particular skill of getting partnership, writing grants, building collaboration, expanding your network. And also your faculty, your lecturers also, they are looking at you. You must have reached out to one or two people in the process whereby they guide you and try to provide support and mentorship. And they are also able to see your growth and believe in what you are doing. So after you finish medical school, for instance, and you needed a letter of recommendation, there are people who cannot even, there's no professor in their school that they can call in the midnight or in the night that, please, I need this particular support, and the professor was actually ready to stay all night in order to provide recommendation letters. So these are the kind of things you want to build because it actually gets busy and you might not be able to explore as you want as when you become a medical doctor. So yeah, it pays off definitely a lot when you apply yourself and you're actually solving problems and contributing to development of healthcare system. Yeah, regarding the other question about balancing with medical school. For me, I don't think there was balance, but yeah, of course, there were times where things were easier in medical school, probably because of the strike action, or you were in some particular postings that are a bit more flexible. So during that period, you might want to, okay, have more time to dedicate to what you were doing. For instance, when I was in FAMSA school, my chairperson, I was preparing for an exam, MBA exam, but I was able to plan my action plan as the chairperson to fit into the curriculum and see that, oh, this particular period when I don't have exam, there are a lot of programs that are happening, and also I learned to delegate tasks very early, communicate very early also with people in my committee. So we want to be able to master this particular approach and make sure other people are doing it. Everybody will be busy at the same time. So we want to be able to delegate tasks so that you achieve what you want to achieve. And yeah, there is also taking the risk, because in the end, things still later have to put into place. For instance, I got selected to attend FAMSA conference and also African CDC conference together in November when I was in final year. And that same time, I was also in a particular posting, community medicine posting. So I was able to reach out to the faculty, submit letter, and I was able to go for the conferences, and I was attending the sessions online, and that was very helpful for the school. So you want to understand and communicate very early also to your faculty and to the school about the program you are going. Of course, you also want to not be reckless about what you are doing by understanding that the primary goal is being in medical school to finish it good. So you don't want to abuse the opportunity that has been given by always being the one attending international conference every single time. Try to prioritize and leverage on the available resources. So you want to, and also not everyone have the liberty. You need to understand yourself. If you are struggling academically, sometimes you might want to just wind down on doing some extracurricular activities and focus on the medical part. So you want to set your priority very clearly and also what you are targeting. So not everyone will have the opportunity to be the best graduating students, and also not everyone will have the opportunity to do a lot of activity with WHO, African CDC and the likes. But yeah, you want to understand that you still have to have some extracurricular activities and understanding solving problem while you're a medical student. Thank you.
Thank you very much, Dr. Abdulhamid. Unfortunately, we're running out of time. So, Victor, can you just answer the question in like few seconds?
All right, thank you. So I'll try to quickly answer that. In terms of balancing, I think there are just a few things that I would just add. I think, of course, Dr. Hamid has said a lot of the things, but I think one of the key things is, of course, prioritization. I think at the end of the day, medical school, when one is in medical school, that's still number one, right? So the most important thing is whatever activity one is trying to do, what to contribute to, should be planned around your medical school schedule, whatever posting that you're currently in and all that. So that having that consciousness helps you to easily know what you are able to commit to and what not. And even personally, I've had to either turn down or decline certain things because of maybe certain postings or certain activities. I mean, I think last year there was a conference I was supposed to attend in Nairobi, which I had to decline because I just saw that it was going to was so it wasn't compatible with the posting where that is one of the key things. I think Dr. Abdulhamid also mentioned delegation, which is very important, especially if you're in leadership roles. It really helps because that will ensure that the work actually goes on, right? But you are not affected. Consistency, I would say, is also very important. Sometimes you're not able to do a lot in a day, but you can just do just as little as possible so that at the end of the day, you actually end up achieving something. For example, if it's a short period you're doing, maybe today you're going to work on maybe the introduction, and then you come back the next day to work on the methodology, something like that, so that at the end of the day, you actually end up achieving something, right? But without overly affecting your activities. Then I think one other thing I would just say is also collaboration. Goes hand in hand with delegation, but collaboration in the sense that it makes you move faster and get things done. So when you're able to work with like minds, right? When you're in communities of people that are all focused on probably achieving certain things, that actually helps in actually moving further, right? And even doing that faster. Yeah, thank you.
All right, thank you very much, Mr. Victor Femlawal and Dr. Abdulhamid. Thank you very much for answering that question beautifully. Very, very briefly, Victor Femlawal and Dr. Abdulhamid have mentioned very beautiful areas where students can actually impact. But I'd like to hear very briefly from Dr. Akemi as well, if all of these activities, all of these outreaches, research project that they mentioned, if from a top level, from a top person perspective, if those activities actually make impacts. I would like to hear from Professor Akiemi.
Yes, certainly. All the elegant points made by my esteemed younger colleagues, absolutely very, they're on point. But one thing that I think would be of help, because sometimes you're unable to chart the course yourself. And this is where mentoring comes in. you stand on the shoulder of giants, they walk the pathway with you. They will help you to see things in a better perspective. They will guide you even based on their own past experiences, including failures and successes. So I would say mentorship helps to put all this together. When you follow, when you follow a mentor, your journey is faster. You avoid landmines in the course of the journey. And I would say that is a catalyst to helping your journey to be more effective, efficient, and of course, you achieve bigger impact over a shorter time. And of course, you always have their back. Mentorship is very, very important. Thank you.
Thank you so much, Prof. So, from my understanding, yes, while it's important or it's advised that we turn all this motivation into real impact, it's also very important that we get guidance from those who have gone ahead, those who are already at the top, those who are already making the influencing decisions in health systems. Thank you so much, sir. So, this last question to Professor Yosin. So, from your experience, I mean, from my own experience, I can say confidently that medical education in my school is top notch, is global standard. But from your experience, from your perspective, sir, do you think there are any gaps in the current medical training? And I mean, in the context of not just building the clinical acumen of the students, but also like equipping them to be contributors, to be solutions in the health system. Do you think there are any gaps in, equipping students to be, apart from being able to diagnose diseases accurately, that's wonderful, but also to equip them to become contributors to solving some of these global health challenges? And what are some of the ways that we can support and scale up student-led initiatives? So it's a two-in-one question, sir. Are there any gaps? Is there anything we can do better in our medical education? Is there anything we can add to ensure that students are stimulated and students are well equipped to solve global health challenges? And how can we support student-led initiatives? This is for Professor Yosin. Co-host, please. No, he's on, but he's currently not a co-host, so he can't unmute himself. Professor Alfred Yosin.
Yes, I couldn't
Right.
unmute myself.
Yeah, sorry about that, Prof. Thank you, sir.
It's all right. So thank you very much. I would like to say that from the training and health system level activities that we can do, I appreciate all the contributions from the junior colleague and the senior colleague online. I would say mentorship again is important, like Prof highlighted. What I will say is that we need to create opportunities in our institutions, even if it's not institutionalized, to develop some soft skills for ourselves. Entrepreneurship, it's important. Develop your IT skills. So as student leaders, we need to create opportunities. The curriculum in most of our medical schools are packed such that there are little opportunity to introduce some of these. But as students, we can develop seminars, we can develop webinars, and with IT tools currently readily available, we need to do that to enhance our skill quite beyond the typical clinical level thing, so that we are able to develop ourselves as human beings, as individuals, and as a group to be able to go beyond just the practical, technical things. Recently, we were visited by the World Bank Managing Director, and an economic student asked that I'm a level 200 economic student. How do I become like you and be MD of the World Bank? You know what he said? He said, studying economics is important, but do find time to study poetry, read philosophy, read a few of the non-typical things, and that will make you suitable for the current world order. So that is my little advice to you. Look for opportunities and do something extra beyond medicine. There are opportunities out there, as I mentioned.
that we are in the fourth industrial revolution, IT skills, AI is very important. We are saying that AI per se will not replace doctors, but doctors with AI skills will replace doctors without AI skill. That is important lesson for you to know. You might not be replaced merely because of AI, but you'll be replaced by colleagues who have extra skill in using AI to do what you will ordinarily do. So those are skills I will encourage you, even if it's not at the institutional level, we should try and institute some of these through webinars, through student level activity, so that we build these skills for our colleagues. And at the end of the day, at the institutional level, we as institutional leaders will need to find opportunity, create opportunity, revise our curriculum. Now we need to move to competency-based training. And if we did that, we will be able to free up time to do some of these contemporary required things, not the typical thorough didactic lecture several hours in a week for medical students. But competency-based training can free some time, and we hone in on specific competencies. After all, when our students finish school, they may go into specialties, different specialties, family medicine, and that makes them generally. So every medical student will be looking forward to going into one specialty or the other based on the competencies they have developed. So as trainers and institutional leaders, we need to look at shifting the focus from the current typical curriculum that we have in our medical school to more competency-based training across board, and that will help develop the skill of our medical students and give them opportunity to acquire other skills. Thank you very much.
Thank you so much, Prof. Sir. Thank you so much for the contributions, sir. We are really grateful for all the contributions. We're wrapping up already. Just before we take questions, just one word answers that in summary, are students potential contributors to solving health issues? So just yes or no from each of our speakers. Starting with you, Mr. Victor.
Okay, since the one word answer, I would say yes. Yeah, some of it, because in many ways, yes.
Thank you very much. So, Cindy.
Yeah, definitely, yes.
Thank you very much, sir. Professor Alfred Yosin, sir.
Definitely, our medical students can contribute to improve the health system of Africa. Definitely.
Thank you, sir. Professor Rufus Akiyemi, sir.
Yes, absolutely. I agree with my colleagues. Students are the future, and the future begins now.
All right, sir. Thank you so much, sir. Sir, one more thing, sirs. We would appreciate if you can drop your contact email in the chat box for some people that might have questions. Then let know that we are running out of time. So, all right, sir. So, we appreciate if you can put your contact email in the chat box so that people who have questions can contact you directly as we are running out of time. So, thank you so much, everyone, for sticking with us throughout this session. Thank you for your patience. We really appreciate it, and we are wrapping up. Thank you very much. So just one more thing before we are out of here. I think people are telling me that they have questions. I think we might take one or two questions. So let's take one or two questions from the physical guests first. Does anyone have any questions? All right, so we'll take the online question. Let me see. Marwan All has his hand up. So Marwan, you can ask your question. You can go ahead and speak, Marwan. I think he's not able to speak. So you can type your question in the chat box. Thank you very much once again, everyone. Before we step out of here, we have a presentation, a 5-minute presentation by one of our partners, Futurize. So I'll hand over to Ms. Adegute for concluding, please. Thank you so much.
Thank you very much for joining us.
Thank you very much. So before the presentation.
Thank you for the opportunity.
Okay, thank you. So before the next presentation, I'll be calling on Mr. Donatus. Mr. Donatus is one of the managers here, and we are supposed to have done this before we started. Just some 3 minutes of safety protocol information in the hotel here. So please give him a round of applause as he does this.
Good morning, all. You are welcome to Lagos Marriott Hotel Ikeja. I am Godwin Rubem Donatus from Health, Safety and Security Department. This is something we're supposed to do before the commencement of the event, but then the live session has already begun, so I was asked to stand and wait till you're done. So there are several stuffs that I would like to bring to your attention. This is just that we'll be sure that should there be an emergency, you all will know what to do. In line with global best practice, here at Lagos Marriott Hotel, we do give what is called safety and security briefing. Some of the stuff that we would love for you to know are: first, should our emergency alarm system be triggered, should you hear the sound of the alarm while having your event, we would always advise that you do not panic, but then you look for the near doors. In this venue where we're having your event, we have like 1, 2, 3, 4, 5 emergency door. So should you hear the sound of the alarm system, please would advise that you make use of any of these doors and then move straight to the muster point. The point is located at the main gate. I want to believe you all know where the main gate is. So should you hear the sound of the alarm system, please just use any of the door and make your way to the muster point. So also it is important to note that whenever our alarm system is being triggered, our elevator is configured to obey 2 primary commands. First being that it moves to the reception area, and secondly, it opens wide and shuts down. So whenever you're hearing the sound of the alarm system, please don't try making use of the elevator, because at that point in time, it won't be working. Secondly, the location where you're having your event is called, okay, I don't know if there is anybody that is an in-house guest. I don't know if there is anybody that is lodging with us. Okay, so for those that are lodging with us, whenever you hear the sound of the alarm system, we have 3 places where we have our escape route, all staircases. We have one at the extreme end, one at the middle, and one at the rear end. You would always see a signage like this attached to the staircases. So whenever you're hearing the sound of the alarm system, please just look for that signage and then make your way to the staircase and then move down. How the staircase works is that once you've entered, there's no going back. You have to move straight to the exit point and then move to the muster point. Secondly, the venue where you're having your event is called the lower ground floor. If for whatsoever reason you step out and then you miss your way, please look for any of our elevator and press the inscription LG. LG, it will bring you back to this space. And on this space, we have 2 locations where we are having our restrooms. Just one opposite this venue, just outside, we have one, and then we have one at the extreme end for male and female. See something, say something. And it's very difficult to identify anybody. If you see anything that looks suspicious, anything that stands out, our security teams are outside. Please just call our attention to have somebody attend to it. Your personal belongings, like your phones and your laptops, in as much as we would guarantee that they are safe, but you'd agree with me that no security measure is soundproof. That's why I would always advise that you take charge of your personal belongings. If for whatsoever reason all of you will be going out and then you'd want your stuff to be in here, please call our attention. We'll have somebody close to the door depending on when you'll be coming back. For medical emergencies, we have trained first aiders in-house. Myself, I've been trained in that regard, and to the fact that most of you are medical practitioners, I think you will not be needing that service. But then it is important to know that we have trained first aiders in the house. We also have a certified in-house nurse that is always in-house 24/7. Should there be a medical emergency. But then if it's a medical emergency that would require us taking anybody to the hospital, we have a station vehicle. We have a vehicle that is stationed as to that regard. If need be, would have the vehicle convey the person to the nearest hospital, which is Dutchess International Hospital, which is like 3 minutes drive away from this place. If you are walking to that place, it's 5 minutes stop. We should be there. It's important to note that while ours is to just convey the vehicle and then take you there, all medical base is on whoever it is that will be taken to the hospital. Lastly, for security emergency, if we feel the security atmosphere is not conducive, we feel there is a security threat, we have a very good rapport with Area F. For those of you that are familiar with this terrain, you know that Area F is just by the corner here. We have a very good rapport with them. One phone call, within minutes, they should be here. And then while that is done, we have our ERT members, which is emergency response team member, convey you people to a more safer location. This has never happened before, but then it's a laid down plan to make sure that the safety and security of our guests, of course, takes the front seat. So that's basically everything I'm supposed to bring to your attention. But then if you have any question, I would be more than glad to answer them before leaving.
Thank you very much, Mr. Donatus, for the briefing. I believe we all have sufficient information, and if we have more questions, please feel free to contact him outside. So sorry for taking your time. We'll return to the presentation now.
Thank you very much, everyone. Thank you all for joining, both in-house and the people online. Thank you very much to our panelists for giving us such an insightful session. So as we bring this session to a close, I'd just like to take another moment, just about 5 minutes of your time, to introduce another one of our partners. So Futurize Limited is an organization that aims to enhance the university education experience by promoting technological and professional learning through entrepreneurship programs, workshops, and professional services. So, and representing Futurize Limited with us here today is Ms. Mercy Okelo, the Business Development and Project Manager. So please join me in welcoming Ms. Mercy Okelo. Thank you.
Thank you so much. Thank you so much, Dimeji. Thank you so much, Tim. Can you hear me?
Yes, we can hear you.
All right. I greatly appreciate. Sorry for the delay. I had an emergency with my connection, and so I've had to log in back quite fast. I'll just quick introduction. My name is Mercy Okelo, as had been stated. I work with Futurize. Futurize is a global innovation program where we work together with higher learning institutions across the globe to train their students in entrepreneurship and innovation. So briefly about Futurize in Africa, we operate across the globe, I've stated, but then we have major operations in Africa. Specifically, currently, we have a partnership with FAMSA and other higher learning institutions. This is our third year in partnership with FAMSA. We worked together with FAMSA to train them to build their innovation ideas through our 3 main programs. Sorry, I had prepared a slide, but I won't be able to share it because of the device I'm using. So we have 3 major programs. We have the Futurize Academy, the Futurize Incubator Program, and our physical summit. Our programs are majorly tailored in the health tech space, and we have, this is our 5th year training students. We have in the academy, it runs for 3 weeks. I know some of you have gotten the chance to participate in our program last year and in the previous years. Last year specifically, we received quite a number of students from FAMSA. This year, we will be launching our incubator program in the next 1 week, early April, and we'd like to encourage students to be part of our program. Just a brief explanation of what our program is all about. So the academy is a program that runs for 3 weeks. It's a sprint, and then it's all about helping students work on their idea so that they can prepare it and be able to pitch it. After which they can now work on it to develop it and get investors invest, and then they can come up with these innovation technologies that help us solve our problems in Africa, address the problems that Africans are facing. So we ended last year in December. We'll have another this year. But then in the 3 weeks, students are taken through 3 weeks, which have workshops, mentoring sessions, and just other trainings that help them interact with each other. As I had stated, it's across Africa. And then the other thing is that it's followed by our incubator program, which runs for 5 months. For the 5 months, students are able to now develop this idea. They have their prototypes, they train it. At the end of it, we have a physical summit where we bring the ecosystem together, the investors, the mentors, the trainers, and organize a physical event so they can pitch, and the best teams always get some awards. We have had successful teams from our previous programs and cohorts. We have had some teams in Nigeria, which have been really successful, some in Uganda, some in Kenya. And our call this year through FAMSA is that, as I had mentioned, we understand that there are some higher learning institutions represented here. So if you'd like to have your students join us in the global stage of innovation, where they come up with it from across Africa, we welcome that. You can reach out by sending me an email at Mercy@Futurize. Futurize is FUTURIZE, and we can work together and bring your student the limelight and help them develop their innovative ideas at the end of it all. So I don't know if there's any question for the students or partners would like, or higher learning institutions would like to partner with us.
All right, thank you very much, Mr. Ms. Messi, for that wonderful presentation from at the FAMSA Headquarters Board. Thank you very much also to our audience for being with us from the beginning, both those that are here present and those that are also online. We appreciate you for participating in our session, Training the Future, Strengthening the Present, Medical Students as Catalyst for Health Systems Strengthening in Africa. Thank you very much again. I also want to also appreciate every of our speakers for being online, the guys of our visit here. Thank you very much. And we also want as medical students to present here. Thank you very much for joining us once again. I'm a member of the FAMSA Headquarters Board. Thank you.
Good afternoon, ladies and gentlemen. That was the end of one of the 3 parallel sessions we've had this morning. We're all welcome to AMSA 2026, the Conference on Medical Education. We have distinguished members of the profession, senior members of the profession from all over the world attending, and we have our students who are here, practitioners who are here. On behalf of the LOC, we want to welcome everybody who's here so far. There are a number of people online, quite a number of people online that are joining us, and they too participated in the 3 parallel sessions. The session we just witnessed here, tailing off, brought out a number of issues. Questions were asked, and I think we were thoroughly enriched. On the second session too, in room 2, It was about education, health education. There's something I picked up there that was quite interesting, and that as we prepare, material for health education for students, it should be outcome oriented. I think that's what you said, sir. Outcome oriented. And then, of course, there was a closed session that none of us were involved, except those who participated. I have the distinguished privilege to inform all of us that in our presence, we have the Honorable Commissioner for Health, Lagos State, representing the Governor of Lagos State here present. Shortly, I will be calling on the chairman of the LOC, one of the co-chairmen. We have two co-chairmen, Professor Olubunmi Olaopa and Professor Fasomade, both of them who are here, who have led a local organizing committee to put this august event into place. And is here. He will come do the introductions, including that of our chief host, who is the president, Association of Medical Schools in Africa, or one of our chief hosts, let me say, Professor Tim Dayo. Professor Olaupa, you're most welcome. Can we give him a round of applause, please? And by this, thank you very much, sir.
Good morning, distinguished ladies and gentlemen. It's a pleasure to see you all here. And before we go on to the protocols, let me, on behalf of the local organizing committee, welcome you to Lagos. It's indeed a real great pleasure to see as many people as are here, because this is a hybrid meeting and we know there are more people online. We had been a little worried about the current situation affecting ability to attend, but as it is, we have made arrangements to ensure that those who attend would have a good session. The present meeting was postponed from 2020 because of COVID. Just as we were about to hold that meeting, 4 weeks to go, COVID struck, and 3 weeks to go, the world was shut down. And we had to cancel that meeting. So we were wondering whether or not the pixies were after us, when there was a situation in the east of the world that also threatened this meeting, because half of the world was unable to move. In fact, 40% of our delegates had to send in to say they could not go past the Middle East, which was their hub. But we were pretty determined that this meeting would go ahead, if only online. And we therefore activated a hybrid format, and we're quite pleased that that has been working so well. It's my duty to invite the president of AMSA to please bring forward the Honorable Commissioner for Lagos State, Honorable Commissioner for Health for Lagos State, who is going to give our first presentation this morning, and bring him forward with his entourage. May I also ask the World Federation for Medical Education delegates to please come forward. They're sitting nicely at the back, as well as the AMSA Exco to please come to the first two tables, so we can begin this session. So David, Adelina, please, we have seats for you in front. Jehu, put on I must say that I am the chairman of the LOC, but my co-chairs are Professor Fasmade, as you've been told, who is in the room, and also Professor Abolariwa, who is holding fort outside to make sure things go well. we shall do the necessary introductions during the opening ceremony. Welcoming those who are online. May I just pass on some few bits of information. The abstracts are online. We are going to have 2 TV screens that will be rolling continuously for the 3 days. But there will be links sent out for those who wish to view the abstracts online that have been listed in the program. The program will also be circulated online. And on Saturday, we have conference awards winners, both faculty and students. There are 10 each, I believe, and they will be making their presentations physically, which of course will be also shown virtually. But during the tea breaks, please go and view the abstracts. Lunch will be served in the next 2 rooms, which will be shorter than usual 1 hour. The reason being that being a hybrid conference, we are having to arrange our talks between Australia, that is 11 hours ahead of us, and Chicago, that is 7 hours behind us. And I can tell you, it's added a few gray hairs, just trying to make sure everybody can cinch in. So with that, it is my great honor and pleasure to ask Professor Akin Abayomi, who is the Honorable Commissioner for Health for Lagos State, to give the first plenary of the AMSA 2026 conference, Medical Education Conference in Lagos. Professor Abayomi.
So good morning, everybody. Let me first of all express the sincere apologies of His Excellency, Governor of Lagos State. As you will see from my presentation, significantly invested in medical education. And you come at a time when the world is experiencing some upheaval, and domestically, we're just about to start the campaign cycle for election, and His Excellency has just accompanied the President back to Abuja. And in fact, I cannot stay for the whole of this conference, even though I would have loved to. I will have to leave as well and head to Abuja soon after my time with you. But he did say to welcome all our visitors, particularly. I've met some of you from the UK, from Portugal, from Uganda, from Zimbabwe, and I'm sure there are many more. We are delighted to host you in Lagos on such an important subject matter. A subject matter that is indeed worthy of multiple dialogue sessions to find resolutions to significant issues that we're experiencing. I will, after my lecture, represent His Excellency at the opening ceremony on his request. And so I will do some of my protocol during that session. I've also say a big hello to my local colleagues in Nigeria. I know how much work you've done to put this conference together. I'm excited that it's happening despite the circumstances. And I hope that at the end of this conference, that we in the local environment would have been able to learn a lot more about the education of medical professionals, and that you would have taken some observations from this environment as you work towards your global assignment, vision, and mission. So when Professor Bumi asked me to speak at this conference, I think he's fully aware of what is happening around in Lagos and Nigeria. And I may be letting the cat out of the bag somewhat, because what we're trying to do in Lagos is, I would say, just over half cooked. But it's still a process on a fast trajectory. And what I'll be doing this morning is just trying to explain to you in very simple terms the logic behind what His Excellency has given us a mandate to do. So if I could have my slides projected. I don't have a prompter, so I have to turn around a bit. And this speaker right in my ears. So let me move back. So I want to explain what Lagos State as a government is doing in its attempt to establish the Lagos State University of Medicine and Health Sciences in Lagos. This is a collaboration between several ministries. Ministry of Health, Ministry of Tertiary Education, the Ministry of Justice, and the entire Executive Council of Nigeria, of Lagos. So Lagos State has annually a think tank political private dialogue called ENIBETI. And we converted this in 2022 into a 30-year master development plan for the state. And it's called the LSDP 2052. We're quite proud of this because I think that this is probably the only geopolitical space on the continent that has a 30-year advanced development plan. Most people have a 5 or 10. But the speed at which Lagos is growing, the speed at which its prominence is evolving has made us think. And I extracted the salient medical issues out of the plan, and I've summarized them in 3 sections. And the main idea is that Lagos needs some far-reaching strategic development plans to achieve economic competitiveness globally. And so to do that, we need to have a very healthy, robust human capital. And we all know that human capital starts with health. And so to achieve that, we need to achieve healthcare coverage. And we're embarking on a very aggressive health insurance narrative in Lagos, where we've passed a law at the federal level that health insurance is now mandatory for Nigerians. And Lagos was quick to domesticate that law through an executive order. And so we are actually in the process of enforcing this law in Lagos. The next thing we want to do is to stop outbound medical tourism. In other words, all our citizens should be able to get the plethora of healthcare solutions at home. And to drive our economy, we need to make sure that our vibrant youth, you've probably heard that Africa has a youth bulge. So our demographic profile is a pyramid, and 60% of Lagosians are under the age of 25. And so it's important that we focus on this youth bulge and we make sure that from the moment they're conceived, that they go through an appropriate 9-month gestation, and as soon as they're born, the system ushers them into this vibrant capacity that we're looking for. Now, the 30-year plan is hinged on health care delivery. And according to the WHO statistics, we should have one healthcare professional for about 600 or 1,000 population. But in Lagos at the moment, we have one healthcare professional for 4,000 population. So not surprisingly, translates into indices that we're not so excited about. For example, maternal mortality rate is high. Our infant mortality rate is not something that we will, shout from the rooftops. We have nutritional issues. And as you can see there, we have a shortage of beds, medical beds. And in Lagos, we're trying to distinguish medical beds because there's medical beds and then there's specialty beds. One figure talking about medical beds, but we need intensive care beds. We need surgical beds. We need pediatric beds. We need psychiatric beds. So, talking about beds is good, but we need to unpack those beds and make sure the relevant disciplines that will cater for the various conditions in Lagos. And then at the bottom there, we're really, really trying to move away from, reaction to prevention. So almost all our medical encounters at the moment in Lagos are curative or treatment. We're trying to move into an era of wellness so that we can forestall medical conditions. And the biggest area we're discovering at the moment in Lagos is the metabolic diseases. And if we're trying to unravel a massive public health campaign around curtailing metabolic disease in Lagos. So what is the Lagos mandate? I've explained the plan, the justification for a standalone university focused on medical sciences in Lagos. And I'm sure you all know these figures. Essentially, Africa has a significant shortage of medical schools. That's why we're here. Our population of about 1.4 billion, only 154 medical schools out of the 3,700. I'm not sure if these figures are still correct, but I got them off the internet, and it shows you the ratio of university to 9 million people in Africa compared to one university to 1 million people in the Americas, and even better in Europe. So typically we have these figures, and I'm sure you've seen different iterations data. Green are the well-endowed countries with good numbers of medical professionals per population, Belgium, America, Europe, and so on. And then typically at the bottom, and sorry, it's not projecting that well, you have countries that we belong to, typically on the continent of Africa, where there's a serious shortage of human manpower in the health sector. And what makes it even more alarming is the fact that there's a drain from a shortage. So the countries in green are well endowed, and the countries in red, as you know, are significantly less endowed. And yet the drain flows from the less endowed to the more endowed, which is a vicious circle rather than a virtuous circle for us. And Nigeria sits somewhere in those poor indices, and Lagos as well. So we have two medical schools in the public sector in Lagos, and we have one private. I'm going to speak about the state university. So there's a state university, Lagos State, and there's a federal university. Graduates, at least 50% will migrate out of Nigeria abroad. So that leaves us with about 50. Over the last 25 years, we've graduated 1,690 doctors. And I'm just using doctors as a surrogate marker. But Lagos, with a population of 30 million, according to WHO standards, needs 30,000 doctors. And we only have 7,000. So there's a shortage of about 23,000 doctors in Lagos. So if we're producing 100 every year in our institution and maybe 100 in our sister institution, that's 200, and half of them leave. We're left with 100. And how, if you do the maths, 23,000 into 100, it's quite a large number of years for us to catch up at this rate of production. So what are the clinical ramifications of this data? How are our citizens coping? Well, our indices show that women and children are struggling. Our medical professionals that are left on ground are experiencing significant burnout. And we all know what happens when our professionals are burnt out. They lose empathy, they make mistakes. And at the end of the day, they look for greener grass and they migrate. But in reality, what's happening on the ground? And what's happening is this phenomenon that we all know about. It's called task shifting, task sharing. And so there are several dimensions of task shifting. Our allied health professionals and specialists are consulting, diagnosing, and prescribing. Patients are self-diagnosing using AI and all kinds of things. And self-prescribing, and in fact, self-testing, because there's self-testing now available. So if you go onto the internet, you put in your symptoms, it gives you some information, and you go and you do this, and then you eventually treat yourself, which is not so difficult in a place like Nigeria, where you can get prescription drugs over the counter without a prescription. Medical professionals are doing things beyond the scope of their expertise, which is a form of quackery. And then there is real quackery, where you have fake professionals masquerading themselves as medical professionals. So the sum total of all that is high morbidity and high mortality in the populace, and a very fragmented, stressed, and chaotic health ecosystem. So we thought about this situation, and we had a brainstorming session. We went into a retreat, and Mr. Governor called the retreat. We had a number of things to talk about, but this was top of the agenda. And what we do is we have a teaching hospital, a college of medicine that trains its medical professionals at the teaching hospital. But when you look at the ecosystem of the health sector in Lagos, at blue there is the tertiary, is the apex, green is our secondary, and red is our primary. And Lagos is actually extremely well endowed with infrastructure. We have over 30 huge general hospitals with a patient footprint of at least 1,000 a day. We have 300 primary healthcare facilities. Of those, about 60 are called our flagships. They're almost like health centers. They're like mini hospitals. So you have 30 big general hospitals and you have 60 health centers, open 24 hours. And when you look at that, collectively, we're adding an additional 4,000 beds to the 750 beds in our teaching hospital. So we said, this is our asset. What are we doing with it? Yes, at these facilities, we offer service predominantly. So the Lagos strategy is simply based on extending our training of medical professionals into some of our very impressive capital assets, our general hospitals, our flagship 24-hour PHCs. And we can take advantage of our 30 million population. So 30 million population must have a significant number of people that are sick. And those of us who have come through the medical profession, you know that medicine is taught at the bedside. As medical students, yes, you do your 2 years of didactic theory and, learn your Krebs cycle and learn this and that. But where do you learn your medicine? You learn your medicine at the bedside, in the clinic, in the theater, in the community. And so here you have students clerking a patient, taking a history, examining and spending hours and scribbling and writing. And that's how we learn medicine. We're apprentices. We all know that. It's like in Nigeria, people learn their artisan trade as apprentices. They go and join a mechanic workshop or a carpenter or this, and they spend 2 or 3 years. And after that time, they know how to put a table or a chair together. And so the lady in green is the patient. And the 2 students there are practicing. Now, these figures are impressive. In our general hospitals alone, we see 7 million patient encounters a year. If we add our primary healthcare to that level, it goes up to 20 million patient encounters a year. So, what can you do with 20 million patients? You can train thousands and thousands of medical professionals because that is the fuel that you need. And for many medical schools around the world, and I've spent time in many parts of the world, particularly in the Caribbean, where you have an explosion of medical schools, what is the one currency they're looking for? After their preclinical years, they're all looking for patients because that's how they get signed off on their rotations. And so in Lagos, we're actually wasting a magnificent and huge asset because these patients, these 20 million patients, need to be converted into the opportunity to make a massive number of healthcare professionals. And Lagos should never be a city that is short of medical professionals. And so, putting this into some kind of schematic diagram for you to try and understand, LASU is the Lagos State University. Inside LASU is the Lagos State College of Medicine. What we're trying to do is pull the College of Medicine out of LASU, make it a standalone University of Medicine and Health Sciences, and decentralize our training so that instead of exposing our students to 800 beds, we have now about 4,000 beds in addition to the 800 that would be the supervising teaching hospital. Now, there are some people in this room who come from London, and this is exactly what happens in the United Kingdom. Your teaching hospital is where you spend maybe 50% of your time. The rest of your time, you go out into the community, into the general hospitals, into the GP practices. That's how I learned my medicine. I would come back periodically I studied in St. Bartholomew's, by the way. I would come back to St. Bartholomew's maybe every 3 months to get 1 or 2 sessions to rest, team up with everybody, play your usual rugby and football, and then you're out again, back into the field. And so medicine doesn't have to be entirely taught at the central teaching hospital. And this is a map of Lagos. I was just telling our guest from Portugal that Lagos is a very small state, the smallest state in Nigeria in terms of land size, but the biggest state in terms of population and in terms of commercial activity. And for us, it's 1/3 of Lagos is water. So there's only 2/3 of land. And that's why it's called the center of aquatic splendor. So I hope that in your visit to Lagos, that your hosts will take you to our numerous beaches and fish restaurants, because there's a lot of good dining and cuisine and swimming to do in Lagos. So essentially, this standalone university will decentralize the access of students down into our significant secondary and primary healthcare structures. And so Lagos is divided into 5 zones. We call it the Ibile zones. You don't need to know the details, but in each of those zones are general hospitals and flagship PHCs. And so each of those zones will form a cluster that the patients can go to, a little bit similar to the way you have almost 12 medical schools in London, but they're all under University of London. So there's St. Mary's, there's King's College, there's St. Bartholomew's, but they're all University of London. So these, if you like, can become the colleges that fit under the University of the Lagos State University of Medicine. And not forgetting that we have several federal and military hospitals in Lagos, quite a number. And we have a very, very well-developed private sector. And we have about 3,000 registered private healthcare facilities in Lagos. I would say about 400 of them are at the secondary healthcare level, and maybe about 20 are tertiary. So again, quite a number of these private sector institutions can team up with government to create that environment in which we expand our medical professionals. So we're thinking that in the next 3 to 4 years, that we can grow from 150 students a year to training 1,000 nurses, 1,000 doctors, and all the other healthcare professionals that make up the ecosystem of the health sector in Lagos systematically. And this is a picture of one of our general hospitals. This is Lagos Island General Hospital. It's the oldest general hospital in Nigeria. It sees 1,000 patients a day through its outpatient clinic and hundreds of beds. This is Badagry General Hospital. And there are about 20 to 30 of these hospitals scattered all over Lagos, primarily focused on service. But the whole idea now is to introduce the concept of academia. And some of them already have academia because they're training postgraduate students and they have house officers. And so it's not academia, it's not alien to them, but we understand that there's a process that needs to go through to get us where we are. So what's the campus development strategy? So this is the master document. We have it in 3 phases: expansion, phase 1, land acquisition for the 4 separate campuses, and commencement of the main campus. Construction of the sub-campuses, we have 3D designs that have been developed. We're acquiring land. We're expanding our assets as they currently exist. And then some people may say, well, if you are grumbling about human resources shortage, where are you going to get the academia to train 10 times more students? So at the top there is the human resources in our general hospitals. The second line is the human resources in our College of Medicine. And the third line is our human resources in the teaching hospital. And you can see that the top line has almost an equal number of specialists as does the academic segment of Lagos. So there's a bank of professionals that are sitting in our general hospitals that can become adjunct lecturers or honorary lecturers into this new decentralized strategy. And then we have residents, and we all know that residents are what really fulcrum of the senior registrars and the registrars. I was taught most of my medicine by registrars and senior registrars. You know, you only go to your ward round to be humiliated by your consultants. But it's the residents that hold you together, you know. And then in the private sector, we have at least 400 specialists. And now that we're in the age of digital technology, AI, telemedicine, we're looking at our diaspora. And our diaspora is at least 16,000 strong in the Americas and an equal number in Europe. And if only a fraction of our diasporians want to be involved in this facility, we're setting up the opportunity to be able to, through learning management systems, to be able to do real-time lecturing and tutorials and even supervision with many of our diasporians. So when you add all that up, there really is indeed a large pool of human resources to pull from. And it's a matter of focus and dedication. Okay, so this is just the projection of how the school will increase its intake by about 500 every year until we hit our target, and then we'll plateau out and see how things go. So over the next 3 to 4 years, we're hoping to hit this exponential growth of student intake into the college. So this is the roadmap, just so that you know I'm not just talking theory. We've developed step one, we've developed the medical university concept. There are many people in this room involved in that process. We did the draft law. It was presented to, in Lagos or Nigeria, we call it the Executive Council, which is the cabinet of the government. The government passed it and moved it on to the Lagos House of Assembly, which is our legislative arm of government. And they will convert the draft law. So the draft law was developed by professionals, moved to the Ministry of Justice to be put into a draft law, and then moved to the Lagos State House of Assembly, where it will be put into, passed into law. We've developed a very detailed academic brief. Even I was shocked when I saw the first draft of the academic brief. It's extremely detailed and lays out the entire plan as I've tried to elucidate. And then the Lagos State House of Assembly, in my time in government, which has been 7 years, I've never seen a law passed so fast, which is a reflection of the enthusiasm and the understanding of the legislators and the citizenry that this phenomenon should have started 20 years ago. And so the law has passed through the House of Assembly. We've developed some sustainability plans. We've started to expand our physical infrastructure in phase one. So we could only seat about 300 students last year. In another 2 months, we can seat 3,000 students, and that's just phase one. And all that's left now is for the governor to sign the law and the university starts. And then the other events have to happen. We have to get concurrence from various accreditation bodies, and then we plan our our increased uptake, and then we go into the general hospitals and we start to prepare them for their diversification of their responsibilities, because we all know that service and academia are two different things. On a work round, you can do 30 patients in 1 hour. On a teaching round, 30 patients can take 3 to 4 hours. And so there's a difference. And so some rounds will be working rounds and some will be teaching rounds. And we start to engage our diasporians and persons, eminent persons like you, to help us to think through this strategy, bearing in mind the significant shortage and the crisis that we find ourselves in. So you might think, wow, you know, all this is on a tangent. It's not. We're optimizing Lagos State's health financing landscape because the crux of the matter is all about health financing. That's the bottom line. And so we can't put a band-aid on the problem without going deep into the wound and find out what the wound is. And the wound basically is a fragmented sector, heavily reliant on subsidies, which is not encouraging for our professionals. If you are in a profession, you've spent 5 years, 6 years becoming a doctor or a nurse or whatever, another 5 or 6 years specializing, everyone knows how hard that is. And everything depends on subsidy. It's not encouraging, and that's the root cause of outbound migration. And so the government is trying to consolidate the sector, place it back into economic realities, make sure that it is a major contributor to the GDP, either directly in terms of health economics, but also indirectly in terms of ensuring we have a healthy and robust youth bulge, because that's really the currency of a sound economic pathway. And most importantly, applying the very sound principle of health economics, which is that supply will always follow demand. So you just make sure you can pay for health and pay for health properly, and the supply will appear. It's the invisible hand of the economy. You don't need to do anything else. Just make sure that Lagosians can pay appropriately for their health care, either through government insurance or through private insurance or through government subsidy, which is our responsibility. Government is not shirking away from looking after its vulnerable, but the workforce can drive a very healthy healthcare sector. And so Lagos has embarked on something called HFIRE. And HFIRE stands for the Lagos Healthcare Financing Reforms, financial reforms. And there's several compartments to it. I'm just listing a few. Improve allocation to health and improve the budget's performance. So this year, we went up by about 30 to 40% on last year's budget to address many of the issues that we're facing in Lagos. And any of you spend some time in Lagos, you will see some of the manifestations of this very encouraging expansion of the health budget in Lagos. We need to continue our dialogue with our donors and our developmental partners. What we're talking about in 3 is improved human resources for health ratio to population, which is the academic environment, efficiency and reducing cost of doing business through the digitalization of the health sector. And we've embarked on something called the SHIP, which is the Smart Health Information Platform. We're 50% of the way through the project, which is to totally digitalize the health sector the public health sector in phase 1 and move in phase 2 to the private sector. Very, very important that we do this because digital technology really has multitude of solutions to some of the deficits that we have. So the onset of computational analysis, deep learning, machine learning, and AI can help us. We are in the age of intelligence now. And so we can use intelligence to circumvent some of the shortages that we have if we think right and think smart. Our infrastructure is going through a massive transformation, renewable energy, low carbon footprint. We're stepping up our regulatory framework and our clinical governance. We're really, really partnering with the private sector and creating an enabling environment for the private sector to carry a significant load of the deficits. The government is not going to build the 500 hospitals that this state needs. We'll build maybe 5 or 10 and make sure that they are the standard. And we're spending a lot of time creating those benchmark infrastructures so that the private sector can't go below the standard of government. And if you see some of the hospitals we're building now in Lagos, they're very, very impressive. And then finally, the health insurance, the health financing framework to ensure that there are realistic funding flows. And the moment there are realistic funding flows within the sector, we know that brain drain will stop. And in fact, brain drain will change to brain gain because our diasporians and our friends around the world will find Lagos to be a place that they would like to be. And so the virtuous circle, restoring healthcare into the mainstream economy through restructuring of insurance, massive medical infrastructure transformation, use of digital technology to circumvent physical shortages, neutralize the brain drain phenomenon, accelerate and activate the brain gain, make more professionals, and attract our diasporians back and say, hey, what you were running away from has been fixed. You can come home now. And come home with all the expertise that you picked up for the 10, 15, 20, 30 years. We'll take it all. And 6, making Lagos the center for inbound medical tourism by empowering the private sector in particular. And on that note, I give you the greetings from His Excellency, the Governor, and the Deputy Governor of Lagos State, and our future medical students. Thank you very much.
Well, I'm sure we know we've heard a very innovative, a lecture about a very innovative plan for medical education in Lagos State. I must let you know that Lagos State must always be emphasized because they always like us to know this is Lagos. It's not, it's Lagos State. And I can see my sister also nodding. So this is Lagos State, even though the whole country is going to benefit from it, because if Lagos State can solve its problems, the rest of the country will rest. There's medical migration from the rest of the country to Lagos and Abuja, and then from Lagos and Abuja out. So if we can at least get Lagos State satisfied, then we will be able to satisfy the other countries. So thank you very much to Shakadan. I'm not sure, but I believe this is the first international time you're presenting it to an international audience. and he has graciously accepted to take a few questions. We shall keep it brief because we need to move to the next plenary briefly, and then the opening ceremony because the Honorable Commissioner has to leave. So we'll just take a few pressing questions, and I'll ask Professor Scott Emoapo to ask his question. Kindly introduce yourself because there are people online, and also for us to capture it in the our recording, which is going on to YouTube. Thank you very much.
Thank you very much, Professor Bayemi. I've had a few interactions with you in the past through AMPA, so I know him very well. Thanks for the... I want to find out, why did you leave out University of Lagos from your statistics, as if Luth doesn't contribute to the health care of the state? I mean, it's very important. That's number one. Number two, the population of Lagos is very dynamic. I mean, and this your insurance scheme, how would you account for the influx of people coming to seek better life in Lagos with the insurance scheme? It's very, very challenging, but I want you to elucidate on those points.
Thank you very much. Any other questions? Please introduce yourself.
Thank you very much, sir. I'm Dr. Adewusi Bibilari from Union Osun Teaching Hospital. Thank you very much, sir, for that presentation. I'm excited to be here, and I'm excited that Lagos is actually doing something to fix the problem of Japa syndrome. But what I wanted to ask is the issue of remuneration, because particularly for people in my generation, colleagues in my generation who are the UK, US, when we discuss, yes, aside from infrastructure, a major concern for them also is the issue of remuneration. And in all of these, just like you're saying, presently Lagos produces 100, Lagos Plascom produces 100 medical graduates, about 50% relocate almost immediately. So if we increase the number to 2,500, and we are still not fixing the issue of remuneration, are we sure that we're still going to retain the number and the problem will not persist? Thank you, sir.
Thank you. There is, yes.
Good morning, sir. My name is Victoria Olabisi. I'm a final year medical student. I just want to attest to what you've said, like as a beneficiary of the system, and I want to commend it as well. I've seen the waves. I've seen your administration has, had on us as medical students, and this is me attesting to it. And somehow I know through well that your projections would surely impact the next generation as well. Yes, but to get to that, I just want to ask what about the political space in terms of when the political wheels are changing. I mean, the powers are changing. What factors are in place currently to sustain it? Around this administration. Thank you very much, sir.
Right. One more question, and then we close. Yes.
Thank you, sir, for that presentation. My name is Aliban Jonet from College of Medicine, University of Ibadan, final year medical student. So I wanted to ask, there's been a lot of conversation around increasing the capacity of our training institutions, which is what you are also trying to do in Lagos State, which is quite commendable. But oftentimes when we have these conversations, we don't emphasize that the training does not particularly end in medical school, even in the undergraduate context. There's also the internship training, which is mandatory. And in the last 1 year that I've been monitoring the space, the internship space as a final year medical student, I've realized that it has become increasingly difficult for recent graduates to actually get internship positions. Now, speaking, I'm asking you now from a policy and also an academic point of view. When we increase training positions, we enhance medical training spots. We have more medical schools, and these medical graduates end up spending 1 year, even up to 2 years post-grad without getting internship slots, and then they will have to write their final exams again according to MDCN regulations. So what are the measures you are putting in place such that the expansion does not just end at the training at the 6 years, but we also don't get to struggle to land internship positions. Thank you, sir.
Thank you. I think we'll close it there unless there are other pressing questions. And I think it's for the next generation. They're the ones giving you the
heat. But thank you very much, Prof. Scott. I did mention that LASUCOM makes 100 and LUTH makes 100, so 200. And there's one more private medical school called Eco Medical School. So altogether, we make just over 200 doctors a year, and half of them typically migrate. When I first started my first tenure as commissioner, which was 7 years ago, I had a very, very close relationship with my colleagues at LUTH and UNILAG, and it almost caused a problem because my Lagos State University teaching hospital were complaining that I was romancing the other side. So I had to find a way of balancing my time between LUTH and LASUTH. But they're both great institutions. We're very grateful that they've been able to at least hold the ground. But something out of the box needs to happen if we're going to move the dial. And that is to use our assets to fill the gap as best we can. So your second question was around the very significant inbound migration of people into Lagos. And that is happening because Lagos is a very attractive place. It's the commercial hub of West Africa. People see Lagos as a land of opportunity. And so across the country where we have climatic aberration, we have competition for resources leading to conflict, people find Lagos to be that safe place. And so on a daily basis, there are about 2,000 to 3,000 people migrating into Lagos every single day. So that's why our population is going up exponentially. It's not as if our birth rate is that high. It's not actually. But the inbound migration is very, very significant. It's a problem. I can't tell you what the solution is, but one of the solutions to the insurance issue is that the law now says that health insurance of one form or the other is now mandatory. If we just say that, then that law is just a piece of paper. So in Lagos State's domestication of the national law in the executive order, we have incorporated elements of enforcement. So half of it reflects the law, and the other half reflects the enforcement. And so it's just a simple analogy. You want to buy a car, you want to put the car on the road, you need three things. You need a driver's license, you need an MOT, and you need a car insurance. And you can be driving along happily along the road, and a policeman stops you and say, "Can I see your papers?" And if you don't have those documents, you have a problem. And so similarly in Lagos, what we're saying is that if you want to be in Lagos, if you want to breathe the beautiful sea breezes of Lagos, if you want the huge commercial opportunities that this center, this mega city provides, you can do from your civic responsibility is to have an insurance in your pocket. And in any point of time you are engaging with government, you have to demonstrate that you have that. And so most people in Lagos have at some point a touch point with government. And it is at that point that we're going to demand. And if you don't have it, we'll give it to you on the spot. At least the most basic health insurance, which is called the social health insurance, which is a very, very nicely subsidized package, subsidized by government. And so we expect that through the massive public health campaigns around the benefits of pooled funding in terms of insurance, the benefits of what that can do for you and the state, and then the requirement of you as a citizen to own insurance, just like you have an ID card in your pocket. We're going to be changing the narrative because we're not really an insurance culture. And so we have to force it at the beginning until the citizens go through a reprogramming. And then they start to enjoy the fact that they are protected from catastrophic health expenditure by carrying one or two insurance packages in their pocket. And that really dovetails into the next question, which was by Dr. Adewusi. And you talked about remuneration. So what our rejigging of the health sector is trying to do around health financing is to structure particularly the private health insurance ecosystem, which at the moment is not operating optimally. And there are a number of reasons for that. And therefore, the providers are struggling. And so if we can get the correct premiums based on actuarial science for the economic realities, then the sector starts to see a profound uplifting. And that was what I was talking about when I said supply will follow demand. The moment you empower you to be able to pay for health, then it creates the demand that the sector will fill automatically. And so you might say, well, that doesn't really answer my question around remuneration. It does. Because ultimately, the improved remuneration packages through the pooled insurance processes is going to uplift the sector first in the private sector, and the public sector will follow. But most doctors in the public sector have time in the private sector. So you may be having a slightly, what you would consider compared to your counterparts abroad, a substandard remuneration package. But in the private sector, even now, it's happening. Some of the medical bills in the private sector are very impressive. And so if you're a doctor in Lagos, even if you've got one leg in the public sector and you have some sessions in the private sector, life is getting better. And so what we're trying to do is just change the whole appreciation for what you do as doctors and medical professionals. And that follows with the appropriate compensation financially. Victoria, you're worried about succession. Just vote for us. It's simple, yeah. To maintain succession in the current party, it's like a relay. You know, you watch 100 meters relay, one person hands the baton over to the next person and it just carries on like that. Let me just reassure you. I can see you have a little bit of anxiety. The moment the new university is established, it takes on an autonomous life of itself. All right. And government is committed to subventing that initiative. And we've done a fairly robust sustainability strategy. And so it will take on a life of its own. And there are some people in this room again who are involved in that to make sure that this thing carries on, whether I'm there or whether the party is there. It would be nice if the party is there, but even if it's not there, but it will be there, don't worry. It's not going to fall flat. It's going to keep rising as you've experienced as a student over the past few years. Things are going to get exponentially better for you as a medical student in Lagos. Dr. Adebanjo from UCH. You know, you asked one of the most critical questions because there's no point creating a bloated graduate process and you all come to a bottleneck. And that bottleneck we all know is internship or house jobs. And in Lagos, so this whole phenomenon, so as these 30 general hospitals become training facilities, their status starts to rise. And one of the things we've made mandatory in this whole process is that each and every one of those big general hospitals now must become, through accreditation with MDCN, have house job programs. At least 100 house jobs in each of our big general hospitals. So we recognize the bottleneck. The bottleneck is a little bit of an artificial bottleneck in Lagos because it's funny, medical students from all over Nigeria want to come and do their house jobs in Lagos. So we can't even fill our own students because everybody is coming from different states. And we keep asking them, why don't you do your house jobs where you studied? No, I want to be in Lagos. Okay, fine. Come to Lagos, but you might have to wait 9 months or 12 months before we can place you. But it is after this, it's not a successive plan, it's a parallel plan. We must increase our house job allocation. It must happen in parallel. We've got about 4 years lead because by the time we take in an increased intake in the next 2-3 years, it takes about 5 years for those students to come out. So in the 5-year gap that we have, we're not sleeping, we are thinking, and we know exactly what we need to do. And that's why we're going to make Lagos the center for medical professional training in Nigeria and in West Africa. And I think doing Lagos is produce human capital, and half of that human capital is exported. Yeah, that's our product. That's Lagos State's product. Some people export oil, some people export cocoa, we capital. Hopefully it comes back as chocolate in a very refined way. And we enjoy it when it comes back. So we're not scared of the export of human intellect because we know that they're going to come back, at least a significant proportion of them. And they're going to come back with a whole belt of experience that they're going to give back to Lagos State. So we don't see it as a loss. When there's a brain drain phenomenon, I mean, I drained out of Nigeria 4 times. People go out for different reasons. Some people go out to expand their knowledge base. Some people go out for adventure. Some people go out for improved remuneration. Some people go out because they just want something different. But ultimately, I know Nigerians all over the world. Being a diasporian around the world, there's one thing we do on Sunday. We all meet in somebody's house and we eat our local cuisine, whether it's pounded yam or ebaf. Those of you that are visitors, we're going to indoctrinate you with the local cuisine. They have been, so you know what I'm talking about. We sit and the one conversation in the Nigerian associations is, I want to go home. I want to go home. And so all we have to do is make it possible for them to come home. And it's a bigger picture we're talking about here, making Lagos a place that our professionals want to come back to. There's no place like Lagos. This is Lagos. And there is something in the air at the moment. If you come here from November to February, you will know what I'm talking about. There is a massive influx of people into Lagos. We call it Dirty December, but it's a cultural phenomenon that's going. People just want to be in Lagos. And it is extending now into the professions, which is particularly the medical profession. And I think all we have to do is just keep on the trajectory and it will happen automatically. Thank you very much for questions.
Thank you very much, Honorable Commissioner. I think we've been well fed, and our guests will now understand why they had to have pounded yam yesterday. Just a little announcement. You have the program in your hands. We've had to alter today's program because the Honorable Commissioner and the representing the Governor of Lagos State has to leave shortly, but he'll wait just for us to do a few things. And so we've moved things around. So I crave the indulgence of the Honorable Commissioner to allow us to have a follow-on the plenary, because the follow-on plenary speaks to what he's been addressing, which is medical migration and its effect on medical education in Africa by Professor Alaudin, who is the Dean of the Faculty of Medicine, Khartoum. After that, we are going to move on to the opening ceremony. Because of the time that we have spent, we are going to utilize the tea break to cover up this time that we've gone over. But I promise you, you'll have both tea break and lunch together. And please, you have to have both. We've paid for it. So it'd be nice for you to eat it. And Marriott doesn't do takeaways. So we'll enjoy both tea break and lunch together. So may I invite, with great pleasure, Professor Alaudin.
Okay, hello everybody, and thank you very much for the invitation. And I'd like to talk about immigration and its effect on the academia in sub-Saharan Africa. And if I by said that we don't have to worry about the figures, because I think the figures are not very bad when I research this. And I think it's reassuring that there are solutions to the problem, and I think people would be coming back. So I think this is reassuring to everybody. And I think people should continue on the plan to train people, because I think we don't lose anything by training people, and they're certainly going to come back. So do I have a remote to advance my slides? Thank you very much. Right. So these are just disclosures that I don't have any financial conflict of interest. And I have to admit that, as we all of us do these days, I have used AI in preparing some aspects of this talk, especially in relation to literature searches, because we know that AI facilitates this very much. So the figures. Now, if we look at this, I think this is very true that it's from 212, but I think it's very impressive. Study medicine in Africa, 1/5 of them outside Africa. Now, the other important part of this is that more than half of those who stay in sub-Saharan Africa would be practicing in medicine in urban areas. And I think you have to take this into account, because if you like, this is internal immigration. So it's really very important. And very, very few people, as you can see from this, actually go to practice medicine in rural areas. And I think that when we talk about the reasons for immigration, and if you want to address the reasons and solve the problem, then you have to address the causes for it. Now, this problem is increasing, as you can see from the figure. So what are the reasons that make people leave sub-Saharan Africa after they've studied medicine? It's financial. There is no doubt about that. It's working conditions. Political stability in Africa is a big problem. Underinvestment in the health education, and we've just heard a very ambitious plan to invent in health education, and I think that's really a good thing. career progression, and I think in the ambitious plans that we've just heard, career progression is being addressed in a very scientific way, and management support as well. So these are the things that drive people out of Africa. And indeed, there are push factors, people getting out, and there are pull factors, people being kept to stay. And the whole political machine is geared towards balancing push factors to pull factors, so we can achieve a balance between the two and retain our graduates in medicine. Now, overcrowding and training is a big issue in making people leave. Limited residency slots, poor supervision, inadequate indication of structure. The thing that make people attracted to other parts of the world is a better training, environment, financial issues, safer working conditions, and clearer training pathways. And I think any plan to address the issue of people getting out of Africa should address these and get a balance between what pushes people out and what attracts people to other parts of the world, because that's the key to solving the problem. Now, I think this is very interesting. Now, if you look at the African medical school staff and you look at what happened to these staff, you would notice that about 1/3 of academic staff in African medical schools would have left the medical school because they've moved abroad. And obviously this can have an impact on the education of medicine in these medical schools. Now, this would affect certainly teaching capacity, specialist training programs, research output, which I think is a very weak area in Africa, and leads to overburdened remaining faculty staff. And I think this is, we all notice this. I work in academia. So if somebody leaves, the work is not going to go away. So somebody has to do it. And you just notice that you're overwhelmed by the work that has to be done because it's not going to go away. It is extremely difficult in my institute when we lose academic staff is to get locum people to come and do the work. That is just almost impossible. And I think that's probably true for the rest of the African countries. And again, if we look at these two slides, which I think is very, very interesting, and we talked about memory in academia, because when people move, then the memory of the academic institutes is lost. So if you just look at the graph on the left-hand side, left-hand side, you would notice that in some of the medical school, especially in East Africa, there is more than 100% replacement of academic staff. That is true for West Africa as well. The figures are not very bad for South Africa and Central Africa, but still they are bad enough. And this is just borrowed from the previous slide. The figures on the right-hand side is that 1/3 of these people just leave Africa. Now, it is very interesting that private practice does not absorb a lot of the people who leave academia. And I think this is very important. And I think the reason for that is that people can do a combination of both. And there was a notion in my country, for example, is to discourage people in academia to do private practice. And that was not a good idea at all, because that made people leave medical schools. But when they were encouraged to stay in medical schools and do private practice, things were quite well. And I think these are very much supported by the figures I have shown on the right-hand slide. So this is another important thing. So the impact on clinical training, understaffed facilities, fewer supervision for research, reduced exposure to complex cases, and increased reliance on foreign volunteer staff. Now, in my country, almost 100% of the volunteer staff come to work in rural areas because these are very badly understaffed. And it is very, very difficult to convince graduates of medical schools to go and work in these areas. And I think I've shown the figures, very convincing figures, on the first slide that I have shown. And that's why you get volunteer foreign workers to come and work in rural areas. There is disrupted continuity of training, which is quite evident, and lower quality of care, of medical care. So the impact of immigration is pretty negative, and I think it's just shown by these figures. And the other thing is the curriculum, because I think medical schools have to evolve. And I think one of the important evolution of medical school is to pay attention to curriculum, and that has to be amended and changed continuously in order to attain the objective of the medical school. So institutional memory, and I think I've shown you on the previous slide, that the 10 people leaving some of the medical schools in West Africa is more than 100%. So how can you maintain the memory of the medical school if your staff over 5 years change by 100%? Obviously, there is nobody to preserve this memory for this length of time. And I think the other very difficult issue is that, again, in my country, it is almost impossible to be able to do a sub-specialization in a field of medicine, it be surgery, obstetrics, and gynecology. We don't have many problems, just people practicing mainstream medicine, but establish a gastroenterology, for example, you would find that extremely difficult because you cannot sustain staff to do these things. And I think this is one of the deficiencies that we see time and time again. Now, people have tried to establish centers of excellence, tertiary referral centers, where these people can come to, but the problem with sustainability of staff, you can recruit staff, people who've been very well trained, but to make them continue to work in these centers just proves to be totally impossible. So how can we solve this problem? And I think, the points that I mentioned there are very important. And I think these have come from the very first and second slides, which have shown clearly the causes for people leaving Africa. And I think if you can address these, you can probably be able to keep people in Africa. Now, bilateral agreements for ethical recruitment, and this is a WHO thing, which I will show you in a minute, which has been there since 2010, but it doesn't work because, people just leave the country. You cannot sort of, organize it as being negotiated between different institutes in different parts of the world. In my country, a very significant proportion of medical staff immigrate to the Middle East because they speak the language and because they're very, very well paid there. And it is just impossible to have agreement with rich Middle Eastern countries that would limit the immigration of his staff. Now, people may think this immigration is for a short period of time. That is not true. I think most of the people from my country who went to Middle Eastern country to work, they've been there for 30, 40, or 50 years. And most of them, they have retirement posts in private hospitals because they are very experienced and they would not want to leave the country. For example, transplant surgeons. I cannot think of a single transplant surgeon, mainly kidney transplant, because kidney disease is a big problem, who's left the country, who's come back. And even when they retire, they immediately get offered posts by private hospitals because of the expertise that they have. So this is a problem. Retention incentives. I think that's something that people should think about. Investment in medical education infrastructure. And I think we've heard some good news about that this morning. And regional training hubs to reduce external migration and monitoring system for workforce flows. Now, this is the WHO document, which has been in place since 2010. I cannot think of a single case that immigrated from the country through an agreement between the government. And obviously, most of these people went to free medical school that offered very high quality medical education. But when they decided to leave, they just left because you cannot enforce these agreements between the government and international governments. They just exist on paper, but they are not implementable. So medical migration is a major driver of loss of education capacity in Africa. The effects span faculty shortage, training quality, and stability of the system, especially in terms of resilience. They can, at least in theory, be addressed, but I think I'm yet to see this implemented in real life. And the brain drain can be mitigated, but requires coordinated regional and global agreements. And I think this is to enact legislation that already exists. But obviously there are so many logistic difficulties to enact them. So this is just some bibliography on the issues that I've talked about. I think especially the publication by Chen et al. I think this is a very, very good study that is being done looking at the retention and immigration of medical staff in Africa. It's been quite a while ago since it was published, and I think it's about time that somebody repeated this study just to see what the trend is now. So I think this is really important. So I can just leave this for a minute and then just conclude by showing you a picture of my medical school that was opened in 1924. So that's 102 years old. That's the third oldest medical school in Africa. I think we're only preceded by Cape Town and Cairo University. Thank you very much indeed.
Thank you very much, sir. Another round of applause for him. Okay. Do we want to take one or two questions, Max? One, if there's any. Okay.
Thank you so much. This is Naz Kamat from University of Toronto and also a graduate of the University of Khartoum. My question is about the diaspora as a brain gain. A lot of the time when the diaspora wants to engage with their alma mater or other universities, there's a lot of difficulties related to very rigid structures of hiring. For example, it's very difficult to get adjunct faculty position that will allow you to take time off and come and teach, or academic placement or visiting professors. Occasionally, these are given to different races. Not you. Occasionally, that you're from Africa, but you're looked upon as inferior to someone who was born or raised in the West. So what do you think some of the measures that African universities can take to enhance drawing the diaspora home?
Thank you. Any other? Okay. So I'll let Prof do that.
Well, thank you very much. I think that's a very important question. I think that very much depends on the leadership of the medical schools when they think right about these things, because obviously these are expertise that you can attract to come back to the country and contribute to them. Dare I say, Nazik, that when I became dean, I invited you to come and teach oncology in the medical school. Is that true or not? Because we just had extreme shortage in people teaching oncology in our medical school. And I thought that you being the graduate of the medical school, you should pay some of the debt back by coming back and teaching oncology, which you did. Thank you.
Thank you very much. Another round of applause for him. Okay, so very quickly we want to officially open this conference and before the commissioner takes his leave. So please, ladies and gentlemen, may I crave your indulgence to please all rise to your feet, stretch your legs, stretch your arms. So we can do some practicing of what we preach all the time. Make sure you're stretching a part of your body. Stretch any part of your body you want to stretch now. Okay, now if you've done that, may I, as you remain standing, ask that we take the Nigerian national anthem so that we officially open this session. Okay, thank you. So, please take your seat as we continue in the program. Ladies and gentlemen, so we can fulfill the mandate of Professor Laukwat, which is to combine our tea break and lunch. And the water for the tea is getting cold anyway. So probably have to warm it again. So ladies and gentlemen, I would like to invite the AMSA president to quickly just welcome us officially to his program so that we can run along. So a big round of applause as I welcome the AMSA president to give us the welcome address. Professor, give me a round of applause for him.
Thank you very much. Good afternoon, distinguished ladies and gentlemen. I will have to establish some protocol here because we know that there are some people online from governments and from other parts of the world. So I begin by acknowledging His Excellency Bola Ahmed Tinubu, CFR, President and Commander-in-Chief of the Armed Forces of the Federal Republic of Nigeria, Dr. Maruf Olatunji Alausa, Honorable Minister of Education, Federal Republic of Nigeria, Professor Mohammed Ali Pati, Honorable Minister of Health and Social Welfare, Federal Republic of Nigeria, Mr. Babajide Olushola Sanwo-Olu, Lagos State Governor, represented here by his Commissioner, Honorable Commissioner for Health, Dr. Akin Abayomi, and who is also here in his own capacity, Dr. Mohamed Yakub Janabi, Regional Director for Africa, World Health Organization, Dr. Ricardo Leon Bequez, President, World Federation for Medical Education, Dr. Tolani Sule, Honorable Commissioner for Tertiary Education, Lagos State, Professor Kayode Adibowale, FAS MNI, the Vice Chancellor of the University of Ibadan, from where I come from, Professor Folashade Tolulope Ogunshola, FAS, the Vice Chancellor of the University of Lagos, our host here, Professor Ibiyemi Olatunji Bello, MNI, Vice Chancellor, Lagos State University, co-chairs and members of the local organizing committee, distinguished guests, colleagues, ladies and gentlemen, students as well. It is with a profound sense of duty and great honor that I welcome you on behalf of the three hosting institutions, the Universities of Ibadan and Lagos and the Lagos State University, to this landmark AMSA Medical Education Conference 2026. I most sincerely welcome all our dignitaries, political leaders, representatives from the WFME and World Health Organization, other regional medical associations and global medical education networks, national and international regulatory bodies for medical education and medical practice, health sector policymakers, medical school executives, national and international resource persons, medical school faculty and students, and all others who are gracing this opening ceremony, and those who will continue throughout this conference. The conception of the Association of Medical Schools in Africa, AMSA for short, took place in 1961 at the University of Ibadan, and it became formally inaugurated in Kampala in 1963. Since then, AMSA has facilitated networking and exchange of ideas and experiences between its medical schools through its meetings and exchange of faculty and students. As a leading voice for medical education in Africa, the association is committed to strengthening our institutions and reinforcing the vital nexus of research, education, and service. This conference marks a defining milestone in the rebirth of AMSA, a process that began in 2008 following the Sub-Saharan Africa Medical School Survey and was further strengthened in 2014 through collaboration with the WHO Africa region, the World Federation for Medical Education, and the World Medical Association. Through the dedication of the interim executive, AMSA has been reestablished as a corporate entity and has regained its rightful place as a representative of the African region in global health systems. Although this conference was originally scheduled for 2020, unforeseen disruptions, including the COVID-19 pandemic, and more recently, ongoing geopolitical tensions posed significant challenges. Yet, drawing on the resilience and lessons of the past, we adapted. The adoption of a hybrid format has enabled broad participation despite these constraints. The overwhelming support from our stakeholders is a testament to our shared commitment, and for this, we are deeply grateful. I invite you to join me in recognizing our dedicated local organizing committee, our long-standing partners, the WHO Africa region, the World Federation for Medical Education, our steadfast supporters, including the Federal Ministries of Education and Health of Nigeria, the Medical and Dental Council of Nigeria, the National Universities Commission, FEMA, Intel, ACGME Global and International, and the Nathaniel Oidu Foundation. Your collective efforts have made this gathering possible. Distinguished colleagues, Africa stands today at a critical crossroads in healthcare, education, and practice. While our continent bears nearly 24% of the global disease burden, we are supported by only 3% of the world's health workforce, many of whom are migrating or considering migration, as we have heard. This has resulted in a projected shortage of 6.1 million health workers by 2030. This reality demands urgent and decisive action. We must move beyond traditional paradigms and embrace a bold agenda, one that focuses on planning, training, and retaining our health workforce. Our conference theme, Increasing Capacity and Retention of the Global Health Workforce, is therefore not a mere statement. It is a mandate. Over the coming days, we will critically examine systemic inefficiencies that leave 27% of skilled professionals unemployed, while communities remain underserved. More importantly, we will advance practical and sustainable solutions. This gathering is also a call to transform medical education in Africa from a system centered on qualifications to one grounded in competence. It is clinical excellence, ethical judgment, and practical readiness that ultimately save lives. I urge each of you to participate actively, not as observers, but as change agents. Engage deeply, exchange ideas, and build meaningful collaborations with the global community of experts, policymakers, and innovators who are present here. The future of health education in Africa depends on our collective resolve. AMSA recognizes the magnitude of the task before us. Strengthening Africa's health systems requires collaboration, partnership, and sustained commitment. We cannot do this alone, and we are proud to acknowledge partners who are already contributing significantly to this shared goal. While the work ahead is serious, we also encourage you to experience the vibrant culture of Lagos. The richness of its heritage, its cuisine, and its dynamic social life. Your Excellencies, distinguished colleagues, dear students, I wish you a productive conference and a memorable stay in Lagos. Thank you.
Thank you very much. A round of applause for him. Okay, so there is something to explore in Lagos for all our guests. Make sure you So there's a lot to explore, and I think at the dinner yesterday you got some spicy meal. Many more before you go. So, ladies and gentlemen, we heard from the president, and like he has mentioned, we have 3 institutions actually co-hosting this event, and I would just like one of our hosts, the representative of the hosting institution, to also give us a welcome. So, ladies and gentlemen, welcome with me, Professor Femi Fasomade, as he gives his welcome.
Thank you very, very much. In order to save time, I will want to stand on the existing protocol so that we can move on very, very fast. So our chief host for today, the Commissioner of Health, Dr. Abayomi, and all the other executive of the WFME and AMSA, I use this opportunity to greet and welcome each and every one of us to Lagos. Lagos has that appellation that it is the only place that when you arrive to, we say that this is Lagos. Other places, you say, welcome to so-so state, but here, this is Lagos. And as people often also refer to Lagos, Lagos is a city that is bigger than a state, and it's bigger than a country, and has the economy that is larger than some regions in the whole of West Africa. So Lagos is a very, very important place. I'm representing the Vice Chancellor of the University of Lagos, which is the nation's pride and the first choice institution in the whole of Nigeria. Yes, usually I hear the ha's and the ho's, especially when there are people from other schools, because in Nigeria there is just one and then the others. So University of Lagos is that one. So I'm representing Professor Folashade Ogunshola, who cannot be here because of the exigencies of our duty. Yeah, with the Provost of the College of Medicine having a special meeting, an emergency council meeting, so that is why they are not here. So I convey their greetings. I don't have a speech that was written by either of them, but she expresses her desire that she would have loved to be here in person, but hopes that you will accept her apologies, and also hopes that you will take advantage of the diversity in Lagos, the sites of Lagos, and for those who will be staying over up to the weekend, we also welcome you to take a tour of the University of Lagos and also the Lagos University Teaching Hospitals, which are very, very important landmarks in Lagos. Also, you can visit LASU, you can visit LASUCOM, and you can visit LASUP. But all of these institutions, they are scattered in different parts within Lagos, so you need a local guide because you cannot visit all of them in one day. So you might have to either throw the dice or you might just decide to take one or two of these. And if it's only one institution you can visit University of Lagos. I'll be your tour guide. So with that, I think my duty now is just to quickly make sure that we take advantage of the presence of the Honorable Commissioner of Health of Lagos State. We are going to invite him to the podium so that we can do the investiture of him as our chief host, and then he will also now do some other duties that have been assigned onto him before he goes for his next assignments. We also have some photographs with some specified dignitaries. I hand over to my co-host to also help in that. Thank you.
Thank you very much, sir. Ladies and gentlemen, distinguished guests here present, we'll do this for one of the best performing governors in the Federal Republic of Nigeria. I thought somebody wanted to clap. Okay, so I didn't make the disclosure. I don't work in Lagos. I'm not an indigene of Lagos. I don't get paid by the Lagos state government. So if I've said that he's one of the best performing governors, it means yes, he's one of them. And I'm sure we miss him here today. He's somebody that would actually walk into this room himself and relate with everybody. So ladies and gentlemen, once again, a round of applause for His Excellency, Babajide Olúṣọlá Sanwo-Olu, the Executive Governor of Lagos State, as represented this afternoon by the Honorable Commissioner for Health, Professor Akin Abayomi. A round of applause for him. And I please your indulgence to step forward, sir, as I invite the president of AMSA and also the co-host, Professor Fasomade, will be doing this investiture of the governor as represented this afternoon as a patron for AMSA. And this is because we acknowledge his contributions to the association and also to the medical education generally. So ladies and gentlemen, welcome with me, Professor Temidare Ogundiran and Professor Olufemi Fasomade as they do this investiture.
This is highly symbolic. And yes, it's a pleasure for me to be performing this task this morning of putting this around the neck of our governor, represented by his Commissioner for Health. Not just for hosting us, but also in appreciation of the commitment of the government of Lagos State to medical education in Nigeria as well as in Africa. So on behalf of the Executive Committee and all members of the Association of Medical Schools in Africa, it's an honor to put this around your neck. That's our chief host. Thank you very much.
Thank you, sir. Just before he responds, can we just quickly take the photograph with him so that he can then give his response? You want to take it outside? The pictures? Okay, so let me give the governor opportunity of responding and then we'll take the photograph outside.
Let me first acknowledge with gratitude the hosting organizations, the University of Ibadan, the premier university of Nigeria, the University of Lagos, which started after Ibadan. My good friend is the vice chancellor of that university. We actually started life in kindergarten together alongside this young man here. We used to walk with our water bottles across in kindergarten at a very, very important primary school. So I miss Professor Ogunshola at this event, but I'm sure she's otherwise engaged. And to the Vice Chancellor of Lagos State University, my very good friend, Professor Ibiami Ibilola Olatunji Bello, who has the singular honor of being a university that gives birth to another university in the creation of a autonomous University of Medicine and Health Science. I think that's an accolade that she will keep as her legacy for years to come. And to the Association of Medical Schools in Africa, AMSA, thank you very much to the president who gave that wonderful citation. And of course, to our very special guests here, Professor Mohammed Yaqub Janabi of the WHO, and from the World Federation of Medical Education, Professor Ricardo Leon Marquez. Thank you very much for coming to Lagos on this very important conference that really, as you can see from the data, we are in a state of crisis, and it won't be business as usual if we're going to catch up with the deficit that we experience. We need to think outside the box. We need to be creative, and we must find a solution. There is no other way. I hope, and we are very appreciative that you've chosen Lagos to have this very prestigious conference. And I hope that you'll be able to continue your meetings on an annual basis and not have the periodicity of your conferences interrupted by pandemics, outbreaks, or even threats of war. You have a very serious mandate, and that is the dialogue around the crisis that we're experiencing. We heard our colleague from Khartoum explain some of the fundamental principles that lead to the problems we're experiencing. And I know that for sure because I've met several graduates of that prestigious university in many parts of the world. You produce, like other universities in Africa, you produce students of exceptional caliber. And it's not difficult for the rest of the world to snap up these professionals. We only pray that some of them will come back. And we only pray that in the future, that excursions out of Africa will diminish. And the only way that can happen is through these collective networks, these robust conversations that unpack the problem, but don't stop there. You prefer the solutions, and you become advisors to the policymakers, because that is what matters. You can go around the world and have your conversations and talk to yourselves, and that is the difference between academics and policymakers. That divide must be broken down, because everything you do must translate into policy. Otherwise, it's not worth doing. If it ends up in a PhD or in an article or in the proceedings of a conference like this, and it goes onto the shelves and the archives of museums of information and does not translate to reality, then you've done nothing. So I implore you that of the proceedings of this really important conference, that you translate them into policy directives that we as policymakers can take and translate into reality. And that you continue to dialogue amongst yourself, but don't forget, you must dialogue with policymakers. as an academic for several decades. I think back now as a technocrat and as a semi-politician that I spent 30 years meeting the same people around the world talking about the same thing decade after decade. Because I'm a hemato-oncologist, so I go to the American Association of Oncology and Hematology, the British Association and the Africa Association, and you know yourselves. And every year you meet at these events around the world and you keep talking to yourselves. And I've learned that it is very, very important that you are able to communicate with policymakers. And somewhere in your conferences and in your dialogues, you must create that opportunity. When you invite policymakers to events like this, you notice that they don't stay for the whole event. They can't. It's not possible. But you must find a way to take the proceedings in a way that is understood by policymakers and help them translate that into policy, legislation, and translational impact. So that's my charge to you as I take this opportunity really to, first of all, again, to congratulate you. I know what it takes to organize a conference, an international conference. You've chosen one of the most prestigious hotels in Lagos, so it obviously indicates the caliber of your thinking. You've chosen the most exciting city in Africa. You've chosen the most progressive government in Nigeria. And you've chosen the most beautiful mega city of aquatic splendor that we call This is Lagos. And on that note, on behalf of the people of Lagos, on behalf of the Executive Council, and on behalf of my friends, my colleagues, our visitors, one member of my family that's here as well, I take this great honor to declare this conference open.
Thank you very much, sir. A round of applause for him. So, ladies and gentlemen, we take a good photograph with His Excellency. We'll be going for a lunch and tea breaks in the other rooms, but please, the photographers will lead us and we'll take the pictures in this order. The president of AMSA, out on the, yes, we'll take after the instructions. Yes, so the people that will join us for the pictures, president of AMSA, the AMSA executives and trustees, the president of WFME, the vice president of WFME, the World Health Organization team, and the FAMSA representative. So please, you join us outside. And so may I please ask that we all rise and to take the third stanza of the Nigerian national anthem. First, okay, let's take the first, if you have the first, yeah. No, that's first and last. Let's take the first. ITU.
My feet
All tribes and tongues may differ. Children's all to serve us all. Thank you very much. So those listed, please join us. Lost is our bar to honor. How do this mean? Our children upon our way downstairs. Thank you very much. So the aforementioned, please join us upstairs for the group photograph. The President AMSA, the AMSA executives and trustees, the President of the WFME, the Vice President of WFME, the World Health Organization team of FAMSA representatives, so that we take a picture with Patron before he takes his leave. So others can please make your way to the tea table, get your tea break and lunch, and we converge in a moment.
Think about the generations and to say we want to make it a better place for our children and our children's children so that they know it's a better world for them and think if they can make it a better place.
There's a place, your heart, and I know that it is love. And this place is much brighter than tomorrow. And if you really try, you'll find there's no need to cry. This place, feel there's no hurt or sorrow. There are ways to get there if you care enough for the living. Make a little space, make a better place. Feel the work. Know why? There's a love that cannot lie. Love is strong, it only cares for joyful giving. We try, shall see this bliss we cannot feel. There are two, stop existing and start living. It feels their way. Something that folks growing. Make a better, make a better world. Feel the work. Shining in my deep strength. It's very crucified soul. It was plain to see this was heaven. We fly so high, let our spirits never die. By Feel you on my bruise. Create a world, no fear. Together we'll cry happy tears. See the nations turn their swords into plowshares. We can bring us there if you get enough. Make a little space to make a place. Here what is a better place. Where I you the world we live, sing for our children.
think about the generations and to say we want to make it a better place for our children and our children's children so that they know it's a better world for them and think if they can make it a better place.
There's a place, your heart, and I know that it is love. And this place was brighter than tomorrow. And if you really try, you'll find there's no need to cry. This place, feel there's no hurt or sorrow. There are ways to get there if you care enough for the living. Make a little space, make a better place. Hear the word for you. Know why? There's a love that cannot lie. Love is strong, it only cares for joy, forgiving me. We try, shall see this bliss we cannot feel. Here are true, stop existing and start living. It feels their ways, nothing up for us growing. We can't pick up the road. Here for Sparks my soul. It was plain to see this was heavenly. We fly so high, let our spirits never die. I feel you are all my brothers. Create a world, no fear. Together we'll cry happy tears. See the nations turn their swords into plowshares. We can bring because there. If you get enough, make a little space to make a place. Here the
think about the generations and to say we want to make it a better place for our children and our children's children so that they know it's a better world for them and think they can make it a better place.
There's a place, your heart, and I know that it is love. This place much brighter than tomorrow. And if you really try, you'll find there's no need to cry. This place, feel there's no hurt or sorrow. There are ways to get there if you care enough for the living. Make a little space, make a better place. Feel the world. You can run. There's a love that cannot lie. Love is strong, it only cares for joy, forgiving me. We try, shall see this bliss we cannot feel. Here are truth, stop existing and start living. It feels that way, nothing up for us growing. World, a better world. Heal the world. It's the crucifying soul. Though it's plain to see this world's failing me. We fly so high, let our spirits never die. My heart, feel you are my birthright. Create a world, no fear. Together we'll cry happy tears. See the nations turn their swords into plowshares. We can bring we get there if you care enough. Make a little space to make a bonus. Kill the
Time when we heed a certain call, when the world must come together as one. There are people dying when it's time to lend a hand to the them ready. Can't go on. Wagon fire. You know what I don't see. But all right. Fly me to the moon and let me dance among the stars. Let me know what spring is like on Jupiter and Mars. In other words, hold my hand. In other words, baby, kiss me.
Song, let me sing forever. You are all I please be true. That's
You hear me? I'm talking to you across the water, across the deep blue ocean, under the open sky. Oh my, and baby, I'm trying.
Boy, I hear you in my dreams. I feel you whisper across the sea. I keep you with me in my heart. You make it easier when life gets dark.
Lucky I'm with my best friend. Lucky to have where we lucky to be coming home. Lucky we're in love every way. Lucky to stay where we have stayed. Lucky to be coming home someday. Friend, lucky to be where we have been. Lucky to be coming home. So let me sing forever you want. Tell me I'm the lucky one. You put your at the door. Dream is a wish your heart makes when you're fast asleep. In dreams you will lose your heartaches. Whatever you wish for, you keep. Have faith in your dreams, and someday your rainbow will come smiling through. No matter how your heart is grieving, if you keep on believing, the dream that you wish will come true.
Dreams can come true. It can happen to you if you're young at heart. For it's hard, you will find to be narrow if you're young at heart. You can go to extremes with impossible schemes. You can laugh when your dreams fall apart at the seams. And life gets more exciting when it gets and life
It's your heart melting, it's just in dreams. You will lose your heartache. Whatever you wish for, keep a dream. And someday your rainbow will come smiling through. No matter how hard it's screaming,
if you keep on believing.
the dream that wish will come true.
That's falling in love. Why shouldn't we fall in love? Our hearts are made of faith, as they could change it. Why be afraid of fate? Let's close our eyes and make our own paradise. We don't know it, still we can try to make it go. We might have a each other to be or not to be, let our hearts discover. Let's fall in love. Why shouldn't we fall in love? Now is the time for it while we are young. Let's fall in love. That's falling down. Why shouldn't we fall in love? Our hearts are made of fate, let's take a change. Why be afraid of fate? Oh, well. Let's close our eyes and make our own paradise. Little don't afraid, still we can try to make a go of it. We might have been meant for each other to be or not to be. Let our hearts discover. Let's fall in love. Why shouldn't we fall in love? Now is the time for it. For young, let's fall in love. Let's fall in love. Oh, let's fall in love. Let's fall in love. When time falls in love, it will be forever around ever fall in love. Okay. The rest is work like they say. Love is ended before it began. And too many want to breathe. Moonlight kisses seems to cool in the warmth of the sun. Yeah, angels. I feel it now. Yeah, I'll give my heart and I can let you feel. Love is the you need. Oh, when I fall in love, right now, it will be forever. Alright, never fall in love. Yeah, sing it now. It's your dress. This is
Love isn't good before it's begun.
and to I
It says
it's true. One that's on and I can heart with because you are waiting.
I'll never
Now keep
my heart.
heart.
But
I can fly you through back with you.
oh,
I will sleep, and so I face the final curtain. My friend, I'll say it clear. I'll state my case of which I'm certain. I believe the life that's full I family and every holiday and more, much more than this. I did it my way. Regrets that I would, but then again to move the mountain. I did what I had to do and saw it through without exception. I found each other call, each goes along the valley, you know, much more boundaries. I did it my way, my way. Yes, there were times I'm sure you knew when I beat up more than I could chew. About to when there was still I ate it up and sweet it up. I face it all and I stood up. Yes, did it my way, my way. I'm sure you do. When I get off, won't bet you choose. Bob through it all, when first down, I ate it up and spit it out. I'll face it all, and I stood up and did it my He's a man. What has he got? Not himself. That he has not to say the things he truly feels. And I of one who lives, the record shows. I took the blows and did it my shows.
There are times when there are times when my feelings can't see the places where you belong, but you will find that
There is a purpose. It's been there within you all along.
When you're near it, you can almost hear it.
It's like a symphony. Just keep listening and listen.
Let it ring out as you discover who you are. Others around you start to wake up to the sounds that are in their hearts.
It's so amazing what we're all freeing.
It's like a symphony. Just keep listening and listen.
That you feel in those bills. It's like a symphony. Just keep listening, and pretty soon you'll start to figure out.
There are times when you might feel aimless. You can't see the places where you belong,
But you will find that there is a purpose. It's been there within you all along.
When you're near it, you can almost hear it.
it's like a symphony. Just keep listening and listen. Sounds to hear to everyone.
Let it ring out as you discover who you are.
Others around you start to wake up to the sounds that are in their hearts.
It's so amazing what we're all freeing.
It's like a symphony. Just keep listening and listen to it.
You feel
Okay, thank you. Ladies and gentlemen, I'm sure you had some nice lunch and we should be ready to go now. I hope you had enough coffee to take so that you don't have this postprandial sleep that goes with it. So we're starting in earnest. I'll just get off the microphone. Please kindly get a good seat for yourself. We're on the plenary, one more plenary session, and then we go for the panel discussion and the parallel sessions after. So we'll just wait for our lecturers to step forward into the room, and I'll be back so that we can start the plenary. So in the meantime, we'll continue with the music, and I'll be back in about 3 minutes to start. Thank you.
About the generations and we want to make it a better place for our children and the children's children so that they for the world think they can make it a better place.
The place your heart, and I know that it is love. This place was brighter than tomorrow. And if you may try, you'll find there's no need to cry. This place, feel there's no hurt or sorrow. There are ways to get there if you care enough. Make a better space. Love that cannot lie, strong, only cares for joyful giving. We try, you'll see, this bliss we cannot feel. Here are dreams of existing and starting living.
So thank you all for your patience, and for those of us online, thank you for that patience. We had to move around and take care of the GI tract. I want to welcome us all back, and we'll be moving straight into the plenary. And this time around, we'll be talking about professionalism in medical education curriculum, something that will fascinate all of us, and something that we're going to learn a few new things about this afternoon. Ladies and gentlemen, with a warm applause, please make welcome to the microphone our speaker for this plenary, Dr. Ajovi Scott Emapo. A round of applause for him as he steps forward. Let's clap for him. Let's clap for him. You're welcome, sir.
Where are the who is doing the where do you advise? Good afternoon. This is a very difficult time to give a talk after everybody is in a state of contented stupor. But it's all right. One of my colleagues said I should tell the students that if you dare fall asleep, you are going to repeat the rotation. So you better stay awake. Anyway, professionalism has been one of my pet subjects, other than the issue of ethics, which was copiously dealt with yesterday during the virtual workshops. And so I have thought about the issue of professionalism extensively, realizing that professionalism is not absolute, it is relative. So what is professionally tenable may not be professionally tenable here. Even within the same ecosystem, what is professionally tenable in one institution may not be professionally tenable in another institution. But there's got to be a basis, got to be a basic platform upon which all of what we think about professionalism arises. And that is what I'm going to try to present today, to see whether this is something we need to include in our teaching. Well, I have no relevant financial conflicts of interest, so nothing to disclose. All of us here probably have taken this oath. We call the Hippocratic Oath, which is an ancient ethical code for physicians. And this code emphasizes principles like non-maleficence and confidentiality, and it remains a cornerstone of medical ethics today. So all the talks about ethics yesterday all centered around what this oath tells us. This oath is credited to Hippocrates, who is believed to be the father of modern medicine, although there's a lot of dispute as to whether he really started this or not. As David will say, tell me tomorrow. It is oldest known binding documents in history. For centuries, a guiding principle for all medical practitioners. This oath outlines several fundamental ethical principles that physicians are expected to uphold. And these principles include, as I said earlier, non-maleficence, which is the obligation to avoid causing harm to your patients. It includes beneficence, which is the commitment to act in the best interest of patients and provide beneficial treatments. It includes confidentiality, which is the duty to keep a patient's information private and not disclose it without consent. And it now includes teaching and mentorship, which is a pledge to share medical knowledge with future generations of physicians. That's where the medical students come in. So what professionalism actually derives from the Latin word professio, or public declaration. These are occupations, professionals, those are occupations that are granted a special status by society to deal with the needs that are valued by the community that they serve. Earlier, the status of the professions was harshly criticized. If you read Terence Johnson's Professions and Power, which was published in London in 1972, which I've read over and over again. I still don't understand most of what it's saying. It says that this was criticized very harshly, and many people looked upon the profession as a method of controlling work, and in some cases, as a menace to the public interest. It was believed that the more powerful the professions, the more serious the dangers in concern for public service, and the zealousness in promoting the practitioner's interests. That is what Eke Daniel said. However, the realities of everyday medical encounters boosted the status of medical professionalism. As stated by Sir James Spence, the essential unit of medical practice, this is very important, the essential unit of medical practice is that very moment in the intimacy of a consulting room when a patient who is ill or who believes that he is ill confides in a doctor who he trusts. Very important. That intimate relationship between that patient and the doctor is not seen in any other profession. It is a sacred relationship. This interaction between the doctor and the patient, which we say is consultation, is so important that all else in medicine derives from this relationship. So professionalism remains necessary and desirable for any decent society. Another thorny point in this discourse is the fact that professionalism has different meanings for different people in different contexts. That was how I started my presentation earlier. You know that it's essential to be professional if you want to be a successful person. So, but what does being professional actually mean? I have been searching for this same answer. So I turned to what I was raised with, Webster English Dictionary. I don't know if any of you remember Webster English Dictionary, to look up the meaning of professionalism. It says that the conduct, the aims or qualities that characterize or mark a profession or a professional person, a calling that requires specialized knowledge and often after long and intensive academic preparation in medicine. So professionalism, therefore, encompasses a number of different attributes. And together, all of these attributes identify and define what a professional is. And if this is the case, therefore, we probably can teach it. We probably can teach professionalism. Using these attributes, the Association of Medical Colleges in the United States worked to incorporate professionalism into medical student outcomes and also into accreditation and reaccreditation processes. Also using this set of attributes, in 2002, a combined North American and European internal medicine boards published the Physicians' Charter, a declaration on medical professionalism that is required for the new millennium. The AMC Charter defined three fundamental principles of professionalism. One of them is the primacy of patient welfare. The other one is patient autonomy. And the third one is social justice. If you read the Annals of Internal Medicine, edited by Sachs in 2002. All of these are well defined, and every one of these aspects is expanded ad infinitum. Let's look at the primacy of patient welfare. This principle focuses on altruism, trust, and patient interests, which must not be compromised by market forces, by societal pressures, and by administrative exigencies. How many of us can resist administrative exigencies? Even in the most sophisticated societies, administration still determines what you do. Administration will schedule patients for you to see every 10 minutes, as if every patient is the same. They can never be the same. But they say every 10 minutes. So for a day, you have to see this number of patients. That has almost destroyed the special relationship between doctor and patient. What about patient autonomy? This principle incorporates honesty with patients and the need to educate and empower the patients to make appropriate medical decisions. And social justice, this is the principle that addresses a physician's societal contract and distributive justice. That is, considering the available resources and the needs of all patients while taking care of an individual patient. This is very difficult. Again, this also can be taught. So based on this preamble so far, we can therefore list the following attributes. What attributes we need to see and we need to teach in professionalism. Specialized knowledge and competencies, honesty and integrity, respect, accountability, self-regulation, and image. My college actually lists just 3 of them. Talks about courage, humility, and mercy, but I will not bother about my college at this time. So professionals are known for their specialized knowledge, deep personal commitment to develop and improve their skills. They have the degrees and certificates foundation, which is the foundation of this knowledge. This has been taken to a different level by a lot of the developed countries, where every 5 or 6 or 7 or 8 years, they tell you to come and retake your board exams because you need to develop and improve your skills all of the time. In medicine, that is the only place, only profession in which there is this repetitious re-examining of individuals for proficiency. So professionals work in a serious, thoughtful, and sustained way to master the specialized knowledge needed to succeed in their field. Professionals keep this knowledge up to date so that they can continue to deliver the best work possible. So we expect professionals to keep up to date. That also can be taught. So when you hear about departments that have what you call journal clubs, where they bring all the latest information and the latest things that have appeared, and they discuss it and debate it intelligently, that is part of the development. And that in itself is what professionals should do. Professionals get the job done. They are reliable. They keep their promises. Professionals don't make excuses, but focus on finding solutions. All of these premises can be taught. Professionals exhibit qualities such as honesty and integrity to get the job done. They keep their word and they can be trusted implicitly. If you tell a patient that you're going to be available for them, you should be available. You can't be tossing your patient around give them an appointment, you don't keep the appointment. That in itself is breaking the trust because they came to you because of that trust. They never compromise their values. They will do the right thing even when it means taking a harder road to get there. All of that can be taught. So all persons have basic rights that must be respected. Patients have special additional rights that must be protected. All persons should be treated with common courtesy. True professionals maintain attitudes and behaviors that communicate respect. So professionals hold themselves accountable for their thoughts, words, and actions. When they've made a mistake, they own it. They don't try to pass it on to someone else. Personal accountability is closely tied to honesty and integrity. So accountability is a vital element in professionalism. And that's what is accountability? To err is human. So to admit your error with humility is honesty and integrity. To continually strive to improve in yourself to avoid such errors is professionalism. So professionals consider the emotions and needs of others. They don't let a bad day impact how they interact with colleagues and clients. They disregard for the feelings or welfare of others is an affront to common decency. So no matter how a patient appears to you, no matter whether the patient crawled to you or came in a limousine, you should treat them all with courtesy and respect. Professionals look the part. They don't show up to work sloppily dressed with unkempt hair. They are polished and they dress appropriately for the situation. They exude an air of confidence and they gain respect for this. So you have to be appropriately dressed. There are some individuals here. Which one of them do you think is dressed professionally? I mean, there are some dressing that is totally inappropriate for the woman. Okay? So I expect professionals to dress properly for the occasion. So an individual comes in like this guy here who has pants that are torn and comes into your ward to do ward rounds with you. How would you feel? Of course, you probably will kick him out. Okay? But he's probably as knowledgeable as everybody else in the place. So he's not properly dressed. Okay. So the increased attention that medical professionalism has received lately exposes the deficit in our educational system and indicates the need for more work to be done to ensure an effective teaching and assessment of this competency. I've taken this from my friend's staff, Khalid Altikawi, published this in the Sudanese Journal of Pediatrics, and I took this quotation from it. It's a beautiful statement. He also said that teaching professionalism requires special efforts in terms of imparting the non-cognitive skills. Respectable role models play a major part in this process. Someone earlier this morning talked about mentors. That is what mentors do. And students and resident doctors must choose their mentors carefully. Helping students to reflect on the real life encounters in a safe environment is probably one of the most effective tools at our disposal. Now, what is a safe environment? That is left for every healthcare provider, every teacher to determine. Let me skip this for time. So the process of professional growth is dialogue, reflection, and practice. Dialogue, interactions with your mentors, thinking about what they have imparted you and then practicing it. So a program for teaching professionalism in medical schools must be implemented. It is not a luxury, but a necessity, and it must cut across all departmental lines. It must be taught not only at the undergraduate level, but also at the postgraduate level. It should also be a required competency for the continuing professional development. This is my belief. Every community or college must be cognizant of its ecosystem in planning a professionalism teaching curriculum. There are many strategies for advancing the teaching of professionalism in medical schools, but the optimum method will be environment specific. I cannot give you that recipe because there's no such recipe. Success depends on institutional commitment, such as faculty development programs on teaching professionalism and the inclusion of professionalism in the curriculum. Professional behaviors must be rewarded, meaning that unprofessional behaviors must attract sanctions and a program of remediation. A highly professional doctor is not just a good doctor, but a great doctor. See what John P. Higgins said about great doctors. Let me go through that very quickly and stop. 10 Traits of a Great Physician by John P. Higgins, which is published in the American Journal of Medicine in 2002. A great doctor has to be a detective like Sherlock. Okay? Whenever you have eliminated the impossible, whatever remains, however impossible, must be closer to the truth. That's what Arthur Conan said. The great doctor must get healthy and must relax. Intelligence and skill can only function at the peak of their capacity when the body is healthy and strong. That is a quotation from John F. Kennedy. And that is true. The great physician must be a master listener. Listen to your patient. He or she is telling you the diagnosis. Sir William Osler said that. The great physician must find his passion. Your work is going to fill a large part of your life. And the only way to be truly satisfied is to do what you believe is great work. And the only way to do great work is to love what you do. If you haven't found it yet, just keep looking. That's Steve Jobs. A great physician treats the whole patient. A good physician treats the disease. A great physician treats the patient who has the disease. Again, that is Sir William Osler's quotation. A great physician must have empathy. People will forget what you said. People will forget what you did, but they will never forget how you made them feel. So you must make your patients feel. This is Maya Angelou, who is a poet. So a great physician must pay attention to details. It's attention to details that makes the difference between average and stunning. That's Francis Atterbury's quotation. A great physician must develop resilience. It is not the strongest of the species that survive, nor the most intelligent, but the ones most resilient and responsive to change. Those of us who studied genetics know what Charles Darwin said. Take responsibility. The buck stops with you. I'm not a product of my circumstances. I'm a product of my decisions. Stephen Covey. So, count your stars as a great physician. Only in the darkness can you see the stars. That's what Martin Luther King said. So I want to let you know that my presentation to you today is to sensitize you to the fact that we have a very important thing to do in this conversation. And the task before you is enormous. And professionalism, if we can teach it, if we can impart it, we will be great doctors. And this continent will be blessed with even greater doctors. So I want to thank all of you for listening. Thank you.
Thank you very much, Prof. Another round of applause for him. Yeah, so a lot of lessons to be taken away from there, but I'll just allow 2 questions if we have any or comments. 1, 2, any other? Okay, yes, I've seen those 2. So for the benefit of those online, please introduce yourself before your questions or comments. Thank you.
Congratulations, Professor, with the position. My question is about if are there problems of mental health in the undergraduate or postgraduate student of medicine? And if the answer is positive, what actions are you making? Thank you.
Thank you.
Thank you, sir. My name is Victor Odekule. I'm a medical officer, and I'm very grateful to be part of this session. It's also a privilege to be among many of my teachers. Listening to your talk, sir, thank you for the delivery. You did mention that one of the tenets of a great physician is that he is well rested, takes time to rest, right? When this comes up at medical forums, it's usually quite ironic, seeing as training schedule for a doctor, robust as it is, rarely leaves time for rest or recovery. I very recently completed my internship, and repeatedly I had to work 72-hour shifts, 36-hour shifts, because that's just how the structure is. If I would be truly professional, or if other doctors that would go through the same training would be truly professional, there is the requirement to be well rested. Is there anything that is being done, and thankfully the heads of medical schools across Africa are here, is there anything being done or that can be done for medical training in Africa to make it a bit not lax, but to create room for rest and recovery after short bursts of activity? Can that be done, or is it being done? Thank you, sir.
Okay, so I can see that is generating more hands up.
Thank you so much. I really appreciate. I was wondering about how do we look at the health system level of what are the determinants of workforce behavior? So I think it's not only a personal decision to be a professional, like the workload, the number of physicians we need to produce. And I think we, as medical schools, we really need to think of it as a collective effort, adding to professionalism, because it's the time and the number of medical students who are there, or the workforce. So I think improving the workforce working conditions will go a long way towards also adding to improving professionalism, and also the attention to detail. So sometimes for the women, the care that women receive may not be respectful because she has cancer, she has many reasons not to show up on time, and she's blamed because of delayed presentation. Or we have seen sometimes during medical schools how some of the midwives treat the patients while they're on the delivery table. And these were kind of, some of them were horrible examples, and we've seen them also from some of our own professors. So I think we need to look at it. Also, there's a collective responsibility of improving the lot of the workforce in order to, it goes a long way towards improving professionalism.
Thank you very much, Professor. It's a very interesting lecture. I think you've mentioned that there is no hard and fast rule about professionalism, and it can vary from one locality to another. I'm an academic myself, and I think we tend, when we want to teach professionalism, for example, it's just to import the practice and definition of professionalism from abroad, where do you think we should get our professionalism rules in each community? Is that just the norms of the community? Is it just I'm getting it from wise people? How do you create it? Thank you.
Okay, so how many more? 1, 2, 3. Okay, but Prof, I want to rush back to the first question so that I will get clarity.
Yeah, this is a question. I'm Luis Podesta from Peru. The question is, if are there mental health problems of mental health in students of undergraduate and postgraduate students of medicine? And if the answer is positive, yes, what actions are you making in this case?
So is there mental health facility for undergraduate or postgraduate? And if there is, what efforts are being put in place to improve it?
Well, thank you, Professor, for the lecture. My name is Lawrence Sherman. I'm from Liberia. My question is, when you talk about professionalism, wouldn't it be the same as talking about ethics? Because, you know, that's the difference I would like, if there's any.
Good afternoon, everyone. And thank you, Prof. I don't know whether this question is going to be right at this particular discussion now, but my question is from a policy angle. Medical education, to me, is quite long enough for it to be reviewed, because we at the policy end, we see what our graduates are facing in terms of professional jobs. You know, we work with other healthcare professions. And for instance, medical laboratory started from nowhere, and they are up here. Medicine, medical degree has remained the same all through the years. So we are thinking, actually I was thinking that this forum will give us a perspective where a medical certificate will be looked into, where the double degree that we earn, which places us at particular level, and others are coming to meet us on that level. Because now the rivalry in the healthcare system is, I don't know how to explain it. So I think this forum has to really look at the medical degree. We have to budget a degree. How do we qualify each one so that medicine or medical doctor will always remain at the top hierarchy of the profession? I think it's something you have to look to. The another perspective about the medical education is that the other aspect of medicine that is only the clinicians that are at the forefront. For instance, I am at economics, and I want to believe most of these people are clinicians. So where do you place us? Where do you have a trajectory from medical school for you to lead to where we are today? Because, for instance, in the health insurance industry, there are no background, first degree to enter into that space. These are things the medical education has to look into and start creating a pathway where people can be useful for the system. Because we have to create what the society needs and to solve a problem in the society.
Hi. Congratulations for your talk. And sorry, this is not a question, but I can't resist. I loved your citations, and I can't resist only 30 seconds to give you one quotation that always drives me as a teacher. It was from Theodore Roosevelt, the President of the United States, I think 91 to 99 around, who said, talking about the doctors, nobody cares how much you know until they know how much you care. And I think it drives the humanization of medicine. Thank you, and sorry.
Thank you very much. So, Prof, you can go ahead, sir.
Thank you very much. I better repeat that your quotation. Nobody cares how much you know until they know how much you care. That is perfect professionalism. It is so beautiful. Thank you for the quotation. Yes. In any case, I'll probably take the last question at first. Rivalry in the healthcare system. That is by the policymakers. You are asking me a question that policymakers make. The fact that medical laboratory technologies have now caught up with the doctors in terms of remunerations and importance in the healthcare system, that is all policy. It has nothing to do with the healthcare itself. It has nothing to do with the education itself. It's all policy. Don't get me talking about insurance, because if you get me talking about insurance, then we will never leave this place. Health insurance is fraud, in my opinion. Every citizen is entitled to health care. It is not a luxury, it is a right. And it is the place of the state to provide that health care. All of this insurance thing we are talking about have come to hijack health care from those who actually are delivering health care. Okay, so let me not go into the insurance. So your question, it should be directed to policymakers. They are the ones that have created the environment. So in terms of the medical student who has a mental health issue, that should be identified early. Okay, that should be identified. If we have a system that monitors the well-being of our students as they go through medicine, then it will be easy to identify such students and remove them from the mainstream and have them undergo specialized management, counseling, treatment, crisis intervention, whatever it is that we need to do to sustain them in the system. I don't know if that answers your question, sir. Now, a lot of schools, you know, if you know what students go through to get into medical schools, then you should know that no one of them should fail out of medical school. Because they have been selected and reselected and reselected until they get into medicine. For me, if any of my students fails, I feel as a teacher that I have failed. And so it is our collective responsibility to ascertain that after bringing the students to medicine, we must ensure that they get all of the accommodations they need to succeed. Okay, so I don't know what every institution must have different strategies for dealing with mental health among students, mental health issues among students. But the young man who was talking about rest and relaxation, I think my colleague from Rwanda or from Canada via Rwanda, and he has already answered it. The reason why you are working so hard and why you have to take calls every other night is because you don't have enough doctors. So the solution to that is to have more doctors. That's the solution. Because if you are on call, you've taken good care of a patient and you go away, and by the time you come back 2-3 days later, the patient is deteriorated, you will feel bad because no one cared for the patient when you were gone. So you do not mind doing that call, not resting, just to take care of that patient. That is professionalism itself. Okay? So until such a time that we are able to have adequate manpower, okay, there is really no way to answer your question better than that. Okay. Okay. Then there is the question on the question about what is the basis for creating a professionalism in every community? How do you determine it? Well, the determination is based on the various criteria that I just gave to you. What constitutes respect? There are some communities in which a woman who comes to see you, covered all of her face, you tell her to take off that face covering so I can see you. But that will not be respectful in other communities for you to do that. So those are the kind of variations that you have to introduce into professionalism as it relates to that ecosystem you are dealing with. So those are long, it is a tradition. You see, you being a very senior actor in the medical community in Sudan, you see, you can lay what the foundation of respect and non-maleficence, all of those things, you can lay those foundations and it will be a standard of care. Okay. Then the next one says, how is ethics different from professionalism? Oh, very different. Very different. They both derive their impetus from the Hippocratic Oath. That's why I quoted the Hippocratic Oath as the beginning. They all derive. There's nothing wrong. You can be ethical all you want. I mean, you can be ethical all you want and come to the clinic in tattered clothes or in miniskirt. I mean, that is not professional. But you are still ethical. So those are so they are there's a difference. There's a difference, and we should not mix them at all. And in a highly professional doctor, is a highly professional doctor a good doctor? That's a good question. Is a highly professional doctor a good doctor? Yes. He may not be that knowledgeable. See, the difference between a good doctor and a great is it's a very fine, thin line. Okay? Yes. If a doctor is highly professional, he sits there and listens to your complaints and you show empathy. And you say, listen, I really don't know this thing. Let me check with my colleague who is an expert in this area. You've already engaged them. You've bought their trust. And you're a good doctor. As long as you do not fake what you don't know. And once you fake what you don't know, then you are not professional. Okay. Can a highly professional doctor still be able to maintain empathy towards his patients? Of course. Empathy is one of the hallmarks of professionalism. So if you are highly professional, that means you have empathy for your patients. Yes. I think I have answered all of the questions so far. Thank you very much.
Please a big round of applause for Prof. You know, it's only the big men in the room that can take that subject, you know, because it's always a daring thing to talk about professionalism, and I think Prof did that very eloquently. Another round of applause for him. And you will notice that that topic generated highest number of questions so far today, because it's all about professionalism. So, ladies and gentlemen, we want to quickly go into the panel discussion. We want to run along with the time so that we can cover as much as we can in the time possible. So, panel discussion is going to be on health workforce strategy in Africa. We know we've been talking around the workforce and talking about Africa, and I know everybody in this room is passionate about sorting this out. We need a strategy, and you know the commissioner told us that whatever we do, it must be able to shape policy formulation. So we're going to go into all of that now. I'll need some ushers to help me get the chairs in front so that we can call the panelists. Well, ladies and gentlemen, welcome with me the moderator of this session, this panel discussion, as take to the microphone, Biodun Adewuya. A round of applause for our moderator. No, we'll use the smaller chairs. Let's use the covered chairs. Yes. Yeah. Okay. Just take the ones that are free. Yeah. It's easier that way. So I'll be calling on the, I think we have 4. So I'll be calling on the president of the World Federation for Medical Education, who is a panelist in this session. Welcome with me, Professor Ricardo Leo Buckers, as he steps forward. A round of applause for him. Also welcome with me from Marquest, Francis Omasua. Online, okay, it's online. Then we have James Asemani, the WHO. A round of applause for him as he comes forward. And Bernice Adegbengbe from AMSA. Bernice Adegbengbe, a round of applause for her as she steps forward. So one of our panelists is online, and just so that we are sure she's there, the ITU team, can you put her on spotlight? Francis Omasua. Okay. Is not?
Okay. Yes. Because of the ongoing political issues that the Commissioner for Health mentioned, I guess that's why Yodo Adeoya is not here despite his promise. But not to worry. This is AMSA. We always have plan B, plan C, and plan B, and plan D. And some of these things happen, and I'm really quite happy that it does happen, because then it allows me to put some people on the spot. And there's a person in this room that has been putting me on the spot for several years. So it's now my turn to return him the favor. Right now in Africa, as we had mentioned before, health focus strategy is being done by everybody. WHO, Africa CDC, AMSA, Global Forum, they're all dabbling into health workforce strategy because they've recognized the fact that without a strategy, it's difficult for you to implement other things. And part of those things that we need to implement, which is curriculum development and retention strategies, must feed into the health workforce strategy. In returning the favor of this gentleman who over the last 5 years has been running me around the continent, I'm also going to give him the chance to return the favor to someone who's been running him around the bend for the last 5 years, so that all that what goes around comes around. So Professor James Asemani is in charge of the health workforce strategy in WHO. We've been working together on this for quite a few years. And the person who he has tasked with handling the Africa prototype for the competency-based education, competency-based curriculum for multiple professions is Champion Uyoni. So this is Champion's opportunity to put James on the spot, and it's my opportunity to put Champion on the spot. Because in so doing, I kill 2 birds with 1 stone. Because it is important that we fit into what AMSA's future strategy will be our partnership with WHO in the first instance, and that's why the panel was set up, and also how we're going to work with WFME as a region. Champion has asked for a few minutes to catch his breath because whatever he says here may have impact on his career. But whilst he's doing that, in all honesty, when we were starting, when we were thinking about the theme of this conference, it was actually called increasing capacity. It was actually increasing capacity and retention in the health workforce in Africa. When I discussed with my colleagues at the WFME, we realized that this was a global problem, and we therefore changed the theme to increasing capacity and retention in the global health workforce, out of sheer realization that whatever we talk about here has implications for other regions, if only for them to recognize what we are trying to do on our own sides so that everybody can learn and then we can share off. So I'm going to invite Champion to come up to moderate this session and ask his boss all those questions he was there when his boss was asking me, which is why he doesn't need plenty of time. And with that, sorry, don't worry. I know you'll have your own opportunity to. Yes, so it'll be a fireside chat. Thank you. Thanks.
All right. Good afternoon, everybody. Good afternoon, everybody. Now that's much better. As they said, welcome to Lagos, and this is Lagos. And what we are learning from Lagos is that maybe we give it a moment until it's sorted. Ready? All right. Anything happens when it happens. And here I am. I did not see myself in this position, but here we go. So again, thank you so much for joining this session, which is going to look at a bit of the health workforce strategy. And we've got three esteemed colleagues whom I know, all of them in different capacities, in personal capacities, from a father to a mother to a son, all of them sitting up here. I'll give you a moment for them to explain who they are. As mentioned, I'm Champion. I'm with the WHO and the Technical Officer for Health Workforce Education and Lifelong Learning. And what we want to understand from the people up here is what their organizations are doing, particularly with focus on health workforce strategy. So we'll try to find out historically, what have you been doing? What has been your biggest contribution? What is your current strategy? And what are the key issues that we should remember from the work that you're doing moving forward? And possibly have an opportunity to get everybody involved to find out where are our potential areas of synergy. So with that, I want to maybe start with a round of introduction before we get into it. We'll start with you, Prof. Ricardo.
Well, hello, I'm Ricardo Leon Borges. I'm the president of the World Federation for Medical Education. I'm from Mexico. Okay, so I have been participating in WFME for many years now and have been president for the past three years.
Right, thank you very much. Over to you, James.
Good afternoon. Good afternoon. Okay, I hope that the nice lunch we had is not working on us too much. So my name is James Avoka Samani. I work as the team leader for health workforce in the WHO regional office in Africa. Our role basically is to provide technical support and guidance to member states to be able to plan, train, retain, and utilize effectively their workforce for the benefit of the population.
Thank you. Good afternoon, everyone. I'm Professor Benis Adebengbe.
I'm Provost of the College of Health Sciences at Obafemi Awolowo University, Ile-Ife, Nigeria. I represented AMSA in the just concluded Health Professional Education Quality Standard workshop that we had in Johannesburg, where champion was really championed the program. So I'm here on invitation to this panel. Thank you.
Thank you so much, Prof. Benis. Like I mentioned, we know each other in different capacities. Maybe let me start with you, Ricardo, from your experience. And I mean, WFME has been in this process of workforce development, particularly within the medical education space. And a lot of the work that you've done is quite impactful globally. If we were to look at the last 5 years, how would you describe as the single most impactful contribution that WFME has made in regards to workforce development?
Okay, thank you, Champion, for the question. If I have to say the single most important issue that we have been doing is probably the establishment of standards for medical education. And the standards that we have been building at this stage are based on principles. And this has allowed us to get a consensus among all the regions of the world to determine what are the critical aspects that we have to cover in the different stages of medical education. That means that we have standards for basic medical education, we have standards for postgraduate medical education, and standards for continuous professional development. That means that we cover the continuum of all medical education. So when we work together with our colleagues from all the regions, we ask the experts of each one of the regions what do they believe it's the most important things in every aspect of these standards that we're building. And then we get an agreement, then we send it to experts around the world, okay? Many of here from Africa. You give us feedback about them, then we review it again. And once we have a consultation over different countries, we get the feedback that they provide us, and then we decide to set up the standard for every single part of medical education, as I mentioned. So this has given opportunity for every country to adopt those standards because, as I mentioned, they are principle-based. So that doesn't mean that what is going to happen here in Nigeria necessarily has to happen in South Africa or in Mexico, okay? You can adopt them according to the context. You can adopt them according to the healthcare system. You can adopt them according to any need that you may have within every different country. Okay.
Thank you very much. Thank you very much. And I think this is quite an important contribution, particularly to the work in harmonizing medical education. And do you have, in any instance, an idea in terms of how or to what extent these standards have been adopted across countries you're working in?
They, according to the feedback that we have received from the presidents of the 6 regions of the world, these standards have been adopted widely by most medical schools. It's not mandatory to make them the ones that they have to follow, okay? What we promote is that every medical school should have standards in order to run their curriculum, okay? Obviously, what we have done with those is that these standards have also participated in a very critical issue that takes place in every country. And this critical issue is the creation of accreditation agencies of medical education. So most countries have decided to create an accreditation agency for medical education, and they are the ones responsible for putting together the standards that suits the needs of the country to make it better. So today that we were here in the Ministry of Health, it was very important to say that it will be fantastic for Nigeria to create an organization that can depend independently or be part of the government. So you can create the medical curriculum standards that all medical schools in your country should follow. Because in that way, you will be working on the human resources that are needed for the country, not the human resources, since the way I have heard it, half of your population or half of your graduates decide to go abroad. Now, are these standards that you have means that they are standards for they to go abroad? Or are there standards that are needed for the health care of the people in Nigeria? So that's why it's important to have an accreditation agency that sets up the standards according to the needs of the country, okay? Of the healthcare systems, of everything that is involved in the process in this country. So that's one of the important roles, okay? And then we have some other programs in the WFME, like the recognition program, but that's a different issue, okay? But this is important. And one of the key elements that you should be considering is to have someone that can establish the standards for medical education for the whole country.
That's a nice discussion, and thank you for that feedback. And I want to dovetail this to James. James, from your organization, what are the concrete mechanisms that you are doing to support countries in workforce development?
Thank you very much, Professor Champion. So maybe to disclose, myself and Champion work in the same team, basically doing the same work every day. So I can conveniently say, please answer the same questions on our behalf. But on a more serious note, thank you for the opportunity to discuss workforce development, particularly looking at it from an African perspective. And let me take the chance to also acknowledge who will be speaking later on, Professor Jim Campbell, who has led majority of the modern day approach to how we deal with workforce development globally, the global strategy on human resources for health and many other related documents, including the competency framework for UXC is guiding how we transform health professions, whether from education to their employment, retention, among others. So from a global perspective, I wanted to acknowledge Jim's contribution because I'm going to draw a lot from that in my submissions. So in Africa, our challenges with workforce is similar to the rest of the world, but also completely distinct from the rest of the world. And because I'm speaking to predominantly doctors in the room, I want to follow your rubric on how you do your things. First, you make an examination, you come to a determination of the diagnosis, and then you plan the treatment before you discuss and deploy. So I want to take a step back to look at what exactly about the workforce in Africa do we need a strategy on. So the realities of the workforce in Africa is a lot of paradoxes. First is that, as one of the young doctors mentioned, health workers, especially doctors, are working long hours at the very front line of service delivery because there are not enough. There's a shortfall. And our estimation is that Africa needs between 500 and 600,000 more doctors if we want to stand any chance of addressing the disease burden. Put that in context, we are producing just a little over 31,400 per year. So it's not going to be anytime soon that we can fill this gap if we continue the pace at which we are producing doctors. But this is a big improvement over a few decades back. If you were to take it back, remember the professor from Sudan, yes, his presentation earlier, there were very few medical schools, even as recent as 2014, 2012, less than 200 medical schools at the time. Big investment has gone in. The last count showed a little over 400 medical schools producing this 31,000 plus. But the reality is there's a shortfall. We need to do more in education. But here's the paradox. Many doctors these days, young doctors, finish school and they are not readily offered the jobs in a decent way that they can start work right away. And I have had the wrong privilege of being driven by a taxi driver who's a trained doctor. Yeah, I won't mention the country. So I sat in the car, we are moving, then I start coughing, then I put on my face mask, and he says that he started educating me on many things, what to do. So then I said, no, this person must not be a non-medic. So I asked, do you by chance work with the health system? So yes, I am a trained doctor, but I'm waiting for a job. So 18 months now, I don't have a job, so I'm doing this work as a side hustle. So the reality is there. Our estimates show that about 27% of the trained health workers in Africa are either unemployed or they are underemployed. It does not exclude doctors, sorry to say. Doctors are included in that estimate. So that means we have a paradox where in one hand, we don't have enough workers, but in the other hand, we have workers, we are unable to absorb them. Much of the blame has been put on lack of money, fiscal space, they say. So that's one. Then on the other hand, another paradox is that I was just sharing an article with Champion this morning of some assessment that was done across many countries in Africa, including Nigeria, where the conclusion was that health workers' competence can be put at approximately 45%. The ability to give the correct diagnosis of very common ailments, simple pneumonia, diarrhea from a child, and those things, ability to diagnose correctly and give the correct treatment is at only 45% from that paper. Previous papers put it around 60%, and we were thinking it was a big problem. With this, it's even more urgent. So what then it means is that if you look at the medical education, speaking with doctors, I focus on education. There's something fundamental that needs to change to make the workers a bit more competent than they are. So it's not just a number issue anymore, there's a quality issue. But the other point also is that these same people are leaving. 1 out of every 10 doctors who have ever been trained in Africa is already abroad. Not that they intend to go, they are already there. And they go at the point where they have already been trained, they've used the system, done the mistakes they are supposed to make, and they've learned from it, and they are now okay. That's the time they leave. So replacing them is not simple as we will train more. Because training more will replace the human being and not the skill that has left. It takes longer, it's more expensive to replace them. So the question is, what do we do to be able to tackle this myriad of problems to go, but also progressive enough looking at the realities of our system capacity to adapt? So this is where the strategy issue really comes in. And in WHO, in the African region, we are looking at it from 3 angles. So our strategy, what we now call the Workforce Agenda 2035, has 3 main pillars. The first one we call plan. In the plan, we're helping countries to understand the labor market, to a labor market analysis, comprehensively to see what is happening in this market in terms of education, employment, financing, among all of that. Then when they understand that through the analysis, we move the next phase. Have a credible investment plan to be able to crowd in the necessary resources to address the challenge identified in your analysis. And I call it credible investment plan because if a plan is done and it's not in the government budget, it's not credible. So it has to be a plan done and integrated in government budget. That is why we say that plan is credible. Then you can follow through with implementation. Then under the second pillar we call the train is where we are looking at how do we not just expand the numbers of those we are training to fill the shortage, but improve the quality and relevance of the training. And so in that area, we are tackling it using different mechanisms. First is to say, let's agree, what are the core competencies we want to see from a health worker, from a doctor, for example. So back to Ricardo's point, we agree on the competencies, drawing from the global framework of competencies for UHC. Then we build that consensus for Africa. Then from these competencies, it will be like a prototype curriculum that is competency-based. We do the prototype curriculum. And I'm happy to say we've already launched 10 of those ones last year. And Professor Bumi was one of the people who was very instrumental in getting some of those curricula done. And I see a couple of other people here contributed in different ways, including the FAMSA president. Then, after having the curriculum, the next point is, can we aim at progressively harmonizing the way we train and ensure that the quality is at a certain level that we can trust each other's training and qualification? And there comes a concept of the Africa Health Professions Education Quality Standards that can enhance quality assurance. Then eventually we can encourage reciprocal or mutual recognition of qualifications for countries that deem that their quality is comparable. So under the area of train, there's a lot happening. Then the last bit that we call retain is where we are focusing on, if we want to cut back the 6.1 million shortage of health workers in Africa, we have to be aggressive. So the aggressiveness is more advocacy, helping governments to plan to be able to employ at least 3 million more health workers over the next decade. And if that happens, we can cut back at least by half the shortage of health workers. This would also include supporting health workers to become entrepreneurs, to create their own jobs and employ others, and facilitating the diaspora to be able to contribute back to Africa. So these three main approaches of plan, train, and retain is the core of what WHO is currently doing with member states in terms of direct country support, guidance, and translating global norms into local solutions. Thank you.
Thank you so much, James, and that's a mouthful. I just want to build on a bit on what you've said and take a little bit of twist. And I mean, the elephant in the room, we know financing is now a problem. There's a big gap, and yes, we might want to improve the numbers and so forth, but on the flip side, countries might struggle to actually absorb them. So how does your organization then support these countries to move from these donor-dependent models to more sustainable domestic financing for health workforce development?
Indeed, there's no solution that will be cost neutral. Every solution comes with an investment needed. And so when you look at the workforce issues, financing there's a big gap, whether in the investment in education or in the employment and the retention. Now, let me give one specific example. If we take just the employment, to employ the health workers who are currently trained, but they are not having jobs, requires at least 43% increase in the budget of countries on average, 43%. Now, if you look at the ability to spend more, the World Bank has suggested that more than 40% of our countries, their budget is stagnant. There's no room to expand because they are in debt and most of their money is going to pay debt, and there's very limited aid flowing in now. So what we are doing is to help the government come up with a realistic investment plan, what I call a credible investment plan. And that plan, they set together to bring Ministry of Finance, Education, Labor and Public Service, Ministry of Health, and they agree, what can we do in the next 3 years? They put the exact numbers in the text of a memorandum of understanding, and they signed it officially. We call that a workforce compact. And then they implement and have regular meetings to check where they are and what each other can do to help the implementation. And a typical example of how this has worked is Zimbabwe. Zimbabwe, during the period of COVID, that time I used to live and work there. One day we were told that the country had run out of critical care nurses, and so they needed an urgent kind of solution to take care of COVID patients who needed critical care. So we met and said, okay, can we do a 2-week crash course for general nurses to start filling in the gap of those who have left, because the critical care nurses apparently traveled abroad. In a short time, a lot of them left. We agreed, we said, okay, let's get the tutors of the critical care nurses. Only one was left. The rest had also traveled abroad by themselves. So we lost the nurses and their tutors. So, of course, we had to do what we needed to do to find the temporary solutions and all of that. Now, eventually, we agreed that we needed to now do a proper analysis to see what government needed to do. When we did the analysis and we did the plan, we realized that it required a lot of financial commitment that was impossible to get it done using the normal incremental way government business works. So we brought all the stakeholders together to discuss. They agreed on how much government needed to put in every year to increase salaries by 20% per year, recruit at least 6,000 health workers per year, double the training capacity for doctors and nurses each year for the next 5 years. We did all of that and we costed it. The government committed, that was, I think it was almost 70% of the total cost, and they put it in the government budget. Global Fund put in some money, the UK government put in some money, and a few others. And then they are working on it. The last time I checked with them, they showed me the progress metrics that they are tracking, and it shows that the compact was signed in October 2024, and it ends December 2026. So far, they have 60% of the resources that was budgeted for has been released and implemented as of December of 2025. So we see that they are not yet there, but it's progress that with that kind of commitment, they can still get some results, even if the fiscal space environment is limited.
Thank you so much, and also for bringing up these practical examples. Prof. Benis, I come to you, and wanting to speak more specifically with what's happening in AMSA. There are numerous organizations around medical education, health professions education across the African continent. What would you argue is the unique contribution of AMSA in terms of advancing workforce development and medical education in our continent?
Okay, thank you, Champion. AMSA, which is the Association of Medical Schools in Africa, is a representation of all, will I say, leaders of training or health education training in medical schools. That is, deans and provosts of all medical schools from all over Africa are the members of AMSA. And they have come to be a recognized voice in Africa to be reckoned with maintaining standards in health education and then developing curriculum. For example, we can see over the years that medical education specifically has received a lot of attention from AMSA. And especially in Nigeria, we have a competency-based curriculum now that is a universal one that has been embraced by all medical schools in Nigeria. We give kudos to the Professor Bumi, you know him. He was the main person in developing this medical curriculum for Nigeria. And that we are all medical schools in Nigeria now using the same standard of training for our medical students and then medical graduates. And the same thing is happening in other professions like in nursing and pharmacy, everything like that. And so as far as AMSA is concerned, we are interested in enhancing medical education, ensuring that we are able to have a standard curriculum, competency-based, and then be able to train competent health workers. And then the ability to retain these health workers depends on more interaction with the policymakers, especially the governments in the different countries, because we need support from them to retain, because you can train competent people, but when the environment is not conducive for the standard or quality of life they want to live, and if there is no remuneration or if they are underemployed. Because if the remuneration is not enough for them to enjoy the type of life they need, definitely they will move. For example, in my university, we have some departments that you only have professors, no more senior lecturers, no readers or associate professors, because the younger ones, they have all left. So there's a wide gap. And so what AMSA is posing is that if the government can encourage retention of healthcare workers, especially medical doctors our colleagues, then it will improve quality. Because if most of the professors I'm talking about are about retiring, so there is a gap already. So we need to be able to have people that will be able to train the people that are coming from behind. So these are the issues that are on ground that AMSA is trying to address.
That's very fascinating, and I mean, it seems that AMSA is doing so much from curriculum to worrying about what's going on in the system, looking at retention as well as part of your mandate. One thing that struck me was your conversation about the curriculum in which something is happening in Nigeria where there is that harmonization. Probably I would like you to touch base a bit on that, but with the thinking of how AMSA, which has got a bigger footprint outside Nigeria, what would be the impact, of having such a curriculum also with countries outside Nigeria having some sort of discussion on standardization, harmonization, working towards something common outside Nigeria?
Yes, I think it's in all this you are talking about is in the pipeline. I'm sure with this conference, I think it forms the basis of developing such interaction and the ability for us to harmonize our curriculum in other countries in Africa, so that we can have standardized competency-based curriculum whereby our products, our medical products, will be able to move freely and be able to be well represented within Nigeria. And the curriculum we have developed in Nigeria that I think may be relevant to other countries in Africa is not only it's not only for Nigeria. It's not only national curriculum, but it has international standard, and we even say global standard. So that is why our products, not only are they relevant in the country, even though they are the training is targeted towards local needs and community development, but they can work anywhere in the world.
I already see what you are saying in terms of synergy with what James was talking about in terms of harmonization across the African continent, and what Prof. Ricardo was talking about in terms of linking it with standards. Maybe just a round of questions for all of you. Prof. Ricardo, starting from you, based on the conversations from the colleagues, where are you seeing the areas of synergy and partnership between WFME, WHO, and AMSA?
Okay. Definitely, the first part is that we know each other, okay, and we like to work together. And we have been doing this for many years. Actually, as you are aware, WFME was born on request of WHO and the World Medical Association. So to put together, and that's why in one of our sessions, when I met him, I said, "Oh, you are my father," okay? And the president of the World Medical Association, "Oh, she's my mother." So we were teasing. So we get along very well, okay? I think that's part number one. We have to get along very well in order to understand and collaborate as much as we can. Okay, once we have that, okay, then we can start talking of how we can support each other, okay? And one of the things I mentioned already is education, okay? So education is according to and as I mentioned already, is according to the needs of every country. And I said it, not necessarily what happens in Nigeria is the same thing that happens at South Africa. So there may be variants, but we have to take those into consideration. The other thing that we have to work together is through quality. Okay, that's very important. So the best way to do it, and I have already mentioned it, is through accreditation. So if we have a good accreditation agencies in every country, okay, then we can say that we have a robust quality assurance process. And then we can work on quality, on having a competence-based education curriculum, okay, that has been already mentioned here. And that has to be done in combination with all the African countries. And that's why AMSA is so important, because you represent all the countries in the African region. And all of this has to be going along with social accountability. That's very important to have it into consideration. Another thing that I recommend, okay, and that we have been seeing that is working in many parts of the world, is that interprofessional education. I have heard it already here that you're working with the nurses, with the physician assistants and everyone. And because that's at the end, when we send them to different settings, they can work together because they're used to work together. Okay, so that's one of the important things. Another thing. What is very important, and it has been stressed since the beginning of this conference, okay, the retention. Retention is very important. That's my point number 4. So those are, we have to create career pathways, okay, to develop safe environments for the physicians, the nurses, and whoever it comes from your healthcare system. And we have to have an effective absorption of the graduates of the medical. If we are producing 100 graduates here in the medical school in Lagos, and we are not giving work, then they become taxi drivers, as he was telling us. So those are the things that we have to be assuring that we are taking very much into consideration. And obviously, we need to have the accreditation and regulation, okay, systems that I already mentioned. And the other very important thing that we have to take into consideration is the coordination between the ministries of health, the ministries of education, the medical schools in general, through the representation in every one of the countries, so they can start making regulations according to the needs of every country, okay? And international partners, okay? Just like what we're doing right now. WFME can be counted as one international partner for all the countries in Africa in order to support the development of everything that we're going through.
Thank you so much, Prof. This is very profound. James, in 1 minute, what are the areas of synergy?
Thank you, Champion. I think it's becoming very clear how we need each other. WHO will use its norms and standard setting mandate, its ability to navigate through the policy and political process for legitimacy of things to be the driver of us harmonizing medical education in Africa to improve the quality and relevance. AMSA is the coalition of different medical schools, and therefore that is a very good convener of the medical schools, bringing them together so that we can share the ideas, get some of these harmonization processes done. But to do so, you also need that national regulator who would develop this national reference curricula that would foster national level harmonization. And I believe that WFME will play a very big role in that. So I see that we can come together, work on the low-hanging fruit to improve the quality, relevance of medical education in Africa.
Thank you so much. Thank you. Prof. Bernice, 1 minute.
Yes. With regards to synergy, I think in the last few years, I think there have been some close interaction between the different associations in ensuring that there is harmonization of training in Africa, especially. And with regards to regulatory bodies, I know it has started in Nigeria, and I'm sure it's going to spread and be advocated in other countries in Africa if it's not there already. That in Nigeria now, we are having the Ministry of Education and Ministry of Health working together to improve the standard of education by providing facilities, equipment, and support for training of medical students and other health professionals so that we can improve the quality of our products from the medical schools. And this is being championed by, by the Association of Provosts of Medical Schools in Nigeria. And this has taken a great effect, and we are seeing it's part of the thing that actually delayed me from coming to this conference. Thank you.
Thank you so much. And just to close off, I'm sorry we really ran out of time. Just to appreciate the contributions that you've made, the discussions we've made, very rich about the different works that you're doing, but also the points of synergy. And to say that there is a common African saying that if you want to go fast, go alone. But if you want to go further, go together. So thank you so much, and I hope that this is the beginning of a journey of us moving forward in workforce development. Please give a round of applause to this beautiful group. Thank you very much.
Thank you very much. Another round of applause for the panelists and our moderator for a job well done. Thank you very much. Okay, so very quickly, we want to go into the parallel session again, like we did in the morning. So we're going to have 3 rooms for those of us physically on ground and also those online. There'll be 3 rooms, and the main room here where we are at the moment will be the room where we do meet the experts. It's a room for meeting the experts, facilitators, and FAMSA will be meeting. The room 2, that's the next room there, will be the room where we're having the faculty development in teaching and assessments. That's the next room. That's room 2. And room 3 will be having the intellectual property protection for medical teachers. Are we clear? So room 1, this meet the expert is happening in this room. Room 2 will be doing faculty development in teaching and awareness. And room 3, that's the last room towards our registration point, is intellectual property protection for medical teachers. And so FAMSA is remaining in this room. The facilitator for room 3, Yemisi Koya, that's room 3. That's the 3rd room from this point. And the next room is the one with FCFMG FEMA. That's the next room. And for those online, you'll be directed online to your virtual rooms. And so these sessions will run parallel for the next 45 to 50 minutes. I'll be 30 to 45 minutes. Huh? So these sessions will run simultaneously. Please feel free to go to any of the rooms depending on the topics that we have created or that I've announced. Room 1, room 2, room 3. Room 3, intellectual property. Room 2, faculty development in teaching and assessment. And this room here is meeting with the experts. So you are free to go to any of the rooms, and virtually too, you are free to indicate your interest in going to any of the rooms. Let's proceed now, and we'll reconvene in about 30 to 45 minutes. Thank you. So meeting the experts hosts in this room, and FAMSA will be moderating that session in this room. Room 2, the facilitator will be the Int Health and the FC FMG FEMA. And room EMC, that will be the moderator in room 3. So room 1 room 2, and room 3. Please feel free to go to anyone as they'll be running simultaneously. Please, if you are for this room, please just let's move forward so that we can start. If you are remaining in this room, let's use the first 2 rows in front here. Thank you. AMSA. Yeah, hold on. You guys are moderating here now, please. Yeah. You know what to do. Yes.
Good afternoon once again, everybody. I hope we've been having a good time at the conference so far. For one, have been having a very inspiring and great time. My name is Blessed Olaomo. I'm a fifth year medical student at the College of Medicine, University of Ibadan. And currently I serve as the administrator of the FAMSA headquarters. So FAMSA is the Federation of African Medical Students. So together with my colleague here, Mr. Akitunde Iwalesho, we'll be moderating this session. So we'll be meeting with 2 of our amazing experts here today, 2 amazing women who have made so much impact, who are so passionate about medical education. So, I think I would just quickly invite them to the podium very quickly. So first we have Dr. Madelina Patricio. Welcome, ma'am.
Can we clap for her?
Yes, can we appreciate Yes, thank you so much, ma'am. So we also have another amazing expert among us who will be meeting. We have the Vice President of the WFME, Dr. Genevieve Monio. You're welcome, ma'am. Yes. I kindly appreciate that. Thank you so much, ma'am. Yes, Thank you very much. You're welcome once again, Maz. What we want to do here is just to meet you and have some insights into your journeys. How did you get to where you are today? We have a lot of students, I'm sure online, so we have a lot of students who what we want to do here is to um, create an avenue for everyone in this room to be able to meet you and know more about you. So what we'll be doing is just to ask a couple of questions about your journeys, just to stimulate the people to be able to ask relevant questions as well. So I'll be starting with, actually I want to hear from you both, ma. I think we should first go on to read your citation. We have Dr. Madalena Patricio. I think I'll allow my colleague to go on and read a citation.
All right. Thank you very much. I'll be reading the citation of the Madalena Patricio. Madalena Patricio is a globally respected figure in medical education and a retired assistant professor at the Faculty of Medicine of the University of Lisbon, where she served as the director of the Department of Medical Education. She led the world's largest medical education organization, AMI, for 7 years as president and continues to contribute internationally as president ex officio. Renowned for our commitment to teamwork, social responsibility, and excellence in medical education, she has been instrumental in advancing humanistic, transformative, and evidence-based approaches to training future doctors through such as expert to excellence and the BEME collaboration. It's a round of applause. I welcome Mrs. Dr. Madalena Patricio.
Thank you very much, Mr. Akintude. So we also have Dr. Genevieve Monio. We are privileged to have her here in the room with us as well. Dr. Genevieve currently serves as the Vice President of the World Federation for Medical Education, WFME. She was elected in 2023, and she works to continue to enhance the quality of medical education worldwide. She has led the development of postgraduate medical education and continuing professional development recognition programs, as well as the creation of the WFME Declaration on the role of academic institutions in supporting learners and the 2025 WFME conference in Bangkok, Thailand. Dr. Monio was appointed as Chief Medical Workforce Advisor for the Government of Canada's Ministry of Health in August 2023, in support of efforts to address the health workforce crisis. In 2023 also, Dr. Monio completed a 10-year term as President and CEO of the Association of Faculties of Medicine of Canada, representing all of the country's faculties of medicine. Previously, she was the Vice President of Medical Education and has led 2 accreditation agencies as Secretary to the Committee on Accreditation of Canadian Medical Schools and the Committee on Accreditation for Continuing Medical Education, ACME. 2024 recipient of the Canadian Medical Association Leopold Landry Medal Service for exceptional contribution to the healthcare education. The University of Ottawa has also bestowed upon her 2024 Lifetime Achievements Award for her impact on positive change in medical education in Canada and around the world. Dr. Monio is an MD graduate of the University of Ottawa and completed her pediatric residency at the University of Toronto's Hospital for Sick Children. She's a full professor in the Department of Pediatrics and Emergency Medicine at the University of Ottawa and has privileges in pediatric emergency medicine at the Children's Hospital of Eastern Ontario. She's a proud mother of 3 and grandmother of 6, and she enjoys spending time discovering natural beauty all around the globe, developing her skills as a wildlife photographer, and most of all, spending time with her family who bring her great joy. Once again, welcome with me, Dr. Genevieve Monio. So, thank you so much, everyone. I think I will direct my first question to both of you, really. I've read so much. It's very impressive all the things you have done, especially in advancing medical education in globally, not just globally. So I just want to know, what was your journey? What really inspired your interest in promoting medical education? You could have just remained a clinician and just been in the hospital, but what really spurred you to do all the things? Because we could see, we have evidence of your dedication and your passion to developing medical education. So what really spurred you? Can you tell us your journey of how you got into these leadership positions in medical education?
Well, thank you for that very long introduction, and now I'm tired just listening to it. No, thank you for the question. And I think there were 2 sources of inspiration for me. One is that better? I found medical school really, really hard. I don't know about you guys, but man, right? That was the hardest thing for me that I had ever done. I felt I could never keep up. There were moments in medical school where I was not treated properly as a human by another human. And it was quite traumatic for me. I made it through and I did okay. But my goodness, when I've been asked, would I, which part of my life I would repeat, I don't know if I would repeat medical school because it was so hard. So, I'm sure you guys are not experiencing anything like that, but that was really hard for me. So number 1. Number 2, if I had not gone into medical school, because I had to apply twice before I got in, I was accepted to teachers college because I loved teaching and I loved being with children and I loved, being in that role of teacher. And so, when I finished school and residency, as you heard, I did a pediatric residency, and then I practiced pediatric emergency medicine. Right away, and even as a resident, I loved teaching. I loved teaching the students, and then as a staff, I loved teaching the residents and the students. And that passion for the act of teaching was always there. But I also had that, I felt the need to improve our medical education system because I had had such a hard time. The curriculum that I was taught was not always relevant. There were things really important. I don't remember a single lecture on influenza in my medical school curriculum. Imagine that, right? So, and yet I was taught a whole bunch of other things. I won't talk about the Krebs cycle, I promise, but, you know, I really felt we need to improve curriculum, but we also really needed to improve what I call the learning environment, which is very simply, you know, how we treat each other during medical education, how we treat students and residents, and how they treat each other. So those were the two big, you know, inspirations for me. And it also meant that medical education and supporting students in whichever way I could was always my North Star moving forward.
Thank you very much, Dr. Madalena.
The same. So, first of all, thank you for being here. And as Jen said, it was too long. Just here is a friend of you all. Okay, my motivation. Let me talk to you. At a certain moment, because I came from the field of education, I was invited to work at the Faculty of Medicine, University of Lisbon. And when I arrived there in the beginnings of the 90s, so almost 40 years ago, I discovered a faculty where there was no objectives, no structure of the discipline, no reference, not assessment, differentiate formats, nothing. Everything was multiple choice tests, everything was inside the faculty and so on. And then I start looking and I think, oh my God, there is so much to do. And I decided to make some questions, some interviews to all professors in chairs and to all professors that were just regular professors, just regular teachers. And one of them was a blind professor teaching psychology at the second year. And when I asked him a lot of questions to understand where and why I should begin, I asked him about the methods, the evaluation, the assessment, and so on. And at the end, when I was already finished this interview, I said, "Oh, professor, you are not desperate with the state of education at our school? How do you see this?" And I always remember from that professor that being blind, he came always. It was the daughter that bring him to the class. And he said to me, "Professor Madalena, think on my goodness, name in English, how do you say, the Moreira, that give the skill word, on a blueberry tree, there is a tree that gives the things that the skill worm eat, the sheets to make the skill. What's the name of the tree? I don't know it in English now. Oh my God, my story is ruined. My God. Okay, think on the enormous tree where the skill was, the little things that make the skills. And he said to me, think on them. When they wake up in the morning, they look at this enormous tree and they don't think, oh my God, how many sleeps I have to hit. No, they start doing their work. So, Marilena, don't be desperate. Start doing a little bit every day for medical education, and at the end, it will appear. I think it was the beginning of my passion, and I discovered that it was like snowball, because when I really teach the teachers something that was useful, then they started to use it and Then they pass to the others and so on. So this was one thing. The other source at the middle already of my career that also reinforced my motivation was when, do you remember the terrible NASA disaster in the sky when after 60 seconds or so it exploded in the skies? And then they published the interview of all 7 members. And one member, when he was asked by the interviewer, what did you before they go to the flight to the space? He asked, what was your normal profession? And she said, I touch the sky, I teach. And I think this was also a source of inspiration, the need that we are with students, and you are so many times teaching us and motivating us. So these are my big sources for medical education work.
Thank you very much. Thank you. Let's give a round of applause, please. That's very, very inspiring.
Yes,
Very inspiring.
I think one thing that stood out for me is how both Dr. Madalena and Dr. Genevieve got inspired to contribute to medical education from noticing the gaps while they were students. I think that's really amazing. So let's move on. Thank you so much, Maz, for sharing your motivation to contribute to all the contributions, all the great things that you are doing for medical education. Thank you so much, man. So yes, we can forge ahead now.
All right. So I think my question will go to Dr. Madelina. I think why we're trying to read about you, there was something that caught our attention that some of your colleagues they like calling you the calling card in your institution, the calling card. The calling card. Is that true? Calling card.
Oh my God.
Okay. Is that true? No.
I don't know what you are talking. Maybe something because you saw this where?
Yeah, like why reading about you? It's like something that we came across.
I guess it's fake news.
Oh,
Okay.
interesting. All right. Okay. All right. No problem. I think we can go on. I think we can go
All
to
right. So
Dr. Genevieve.
Doctor, my question is directed to Dr. Genevieve. So many medical students struggle with uncertainty when it comes to choosing a career path in medicine, and some end up becoming pressured to follow a certain trajectory. Let me use myself as an example. Although I'm still a medical student, but I used to like surgery in quotes just because people say, oh, it's so prestigious or there's a lot of money in surgery. But as I go through my clinical postings, I realize that what I have passion for is not necessarily surgery. So for students that have this pressure to follow a certain career path, a certain trajectory, I want to ask, did you ever have any moment of doubt while choosing your career path? And how did you navigate through? How do you really know your passion? For example, you have explained to us what motivated you to, do all these things in medical education. So what are the things that a student should really look at while choosing a particular career path?
So great question. I'll answer this in two parts, both my discipline and then my focus on medical education. So my discipline, like you, I did not end up where I thought I would. I was going to be a psychiatrist. When I went through, the theoretical parts of medical school, I really found, all the stuff about neurotransmitters and all that kind of stuff really, really cool. I really appreciated the theory of psychiatry. And this is why it's so important to have a robust clerkship in medical school, because I was so keen on psychiatry. I made that my first rotation, my first clerkship rotation or clinical rotation. And I realized that I was wrong. And two things. Number one, of course, somehow I ended up on the forensic service. And so I was put in a room with criminals, which really wasn't very comfortable, I realized. But also I realized, I can't stay in a room with a patient for an hour. I realized I had a little bit of, ADHD, and I really couldn't do that. So, and as I went through every rotation, it was like, family medicine was nice, but my goodness, it's too hard because you have to know everything. And obstetrics was nice. I like the babies, but not the gynecology so much. And then, of course, my last rotation and surgery, well, I kind of knew I didn't want to do that. And that's where I actually had a lot of my very bad experiences. And so that was ruled out. And of course, my last rotation was pediatrics. And it's so silly because, of course, I should have wanted to be a pediatrician because I love children. I spent my summers being a camp counselor and surrounded by children. So it took me a while to figure it out, but yes, pediatrics. And then in pediatrics, I also realized again I could not do developmental pediatrics, which again was way too long of a time with any given patient, et cetera, and realized that pediatric emergency medicine is what was well suited to me because it was fast paced. I like making the diagnosis of appendicitis, but don't make me take out the appendix. That's a waste of time. So, it's that kind of thing. I like being the first one to solve the puzzle when there was a puzzle to be solved. So that's where I ended up clinically. And then in medical education, as I mentioned, I realized, that there was much that needed to be changed. And so what I initially did is I complained a lot. I was that student that complained or that resident that complained about things not being right. And really, nobody listened. And so that's when I realized that complaining was actually not going to be the solution. I had to be the solution. I had to step up. I had to do like you are all doing already as student leaders. And, I had to be the change. If I wanted something to be improved, I had to be part of the solution. So not necessarily as the leader, but certainly as someone who was enabling the change. And I think that actually, has guided me throughout my career, and very lucky that opportunities have come up for me to take on leadership positions. But again, it's always for the purpose of going back to my North Star, making medical education, the quality of education better for learners along the continuum, and the environment of that education to be improved.
All right, thank you very much, Dr. Genevieve, for answering our question beautifully. My next question, I think it will be directed to both of you actually, because you've rightly shared your experience with us, what actually motivated you. And of course, we have students here in the room and as well students on the call who perhaps while you were sharing your experience might have been inspired by it, and you might be inspired to actually like seeing a future in global health or seeing a future in actually medical education as well, but perhaps they don't actually know where to start. So I would like you if you could touch on practical steps that they can take note of, even why as a medical student. You go first.
So, where do you go and what you should think on? I think that in this career in medical education, there are really things that marked my trajectory. One of them, and it was said already in one of the conferences some minutes ago, is there is no recipe in education. We cannot say that one thing is the best. So we need always to look at the institution, the resource, the kind of teachers and so on. And what is fantastic in one place could not be successful in another one. So we need to be very humble and share the solutions, but get things from the people. And just to tell you an anecdote that happens to me when I was invited to go in Hiroshima, because they were celebrating the reconstruction of Hiroshima after the terrible atomic bomb and so on. Okay, I was invited to give the first plenary, and I gave the plenary, and I thought it was well accepted. At the dinner, the dean of the faculty came to me and said, "Congratulations, Madalena, you did great and people like it. But can I ask you something?" And I said, "Yes, of course. Tomorrow, when you give the second lecture, please don't smile." Oh, my goodness, it's what I make all the time when I'm talking. So, what is something good in Portugal? was not acceptable in Japan. A teacher at that time when I was there, that was already 20 years ago or so, it's different. A teacher must be more serious and so on. So no recipes. This is one advice. Another one is that we can't do something in medical education without involving people. If it's a decision from the top, from the directors, the deans, and so on, it's not going to work. We need to have the button. Start by asking people. The teachers that today deal with the students, ask the students what is going wrong and try to build the things from the bottom. I don't know if you already seen these pyramids in Spain, in Catalonia, that they go in the shoulders and they have 7 or 8 layers, and the small ones in the top have only 6 years. It's the same in medical education. You need to have people to support them. And when I saw these pyramids in Catalonia, I saw what they have written in Catalan. I couldn't understand, and I asked, and then they told to me, it was written, born to sustain. So, in medical education, if you don't take the basis, you never succeed with reforms and so on. And I think I'm too long. I also had a third thing to share, but I don't know if I'm taking too much time. Yeah? Just the third thing that also marked me a lot. In 2015, I was invited to go to the Students Association, to the European Medical Students Association, celebrating the 25th anniversary. And I went to Berlin. And I always like to look at the website of the associations and so on. And what I see, can you stand this here, was like this. Today, medical students with an enormous cross, and down, doctors of the future. And then it marked me so much, and it's true. We cannot treat the students of medicine like students of law, mathematics, geography, and so on. No, because the students of medicine need to be treated as future doctors from the first year. They have to carry in their shoulders the responsibility of being a doctor. We, the teachers, we need to tell them, study for this, not only to have a 20 or a 19 or so on, because you need the high grades for later choose the specialization, because one day you'll be at the emergency at your hospital and you will see someone just walking like this, and you need to know these symptoms and so on. So that idea that they have to be treated not as students but as future doctors, it's another thing that marked always my trajectory. And this is the way we try to deal with our students in Portugal.
Thank you very much, Dr. Madalena. Dr. Jenny.
Yes, thank you. And really agree with Magdalena about the need to treat everyone in our environment with respect. Everyone should be respecting everyone, the student, the patient, the professor, the clinician. And in fact, as you heard, that's been one of my main areas of focus in my career. So what should you do as leaders and future leaders in your careers? I think what you have to think about is, what is the stuff that makes your blood boil? What's the stuff that really upsets you or frustrates you, or the stuff you're really curious about and you cannot find an answer? And that should help shape your career. So yes, you have, so you can use that type of questioning around which discipline you want to perhaps pursue, but also that'll help you in whichever discipline around what research you may want to undertake, or also what areas of care you want to improve in your patients, and also what it is you might want to be trying to think about in medical education and trying to improve upon in medical education. And so, as I think you're hearing from us, there's no straight line, and you have to decide for yourself, what is that stuff you're important, that's really important to you and that really matters to you. Because whatever it is that you choose, chances are you're going to be working at that for a long time, right? There's nothing worth fixing that you can fix overnight, generally speaking. And so whatever it is, you're going to have to work on it for a long time. So make sure it's something that you're really interested in and really passionate about, because that's how much time you're going to have to be spending on it. I think I'm just going to mention one thing related to students and learners in particular that I'm really proud of, that relates to my work with the WFME, and one thing I'm so proud of that we've accomplished is that the WFME published last May a declaration on the role of academic institutions in supporting medical students, resident doctors, and faculty members along the continuum. And when you look at the declaration that's on our website, and I encourage everybody to go look at it, you'll see that there's a series of calls to action as to what can be done. And I am thrilled that this idea was brought to to our executive council, to our board. They agreed that this was an activity that WFME should undertake, and I'm very proud that. Since the launch, we've had 300 signatories. So that's 300 people or institutions that say, yes, this is an important document, and that we're going to do something about it. And in May, when it's a year, we asked them, if you're signing on here, we're going to reach out to you and we're going to ask you what you've done, so that we can actually understand the impact of that. But, I didn't know when I was a medical student that I was going to be undertaking this work. Right? All I know is that not only my experience, but I know that for so many medical students, their experience in their education is lacking. And if this document can help even a handful of students and residents have a better experience in their education, that will make me very happy, and that will bring me great joy. Thank you.
Thank you so much, Dr. Genevieve and Dr. Madalena. I think that will kind of lead me to my next question. So, talking about how education of medical students is lacking in many areas. So, what do you think, beyond clinical knowledge, right? So, what do you think a good doctor should possess? What qualities do you think a good doctor should possess aside clinical knowledge? I know being a good doctor is not just limited to how good you are, how much clinical knowledge you have. So what are the qualities aside clinical knowledge that you think a good doctor should have and should be incorporated into medical training? And in your experience as an educator, what do you see differentiates a student who goes on to become an impactful leader in healthcare and a student who just complete their training?
Okay. Okay, sorry. Before Dr. Jennifer Amadele answer the question, I think I should just tell the audience that the students in amongst that, in case if you have any other questions I want to ask our experts here, you can also kindly raise up your hands, and would do well to get your questions so that you can ask them. So, all right. I've noted one hand already. If there are any others along the way, while they're answering their questions, we'll take them.
So I think this is a question for $50 billion. Yes, we have a program in our TV, because it's so difficult to say all the attributes. But if I can summarize there, I think Jenny Loon in 2008 said that a doctor needs to be a global doctor, because we have globalization. It's different from the past, that we are educating just in Lisbon, maybe for our country and so on. The doctors are now citizens of the world. And she said there is a need for three things. One, sound knowledge to be able to work in an international context, the skills that international context demand to the doctors, and also the values of a global citizen. And that third dimension, dealing with ethics, with values, is often neglected in the schools. And it's important that we think always in these three domains. So the knowledge, the basis, the foundations, the skills also. But if there is no ethics, no values, it's impossible to be a good doctor. And if you are, and if you want to be a good doctor, you need, as I said some minutes ago, you need to think on care, on empathy, on humanization of medicine, and doing your job with ownership, with passion. But it's difficult to cover all the attributes.
Thank you very much, Dr. Madeline.
You know, say anything after Patricia speaks, right? It's amazing. Oh, Madalena speaks. So being from Canada, of course, I'm going to speak to the competencies that are the CanMEDS framework. And so this is something that has been around for a long time. And I actually very much believe in it, and I'm going to add to it. So this is a framework of competency that we've used in Canada and has been used around the world. That talks to, what are those end competencies, whether it's at the end of medical school or at the end of any specialty training that are required of a physician. And so in the middle of the flowers, medical experts, so that's the stuff, you need to know some, have that knowledge, that medical knowledge. But then all around that are some competencies that I would say are equally, if not more, important. I would put the next one in order is communicator. Certainly, is there a problem? Oh, in Canada, when doctors get into difficulty with the regulators, when there are complaints from patients, the most important issue is usually not one of knowledge or competency or technical skill. It's actually communication. And so communicator is one of those other roles. Collaborator, as we've talked about, you can't provide good patient care without doing so in teams, and you can't undertake medical education without doing so with support of groups. Professional, of course, and we've just had a lecture about that this morning. And to me, that professionalism, again, is really simple. It's, again, all about respect in every angle. And then we have advocate. So that's you advocating for patients, advocating for better medical education, better health systems. Scholar, so that's the work that you do. And again, whether you're doing leadership or medical education or research, there are opportunities for scholarship. And the last one is leader. It used to be manager, and now it's leader. And it's not leader meaning that you are going to be running an association or an organization or a hospital, but it's leadership in the sense of contributing to solution. So being part of the system and being part of the group. You mentioned earlier, we were talking a little bit about admissions. To me, there are three important aspects about admission to medical school. So besides bringing in individuals who have the potential of being competent in all these roles, the leadership aspect is important. The candidate needs to have demonstrated excellence, the ability to pass tests, whatever the tests are, because you're going to have tests to get through for medical school, but also the concept of service. And I think sometimes we have lost that in medicine, that medicine is not about me having an illustrious career and you making money, et cetera, et cetera. It's about serving the populations that are needing your care. And I think we forget that sometimes. And I think as students, you have to keep that in mind. Yes, you're trying to shape a career, but really you're doing that so that you can serve patients better. And in medical education, we work to train learners in the best way so that they can provide the best care for the populations who need it. And so those are the two aspects I would speak to.
All right, thank you very much, Professor Madeline and Dr. Chenevi. Thank you very much for answering the question. Now would take few questions that we have. I think I see your hand. So can you? Okay. Yeah, can you come?
Hi, thanks so much for that profound insight. My name is Kunle Adewale. I'm not a medical student. I'm an artist. And tomorrow I'm going to be talking about the use of art in care. And I wondered, with all your years of experience as medical educators and scholars, what change have you made in the area of integrating creativity into care? I mean, I will give you an example, creativity into care. Yeah. I will give a classic example of a lot of medical educators and students who have been part of a fellowship program that I run, a non-academic fellowship program. I think sometimes medical scholars or educators are tired of the curriculum because, again, they feel like same of the same. So there's nothing inspiring or exciting. It just feel like, I don't use the word, okay, let me be very careful. I'm choose my word carefully. But I'm just thinking, what change have you made or what change will you make in that area? I'm an art student. I went to art school. Today I work in the hospital. In the curriculum when I was in school, there was nothing related to the use of art in our curriculum. So what is not in the curriculum, I developed outside of it, and today it's all over the world. So I think it's ways of rethinking what health is. And how do we offer innovation and opportunities for medical educators? I mean, we see a lot of medical students who today now do a lot of research in the use of art in health. I'm not sure that is part of your curriculum because now medical students are finding new pathways or what is not in the curriculum. So what change have you made in that area? What change will you make now that probably you have transitioned? Thank you.
I think you touch a very, very important point. And the point that it's because you are an artist, you are capable. We all need to put our best attributes to differentiate for the things very, how can I say, that were from the past and to students are tired and so on, and to bring art, nature, music, and so on. And even another thing that was said in a minute, you need to have your eyes not only in the skills and attitudes to train the expert, not only in the attitudes and ethics to train the professionalism, but you have to have dimension. Was told us in the Lancet report already from, and I didn't see it in the faculties, it's about a transformative knowledge. We need to train our students to be agents of society change. I cannot admit, and I'm telling this to my students, that they were in the faculty only looking at very, let's say, medical field. But sometimes the best unit in the hospital that publish in all famous journals had a long queue of patients at 9 o'clock for internal medicine, some of them coming from 3-4 hours waiting because all the appointments are made for 9 o'clock. Because we can't accept that someone is missing, so others need to be there. Could you believe people that sometimes are diabetics waiting from 9 until 12? So you need to transform the world. You, the doctors, you are the top of the professional hierarchy with more status. So you need to make things, you need to transform. And this is why we take our students in Lisbon in the first year to the community, but not to hospital on the health centers. They go to the prisons, they go to the houses that have handicapped people, they go to the cars that support the prostitutes in the night in the streets. They go to the minority of gypsies, to the centers for refugees to know what? To know about vulnerability. Because I don't know if it's the same in your countries, but in our country, almost all students have or a mother or a father that is a doctor and is protecting the child. For him, no sport, no love, nothing, to have the best marks to be able to enter. They don't know nothing about reality. And when we bring them to these institutions and ask them to share at the end a message, what did they see in those institutions that can change them for a better world? You can't imagine. They start to be, I say a word that I don't know if it exists in English. Their minds are deconstructed. They are open to something different. And I think this is essential. Go with your heart. I'm not at all an artist, I can't, but you need to bring this. And it's why, as she was saying, that we need to collaborate, because one bring the arts, the other bring maybe the vulnerable people, the other bring, and with all of them, we are sure we facilitate the students to be good doctors.
Thank you very much, Professor Gemma.
Thank you for your question, and this is so important. We have, it's taken us a long time to appreciate the importance of health in a holistic way and health care in a holistic way. And I think we're much smarter about that now in many ways. I think certainly where I come from, we're more open to different concepts around health and wellness, specifically around creativity and art. What we have started doing is to ensure that all of our students actually have the opportunity to go to an art museum or experience art, like literally take time out of the curriculum to do that. In our, we have an overall, humanities course that has many different aspects, but that is one of them. And what I find is incredible is that we've actually opened up other concepts and opportunities around art. We have student groups around music and art, and of course there's the med show, which is great. But it's, to me, it's incredible how, in fact, artistic our students are if we ask about it and if we let them show us, and it's really extraordinary. I also think that we need to appreciate just how important any creative outlet is, as I say, in helping our patients with their wellness and with their recovery. And again, I think we're starting. I think we've got a long way to go. Thank you for all the work that you are doing. And I'd love to have a chat afterwards to hear more. But I think this is really, really important. And, we've been just so scientifically focused in our profession. We need to get out of that. We need to really open ourselves up to exactly what you're speaking about. Thank you so much.
Yeah, thank you very much for bringing that hope once again, and also appreciate our experts for also also appreciating it, because I think the point he also mentioned was also actually very important. Just creating that aspect out of the curriculum, out of the normal world rounds, clinics, and all. Just have the aspect, of course, to wind up and also give medical students the opportunity to also dive in art, and also in a way convert the medical knowledge in art, to express it in art. Thank you very much for bringing it up once again. We'll take the other question.
Thank you very much. My name is Prince Dia from Ghana, University of Ghana Medical School, level 500. And I also happen to serve as president of University of Ghana Medical Student Association. We could relate much to what Dr. Genevieve said concerning how difficult medical school is. Now, our main question is that medical school has been very difficult, as you know, for most people in Africa, specifically combining that one to financial hardship and family issues and all that. Now, we want to know how you managed to survive medical school without mentally breaking down. Were there some steps you put in place to actually ensure that despite the difficulty, you still manage to find a way through? And also, if there is something, if you had a chance to go back to correct or to do or to stop, what will be those things? This is going to be very helpful because you go back to our country and then try to speak to our friends about some measures they can put in place. Yeah, thank you very much.
Oh, just a really simple, not very private question there. And I will keep it short because I think that was our timeout question. But I am very lucky that, I lived in school, so my family was there. I also fell in love in medical school. I know, eh? I know. And, 44 years later, did I just say that? I'm still with the same wonderful man. So, like, could not have done, any of this. And no, it was right. So find your people. Maybe you don't need one, but find your person or find your people, find your support. Do what you need to do for your sanity. And it might be painting. It might be running. It might be whatever it is. What I was just saying the other day how, I used to study 14 hours a day, and I know now that that was dumb. Like you can't. Your body can't. Your mind can't. Doing exercise is not only good for your body, but it's great for your brain, right? So like listen to all that stuff, meditation, like it works, all that stuff. So find your stuff, find the things that after you do them, they make you feel good. Find your people and also get rid of the people that, just bring negativity in your world. You've got to be, a little bit, I know we're talking about the altruism of medicine, but, while you're going through this very difficult time, you have to be a little bit careful of who you associate with. And, I would also say that alcohol and drugs and all of that stuff is not part of the solution either. So, keep your body well, keep your mind as well as you can, and, plug your nose and go through it.
Thank you very much, Dr. Genevieve, for answering that question. And also, thank you very much. I also have to thank him for also bringing that up because when he asked the question, many of us were actually laughing, but in real sense, it's actually a very, very practical question. Obviously, medical students here can relate. And even personally, from my journey in medical school, I've witnessed somebody committing suicide due to the pressure of medical school. I've seen someone attempting suicide, right? So these are like practical things. And
Can I just say one, right? So reach out to your colleagues, right? Like speak up. If you think that one of your colleagues is suffering, don't let them suffer in silence and do what you can to reach out. It's not always possible, but that's so important. And that's part of, in our CanMen's roles, that's part of our leader. It's about care for self, but also care for your colleagues. Sorry.
Yeah, thank you so much, Dr. Genevieve, for those insights. I would say, based on your experience, probably falling in love in medical school too could also be a coping mechanism.
Actually.
So, all right, thank you so much, man. So, since we're running out of time, so I'll just allow for one last question. If you could give one piece of advice to your younger self as a medical student, what would it be? To your younger self, if you could see your younger self.
I think if I have to give an advice to my students, maybe what I would say that could apply because nothing in education can apply to everywhere, but probably there is one thing is always do best, climb another step, I think we leave in our students a seed, something that make him when he left the school to be a better doctor and each day try to be even more and more and more better. I think this applies everywhere. And I think it's don't want to change everything at the same time. I always remember what Gandhi said us when talking about the actions. He said actions express priorities. So tell your students, have some priorities. This this semester, I will work on this to be better. That idea of never be satisfied with the level, to always look for more and better, and also for transforming the world, as I was saying, it's something, but it's not to be done in one day. It's something, just work every day a little bit more, okay?
So I'm still working on me. So, and I have a lot of gray hair. So just to say, but yes, strive to learn, strive to have experiences, strive to do that. But, right, put your own oxygen mask on first and, look after yourself, because if you don't do that, right, you've heard what can happen. And it, this is a marathon, right? This is a marathon. This is not a sprint. And so, it's 11 o'clock at night. Do I try to study for 2 more hours or do I sleep? The answer is sleep. Okay. 8 hours of sleep before an exam is going to improve your output on that exam much more than staying up till 3 hours in the morning or having a Red Bull and trying to pull an all-nighter and all of that, right? So just, listen. It's kind of like listen to your mother, maybe I'm saying. No. But look after yourself, basically, and because you'll be better for it. Thank you.
Thank you so much, Dr. Genevieve. Thank you so much, Dr. Madalena. I believe I myself have learned a whole lot. I myself reflecting on myself or reflecting on things I can do better. And I'm sure that every of the people in here have also been inspired by your journey. Thank you so much, man. I would have wished to be able to continue, but we are running out of time. I already been signaled to. So once again, thank you so much to experts, and thank you to everyone for coming around and for listening. Thank you for your patience. Thank you all so much, and I hope we enjoy the rest of the conference as much as I am. Thank you so much.
Let me just say the name of the tree that I finally remember. I wanted to talk about the mulberry, and the little. Oh my God, to be old is not nice.
There are times when you might feel aimless. You can't see the places where you belong, but you will find that there is a purpose. It's been there within you all along.
When you're near it, you can almost hear it.
It's like a symphony. Just keep listening and bracing yourselves to hear
We all enjoyed that session. I think we should give a round of applause to our facilitators and also our experts. A round of applause for them, please. A round of applause for them. Okay, so the people in the other room will be joining us now, and so that we can return to take one more of the general lectures before we here. Everybody who is here now. So before we do another ceremony and welcome cocktail. So please let's be seated. I'll allow the choir to treat us some good music for some 5 minutes and I'll be back. Choir, are you ready to give us some music now? So we'll take some. Yes, I'll come back so that we can recommence.
Let it ring out as you discover who you those around you start to wake up to the sounds that are in their hearts.
It's so amazing what we're all free.
It's like a slip. Just keep listening and grace to me. That you feel in those bills. You see. It's like
Okay, so that's the University of Ibadan Choir, and they'll be treating us to some good music while we wait for the people in the other rooms to join us. Thank you.
We sing two short pieces. The first one is I have a dream. I have a dream that there will be peace on earth, something like that. And then Shei Toshe, do that which you have to do, but the time is running fast. Thank you.
you can't see the places where you belong, but you will find that there is a purpose. It's been there within you all along.
When you're near, you can almost hear it.
It's like hard to wake up.
almost hearing.
If I miss you. You will find that.
Another round of applause for the University of Ibadan choir. And like that song said, Ṣèyí tó ṣe ọ̀rẹ́ mi ọjọ́ ń lọ. Do that which has to be done, for the day is running fast. Time waits for no man. Another round of applause for them. Ladies and gentlemen, we want to quickly take the Fitzmoreland Memorial Lecture. And I'll be calling on Professor Olaopa to please just introduce us as we take the pre-recorded lecture from Louis Sambo. A round of applause as I welcome Professor Oluwabunmi Olaopa. A round of applause for him as he introduces this memorial lecture. You are welcome, sir.
Can I have my slides, please? Right. Distinguished ladies and gentlemen, as I said early in the morning, when you invite politicians, you must always be ready for the fallout. So we split our opening ceremony into two because the governor of Lagos State had to go to Abuja, and the representative of the honorable minister was supposed to be with us in the afternoon. And it would have been complete infra dig if we held the opening ceremony in the morning and left nothing for the honorable minister in the afternoon. So we split it up so that we could do the awards ceremony when the minister got in here. But we just got notice that yet again his flight has been delayed, and he may not be ready. But he's asked us to give him another 15 minutes, well, until 5:30, to let us know whether we can go ahead without him. And if we are to go ahead and he turns up, then I would have a very successful AMSA Medical Education Conference, but no job. And since I have to keep my job, I would suggest that we oblige him with the 30 minutes he has just signaled that we should wait. But we are not going to be waiting for him indefinitely or just quietly. I'd like to invite the UI choir to come back. They've come all the way from Ibadan, essentially for this opening ceremony, and they're staying overnight. So the least we can do is to have them as an interlude, because once we finish the Fitzmodern lecture, which is only about 25 minutes, then we go to the welcome reception and the day will be over. So Mr. Dr. Owaje, could you please come back and let us have some more music whilst we wait for the signal from Abuja?
The trees of sea sunset. The sky
Distinguished ladies and gentlemen, I'm sure you understand why University of Ibadan has always been the seat of music when it comes to the medical school and the main university itself. Without prejudice to other universities, I've been to their convocation ceremonies, and I've always been grateful for our choir. So can we please give them another round of applause? Whilst they're loading my slides, I must say that the choir was sponsored to this event by the Vice Chancellor of the University of Ibadan. And we're really grateful to him because first he had to underwrite the expenses. But perhaps more important is that as they are students, he had to stand in local parentis for them to travel to Lagos outside of the university and stay for the day before they go back tomorrow. So we'll ask the provost to kindly express our appreciation to him for this kind gesture. I am supposed to introduce the next event, which is the Fitzhugh Memorial Lecture. And I'm not entirely sure what is. Whilst they're waiting to set that up, the reason for this being a memorial lecture, as I will show, Dr. Adebayo, is because of the role Fitz played in the resuscitation of AMSA. Fitz had been working with the American government since 1972 and retired in 1995, and then went into academia. And whilst he was in public service, he was really interested in ensuring health equity and also access for minorities. And I guess he carried that over into George Washington University, where he was appointed the professor of health policy and management. And whilst he was there, we met at the WMC meeting in 2004, 2005. And he told me that he was very interested in finding out what was going on with medical education in Africa. Thank you. And do I have control of the slides? Right. And the discussion we had in 2004 led to what eventually became a 20-year friendship with him, but more importantly, involvement in medical education in Africa. He died in November 29, 2019. That's Fitz. We all called him Fitz. He came from a line of doctors. He was an activist in medical school and maintained that whilst he did his residency in pediatrics. As I said, he joined the United States Public Service in 1972 and retired in 1996. And he held several important offices, including Secretary of State for Health. He was working with the Surgeon General. And at some point, he ran the volunteer service, which made him very, very popular indeed. He was appointed the professor of health policy, I said, and management, George Washington University in 2004. And then in 2008 to 2010, he and a group of African experts, of whom Jehu Iputo was one of them, we were to actually, this was supposed to be a reunion for us. Magda Oasis was to be here, as was Dela Dovdo, who was with the WHO at the time. But several issues made that difficult. And at that point, we discovered AMSA was lying in the WHO office in Brazzaville, and it was decided that we should resuscitate it because it was clear that medical education in Africa required some direction that had been given by AMSA before, but was now missing. The SAMS led the findings of SAMS led to the Medical Education Partnership Initiative of the United States government, which was a $135 million medical education strengthening grant that was given through PEPFAR. It went over 5 years, supported 13 schools. They had a couple more side grants, which brought the total to about 150 million. And that ultimately led to the revitalization of AMSA in 2014 in WHO in Brazzaville. He founded the George Washington Health Workforce Issues, and very unusually, when it was clear that he was losing his 40-year battle with cancer, George Washington University decided to name that institute after him whilst he was alive. A very unusual feat, and Jim Campbell is agreeing with me. And that was named after him in recognition of the fact that he had contributed almost his entire working life to health workforce equity. He was so intent on ensuring that there was equity. And this was a great honor. He was very proud. This is the photograph we took in Uganda whilst we were doing the SAMS, and that fits there. And there's Jehu Iputo and a whole host of other people. That's a much younger me there. We shall go back to those days. And this is also again in Dar es Salaam at the end of SAMS. Again, Jehu is somewhere in the back there with myself, but we're focusing on Fitz. There's him sitting in the center. And that was where MEPI was finally concretized, to use an American word. He was best known for his role in shaping graduate medical education in the States, and he mentored generations of health policy makers. As I said, he founded and led many initiatives, but he worked sincerely and relentlessly for restoration of AMSA as a representative of medical schools in Africa. He pummeled WHO until they agreed to resuscitate AMSA, and David Gordon was in that. Is the photograph somewhere? He was at that meeting. But this is Fitz again with the coordinating center in Harare in 2013. That's him in the center. And that's me somewhere behind there because I worked with the coordinating center as well. So he was a genuine friend of Africa and AMSA. And we felt that it was most important that we recognize his contribution by having this lecture in his memory. And that lecture will be given by none other than Dr. Louis Sambu, who was the regional director for the WHO at that time. He's unable to be here with us. He was very painful, but he sent a recorded message. And I would like to request that before we go on to that lecture, we stand up for a minute's silence in Fitz's memory and indeed a friend of mine. May Fitz's soul and the soul of the dearly departed rest in peace. Thank you very much.
Thank you very much, Prof. We will now take the pre-recorded lecture. IT team, please.
Association of Medical Schools in Africa, in partnership with the World Health Organization Africa region and supported by the World Federation for Medical Education.
Dear President
of the Association of Medical Schools in Africa, distinguished colleagues, dedicated educators, leaders in healthcare, dear participants. It's my great honor and privilege to address 2026 Conference on Medical Education taking place in Lagos, Nigeria, under the theme Increasing Capacity and Retention of the Global Health Workforce. Whether you have traveled to Lagos or participate online, your presence today signals a shared commitment to shape the healthcare professionals who will care for generations to come. You are all aware of the complex epidemiological transition we are facing in Africa. I emphasize the very high burden of infectious and chronic disease, recurrent epidemics, and its overall negative impact on child survival, maternal health, and life expectancy at birth. Communicable, maternal, perinatal, and nutritional conditions are on the top of causes of death in the African region, followed by non-communicable disease and injuries. WHO 2025 World Health Statistics Report reveals a decline of about 40% on the trend of maternal mortality ratio in the African region since the year 2000. However, the current ratio of 442 deaths per 100,000 live births counts for about 70% of the global maternal deaths. During the same period, child survival improved globally. However, in the African region, remained highest under 5, estimated at 67 deaths per 1,000 live births, counting for 55% of the global deaths of children under 5 years old. The global average of life expectancy at birth is 71 years, while Africa stands at 64. The epidemiological transition evolves alongside a demographic transition with a youthful population that represents, in one hand, an important economic potential, and on the other, an enormous pressure on education institutions, health services, and employment market. Dear participants, I am persuaded that two major constraints explain the poor health indicators in Africa. First, the weak health system's capacity and the resulting low performance both in terms of quality and access to healthcare. For example, the current universal health coverage in the African region is 44%, compared with 80% in the Americas and in the European regions. Secondly, the uneven distribution of other key determinants of health, such as housing, employment, education, access to food, clean water, and sanitation, which fuels multidimensional poverty in sub-Saharan Africa, where extreme poverty affects 46% of the population. The economic performance in most of African countries, classified as low-income countries, together with the demographic and epidemiological transitions, reveal insights that could help towards more comprehensive health system reforms. Health systems reforms should be, in my opinion, evidence-based, founded on clear policy analysis drawing from other disciplines such as political sciences, economics, sociology, and management, and should be carried out with a broad framework that includes the determinants of people's living conditions. I think that medical doctors should be involved as actors of health system reforms with other relevant professionals prepared to deal with an increasingly complex public health agenda driven by interconnected and changing determinants. Dear colleagues, dear participants, we are still witnessing a trend towards a highly hospital-centric approach in healthcare services and the commercialization of healthcare, while primary healthcare and health equity remain significant and intractable challenges in sub-Saharan Africa. That's why I think that we should consider alternative lens and see the reality in a broader perspective. I mean, to recognize that in practice, in addition to microorganisms, the immune system, and genetic factors, there are other determinants that also influence the individual and collective susceptibility to illness and diseases. Therefore, African countries need to revisit their public health policies to further promote the social determinants of health. This will pave the way towards universal health coverage to improve people's health status, a primary condition for more productive life and contribution to Africa's resilience and development. Dear colleagues, concerning the human resources, the continent faces a very difficult situation. It faces a deficit of over 6 million health workers and continued brain drain of highly trained professionals. The human resources crisis in the health sector goes beyond quantitative deficits and includes issues of quality, employment opportunities, professional distribution, and retention. And this is a matter of concern in national health systems. These problems weaken the capacity and constrain the performance of national health services and systems. This will be matter of discussion during the current conference, and I think that we need to reimagine how we teach, how we assess, and how we motivate the coming generation of health professionals in Africa. Governments and policymakers should make use of available evidence on health professionals, take into account the state of art in medicine and related technologies, assess the needs and expectations of health services and medical education institutions, allocate adequate budgets for staff costs, and make a case for more suitable investments on infrastructures for medical education, postgraduate studies, and continuing professional development. Despite the ethical and regulatory challenges, I should also mention the importance of training on innovative digital solutions that are already transforming our daily practices in clinical care, in public health, and health system management. I advocate for an eclectic approach to medical education that promotes transdisciplinary pedagogy, transcending traditional academic boundaries within a competency-based training strategy that fosters interdisciplinary research and optimizes the equitable and safe use of new technologies. Distinguished participants, dear colleagues, I congratulate AMSA Local Organizing Committee for designing a very relevant and rich program for this conference that should be not a usual academic gathering, but a call for action. We have among the participants visionary minds, leading deans, healthcare specialists, educational researchers, and representatives of students and residents who are the main raison d'etre of this event. I invite you to look at the available evidence, celebrate what is working well, challenge the wrong assumptions, share innovations, and reform what must change. I wish you all very live and productive debates and the best deliberations. I thank you for your attention.
Thank you all. Another round of applause for Professor Lusambo. So once again, before we move to the next item on our agenda, we would like to welcome the University of Ibadan Choir to give us some music. A round of applause for them. Okay, so for a change, you may have to turn the other way to look at them. Round of applause for them. I'm sure we have enjoyed some very good music. I saw everybody moving and enjoying themselves. Grab volume. Hello. Okay. So, ladies and gentlemen, it's been a day, and we want to talk to the question, but I'll allow the chairman to properly guide us as to our movement from here. So, a round of applause for Professor Rapa.
Thank you very much. I think the round of applause goes to our choir and to all those who really enjoyed it. Yes. So we move to the reception, welcome reception. I must express our appreciation to Marriott hotels. They were so happy with our behavior and audience. They've given us the ball free. And I can tell you that that is of a significant cost. So we have half of the ballroom for our reception, and they're going to ensure we have a good meal. I've been informed that the representative of the Honorable Minister is in flight. We've sent the necessary reception party to the airport, but that will not hold us. I'll ask us to just go and see we're going out and right to the, on the right of us is, you see the doors open, we can start the reception. It's informal. There'll be canapes and some grilled fish. We've asked them to serve it in 2 lots just to make sure that you have time to rest for some to digest before they bring the second lot out. I seriously have a plea. Marriott is not cheap. Please eat it all. Well, Genevieve, I really would wish to lock you in just, just to make sure you eat all the food. But never mind. Ensure that you enjoy yourself. We will be entertained with light music by the saxophone by one of the students of the University of Lagos. They will always compete with us just to make sure that there is no reason for us to fight at the end of the day. There will be no evaluation forms as regards who was better, but I'm sure you'd enjoy the music welcome reception. On behalf of the president of AMSA and the EXCO, I thank you for attending today's session. Tomorrow, we hope we'll be able to go straight to the point and run through. I can't promise that there won't be a little hitch because now that the Honorable Minister's representative is going to be here, the necessary photographs have to be taken. So we'll have a short ceremony just to make sure that it doesn't look as if subnationals have subjugated the national, because he's federal minister. We had the governor, so Lagos State is different from Nigeria. So tomorrow we'll have to do something just to make sure we keep the Honorable Minister happy, and thus the President of the Federal Republic of Nigeria, who has kindly accepted to be the grand patron of this event. So if only for the installation of the President as grand patron tomorrow, we'll just gather for a short period so his speech can be read and we can fulfill all righteousness. Thank you very much, and please enjoy the drinks and the food. Thank you. Sorry.
Recording stopped.